So welcome. Shilpa ji. Hello. Good morning. Good morning to all of you. Good morning to our chief guest, Professor Alok Thakar. Sir has arrived, as you see. I welcome all of you and those who are online. There are about 300 plus online people getting connected now. And we have only 110 seats here. And some of you, I'm very sorry if they are standing outside. They can come in and they're not getting any chair. Please excuse me. And on behalf of the Indian Association of Enteral and Parenteral Nutrition Delhi chapter, we decided to conduct this program this time during the Dysphagia Week. As all of you know, this is Dysphagia Week we are celebrating or commemorating, as I say. And so we wanted to conduct a more of an interactive session rather than talks to find out some solutions and to produce a monograph. The aim of this one is to make a monograph so that we can, or a guideline which you can distribute to all who are connected with us for ready reference. And then we would like to publish that one depending upon what we are getting out of it. There are many organizations focused on dysphagia in India. Madam Sreemathy is one of them. And sorry, I don't know the names of the people who are, we'll get to know over a period of time. And I think all of us, all of the people, or at least most of them who are engaged in dysphagia nutrition activities are here. And I'm happy that many students are also connected to this. And what I request all of you is to ask as many questions as possible. Prepare yourselves during the talk. We have 2, 3 talks, 4 talks, which are very informative. And during those, you will only generate questions and write down on a paper and supply us so that we can discuss them in the last session, which would be interactive session. And the main person who is responsible for organizing this chapter is Madam Shilpa, the secretary of IAPEN Delhi chapter. We got this room only 10 days back, and because of the COVID and when all these things are happening, and virtual has given way to physical one, so it's very difficult to get a room. And we got it 10 days back, and within 10 days, he has managed to completely fill up the slots. So I think you enjoy your time till the evening. And one of our guests, chief speakers, is little bit held up. He will, Dr. Shiv Shankar, he will reach here by maybe 10:30. So by that time, we'll start this one. I request Shilpaji to start and conduct the program.
Thank you so much, sir. So much encouraging words for me. And it's really a pleasure to hear from Dr. Dash. A very warm welcome to all. In such a wonderful to have all of you there in such a chilly weather of 17 December is the event. And as sir told that this event we have kept in such a hurry, but yes, we could make it out. So I am Shilpa Thakur. I am Secretary IAPEN Delhi chapter. And I welcome you all the delegates, all our speakers, all our faculties who have been here and who could make it out in such a short time. I'm thankful to all. So the best part for this theme was being chosen by Sir, and I just drived away because it was something very close to heart, and I couldn't find anything which has been done in Delhi for this theme, dysphagia. So one more thing was that when I put this flyer in groups and shared with the dietitian fraternity and the doctor fraternity, Sir told me that we have just 100 seats or 100 maximum 120. So we have faculty also over 15. So I thought like we should close it by 100, 110. So cannot have more than that. And you won't believe within 48 hours, these 100 seats were been filled. I am still getting messages that now we have reached AIIMS, please accommodate us. Like this is the thing, the way it has been going on. So I've been really privileged that we could do this event, and we will be definitely be doing another event. I will be after Sir. So maybe in 2 months of April, we'll have a second part of this dysphagia, but we'll definitely do another one. I think we require more time to conduct this type of theme. And so one more important way of keeping this was that it is like commemorating the dysphagia week also. So 12 to 18 December has been celebrated for dysphagia week, and we could make it on 17 December. So this was really great. So I am really warm welcome to Ms. Sreemathy and Mr. Shiv Shankar for helping us out in making this event been successful. And I also welcome our other faculties, Dr. Nancy Sani from PGI Chandigarh. We have Mr. Kaustav, fellow therapist from Amrita Hospital. We have Mr. Anil Kumar. He's also fellow therapist. He's from Max Saket. And we have Dr. Neetu Singhal. She's onco radiation specialist from Sarvodaya Hospital, Faridabad. And we are going to have Dr. Varun Surya. He's from the dental department, AIIMS. And we are going to have Dr. Sumant Polu, and he's from Max Vishali, and he specializes into ENT surgery. So we are going to have all the faculties over there. I request all delegates to have put up like their important questions. Either you can put up in the WhatsApp group also, or you can share it across to us so that we can take up them in the panel discussions and lastly in the group discussion. So we'll start on with the inaugural session first, and I would request Dr. Bhavna Gandhi to start with the inaugural session and invite all the dignitaries on the dais. Thank you, sir. A very good morning to one and all. Thank you, Shilpa. It's a pleasure to have all of you here for the inaugural ceremony of the workshop. I, Dr. Bhavna Gandhi, on behalf of IAPEN Delhi chapter, will like to invite Professor Dr. Dash sir. He is President IAPEN India Delhi chapter. So please join us on the Ms. Shilpa Thakur, Secretary IAPEN India Delhi chapter. Shilpa, please. Our national faculty member, Ms. Sreemathy. She is NC IAPEN India chapter. Ma'am, please. Ms. Anita Jatana, ma'am. She is convener IGA Delhi chapter. Dr. Nancy, please. Our chief guest, Professor Dr. Alok Thakar, sir. Sir is MS FR CSCG, Professor of Otolaryngology, and head and neck surgery, AIIMS. Sir is MBBS, MS, GNB, DLO, lot many educational qualification. We can very well make it out from his personality. He has been honored so many awards, all the international and national. So many, sir, it's too difficult to read them here. Sorry for that. And he has got so many prizes, and he is president and treasurer and secretary for so many organizations. To name some is he is president for Neuro-Otological and Equilibrium Biometric Society of India, treasurer for Skull-Based Surgery Society. Sir has special interest in neuro-otology and skull-based surgery, vertigo, hand and neck oncology. I welcome all of you
for the inaugural ceremony. Thank you all. A gracious welcome to all of you. To make this day a blessed one, let us invoke Goddess Saraswati by kindling the lamp of knowledge and wisdom. I request all the dignitaries to please proceed for lamp lighting so that we can start up our CME come workshop. It's here, sir. It's on this side. Please.
Till we get this lamp lighting done, let me introduce Professor Alok Thakar from my side. We have been working since last 15 to 20 years in treating patients with dysphagia. I deal with people with cancers of the esophagus, acid-induced dysphagia patients. He treats head and neck cancer patients who are dysphagia patients, and I think we have treated hundreds of them over this period. And we have particularly found out that it's a difficult thing to manage nutrition in this patient. It's a practical problem. So that's why I wanted that this discussion should be here, there, and we have one of our famous swallow therapist who was here in AIIMS. Now he has moved to Faridabad. So only one line, Mr. Kaustav, please most welcome. एक लाइन खाली मैं डॉक्टर आलोक के बारे में बोलूँगा कि इंटरनेशनल और नेशनल लेवल में जो लोग उनको स्पीकर के हिसाब से देखने के लिए तरसते हैं, हम बहुत आसानी से आज वो हमारे साथ हैं. So it's a great thing for us. And thank you, sir, for coming here. Madam.
So it's really a pleasure, sir, to have you over here. And we are just waiting to hear you. So, sir, we welcome you over here and we are waiting for your motivational thoughts so that even the students, there are many students over here who have been registered for this thing. So I think they can work onto this theme, they can be part of this theme, they can learn more things. And that is the only main aim for this holding the CME come workshop, sir. So we welcome you, sir. Over to you, sir.
Yeah, I forgot to tell that in spite of his busy schedule, he has exams today. He has some CMEs today. He wanted only few minutes, so it will take only will take few minutes of him only.
So the build-up to my talk seems to be very intimidating. So let me also say that when I got the invite to inaugurate the session, I was a bit surprised because I have never done this before, and a bit intimidated again. But yes, also it was short notice, so a little bit tight on time. Nevertheless, as I sort of rushed through my morning clinical duties and came here and realized that I was getting late and getting a bit embarrassed, I realized that this was probably expected of someone who's coming to inaugurate. So being a little bit late was okay. So anyway, certainly I'm, let us say, very pleasantly surprised. Not surprised is the wrong word, but very. It's nice to see how many of you are here. Because though, of course, we realize that nutrition is so important, and of course, we realize the basic function and essential function and important with, of course, healing and, of course, important with immunology and everything that happens in a patient with which Dr. Dash and I treat with regard to oncology or reconstruction. Nevertheless, an aspect which is often not sort of dealt with professionally, and something that is done by people on the side, that this is something that everybody believes they know. Of course, they don't. We are fortunate that we have you with us, so we can do this professionally. And of course, dysphagia is another such a complex situation. I would say it's the most complex situation among the most complex situations of the human body, because the small confluence of organs wherein we can breathe, we can speak, we can emote, we can swallow safely, and yet do it all through life without generally having too many issues with it is amazing in itself. When we do have problems, of course, it can be life threatening, and we are all very well aware of that. I think if anything has happened over the last 15 or 20 years compared to when we all started out, and if I look at the gains that we have made in terms of understanding swallowing function, it's primarily being as we broke it up into smaller and smaller parts. So from initially we talked about pharyngeal and esophageal, then we sort of broke up pharyngeal into oral, pharyngeal, laryngeal, hypopharyngeal, and then we have broken it up further. Is it an issue of the tongue pushing back? Is it an issue of oral competency? Is it an issue of the cricopharynx not relaxing? Is it an issue of the larynx not elevating? And as we have broken it out down further and further, and we understand it more and more, we have so many effective solutions which we didn't have. So primarily, it's just a greater understanding of the physiology. We worked on anatomy. We are surgeons. We worked on anatomy, anatomy, anatomy. But when we started working on physiology and we started understanding each and every bit, and of course, all of you helped. All of you helped. Kaustav here helped remarkably when he was with us for a short while. But just being able to break it up into different bits, having different therapeutic options in terms of medical treatments, swallow treatments, rehabilitative treatments, compensatory treatments for each and every of those acts, and then of course surgical treatments for each and every one of those acts. If the larynx is not moving up, maybe we can pull it up. If the cricopharyngeus is paralyzed, maybe we can tack it. If the cricopharyngeus is constricted, maybe we can release it. And it is really this understanding which I think is making a difference. And if Dr. Dash and I have made a difference to some of our patients, it is because of this. And the kind of work that has been led by him has led to a situation wherein patients who we could never even look at rehabilitating with their pharyngeal stenosis are now being rehabilitated so routinely in our setup. Yet Dr. Dash tells me that when he goes and presents that work elsewhere, people don't believe him. So, but the world is changing. It's only a question of time before that also happens and gets transmitted to other situations. So great to have you here. And of course, I wish you all a great learning day as the day goes on. I wish I could be part of you, but neither do I have the time. And as I said, maybe it's not expected of me either. So anyway, thank you.
Thank you very much, Dr. Thakar sir, for delivering your honorable motivational words for all of us. We would have liked to have you here, but paucity of time is a big thing. So now I request Dr. Dash sir to present memento as a vote of thanks and appreciation to Dr. Alok sir. Sir, please.
Camera.
ये this is so much.
Camera.
Thank you, sir.
Can we let him go?
Yeah, sir, please.
Thank you very much.
Thank you.
Minutes. I'll be little bit highlighting what he said actually. Now, how it has made a difference. Before 2012, any patient coming with acid injury of the larynx or pharynx with dysphagia or high cancers with dysphagia were destined to die because of reflux. And even if they were operated by us or our predecessors, they would always aspirate while swallowing and then develop chest infections. And ultimately, within 6 months or so, they used to die. Then in 2012, I had to run over many places, including Italy, Brazil, India, and conferences and discuss what was the problem. And then I found from Western countries, the main management, it's not the surgery, was not the surgery, was the swallow therapist and the nutritionist. That's where I learned that yes, this is essential. Then I uh, got him on board. We discussed, we made a team, we planned before surgery, nutritionist and swallow therapist. Surgery over, swallow therapist, and slowly taken over by the nutritionist for 6 months. Some of these people they used to take time for maybe 6 months to 1 year to really take food. So we have a swallow therapist, we have Anjali ji as dietitian, nutritionist who takes care of their swallowing, their how and to maintain their nutrition through the feeding jejunostomy, through the tubes as well as partially swallowing patients. That is where the most important thing is a little bit they can swallow and how to make them. And we have other areas of dysphagia like the neurological patients and etc. What Madam knows and they have been doing. So with this, please go ahead with your sessions one by one, and I request you to outline what is in store for us today and go about it.
Thank you, sir. So with this, we close our inaugural session and we'll be proceeding with our scientific sessions. And hope I have shared the agenda also with all the delegates. So we will proceed with the scientific session one, in which we are going to have talk from our fellow therapist as well as from the dietitian point of view, as the management and the way ahead from Ms. Sreemathy and Mr. Shiv Shankar. And post that, we'll be having panel discussion. And for all the talks also, we will be taking the questions into the panel only. So after that, we'll break up for the lunch and then we'll start with the scientific session part 2, which will also have 2 talks. One is like an interdisciplinary approach and that about the texture diets and the framework which we have been following for the dysphagia patient. So Ms. Sreemathy is going to talk about that. And then we have Dr. Varun Surya. He's from the dental side, so he's going to talk about the hygiene part, the mouth hygiene part for the dysphagia patients. And post that, we'll be again having a panel discussion. Along with that, we have new panelists been going to join in for that session. And in the end, whatever the questions we are having, we will try to make out a kind of a consensus from our delegates and the senior people, faculties who have been present. So last session would be moderated by Ms. Sreemathy and Mr. Shiv Shankar. So we will be taking home some messages also. We'll be recording and we'll be coming out with some guidelines, maybe a consensus in which the follow-up for Indian types of patient might be easier for all the nutritionists, and it might show a way ahead how we need to move further into this. Thank you so much for all the dignitaries. We can start with the scientific session. Thank you so much. So we were talking about so many things about the Dr. Thakar also shared and Dr. Dash also shared about dysphagic patients, that how they are being treating and how they have come from anatomy to the physiology part. So if I say that nutrition is not only about when we have been teaching as a nutritionist, been counseling our patients, so it is not only about eating, it is basically to make them live healthy. So that is the major core theme for where we are treating any type of diseased patients. So one phrase comes into my mind while I say this thing. Sometimes when patients fall ill, so they are always like sometimes being burdened up by the disease. They are not thinking their life to be moving healthy in a healthy way. So they are depressed also. They are stressed also. So I would say whenever we are being like fighting with such kind of a disease, whether it is a cancer or whether it is any type of diabetes or anything, where we cannot accept as ourselves as a patient, we need to actually live our life with that. So we need to be like pani puris. I hope we are all majority of here are the females. So pani puri is something which has been loved. So when life breaks you up, you need to fill them with something healthy things, some important healthy things which actually makes you live life. That is what pani puri does. So when you break it up, fill up with lots of potatoes and chickpeas, so it makes out your mouthful with some kind of thing which actually gives you a happiness. So we need to be like that only. So with this, we'll start with our scientific session one. I would like to invite our chairpersons. Our first chairperson for the session is Mrs. Anita Jatana, Madam as Consultant Dietetics Apollo Hospital, and she is convener for IDA Delhi chapter, having more than 35 years of experience in the field of nutrition. It's a pleasure to have you with us, ma'am. I would also like to invite our second chairperson, Dr. Neetu Singhal. So, ma'am is Associate Director, Radiation Oncology, Sarvodaya Hospital, Faridabad, and she has been working with BB Cancer Hospital till 2005 in Hyderabad. After that, she was with Nizam Institute of Medical Sciences, Hyderabad, and Dharamshila Cancer Hospital and Research Center, and then with Asian. So currently, she is with at Sarvodaya. She's been trained in IMRT at Dijon, France, and Zug, Switzerland, IGRT, and Rapid Accurate Respiratory Gating at Amsterdam. And she has participated and organized various conferences, taking active part in the research activities and the cancer registry programs. So I would request chairpersons to introduce the speakers for the session one. Yes, yes, please.
Morning, everybody, and a warm welcome. On a cold day, a warm welcome to everybody. Thank you for the IPN Delhi chapter, Dr. Dash and Shilpa, together in 10 days putting up this excellent program. I think it's really the need of the hour. We've been doing it, but not on a very focused way. And dysphagia, as you know, has been increasing, and it is quite, I think the prevalence is about 13% and increases to about 50% in a nursing home and is more in the geriatric population where it's about 30%. So it's quite a huge number. Causes, I think it's worsening because of dementia, because of, I think, people who are living longer now. Otherwise, we knew by 60, we'd say goodbye. But now we have people who are there till 90, 100. So great things. But it comes with its problems. And dementia is one of the major ones. We have head injury, we have stroke, we have cancer, all in the increase because of our wrong eating habits. So we've gone from healthy eating to wrong eating, which is really the cause. But together, as a team, you heard Dr. Alok and you heard Dr. Dash really introduce the subject very clearly. Together as a team, maybe you can't take away the problem, but you can definitely help them for good, healthy living as we go along. So over to the speaker. First speaker is
Mr. Kaustav.
Mr. Kaustav. Welcome. He has a huge experience. Consultant and please pronounce this word. Amrita Hospital from Faridabad. He's been working there from November 2020 to September 22. He's a swallowing pathologist from AIIMS New Delhi. His education is MSc and swallowing disorders at Amrita Institute of Medical Sciences from Kerala. ASLP from 2013 to 2017, where he was in Noida, UP. Very self-motivated, highly capable and expert professional with comprehensive experience in dysphagia. So we have a great person here going to educate us. Determined, energetic, and disciplined. I can see that, I think, by his nature. Persistence nature means that I'm a fast learner. He's very passionate about his subject. I have a diversified experience of dealing with almost all areas of dysphagia. So over to you, Mr. Kaustav.
Thank you, ma'am. Hello. Good morning, everyone. Thank you, ma'am. Thank you, Shilpa ma'am, and Professor Dr. Niharanjan Das sir for giving me the opportunity today. My name is Kaustav. I am currently working as a consultant and chief deglutologist in Amrita Hospitals, Faridabad. Straight to the presentation. The topic that I have been assigned is dysphagia, its causes, and the assessment. So let's get through some few terms. What is swallowing? Actually, swallowing is cause or allows something, especially food or drink, to pass down the throat. Basically, the definition of the swallowing is that. And deglutition, the act of process of swallowing is called deglutition. And what is deglutology? It is a branch of science which specializes in the physiologic aspects of deglutition. So, what is dysphagia? The global definition of dysphagia is simply difficulty in swallowing. Dysphagia, uh, like there are a lot of definitions that have been given, but the global definition is dysphagia, difficulty in swallowing. There are many causes which can be divided into oncological, neurological, and some other causes. In oncology, head and neck cancer is the most prominent cause of dysphagia. Neurology, you can divide it into stroke, cerebrovascular accidents, and neurosurgeries, and also neurodegenerative disorders, which are like MND, motor neuron disease, Parkinson's, amyotrophic lateral sclerosis, etc. Some of the systemic disorders are also there, and neoplasms, as I've already said, head and neck cancer. Also, some of the treatment modalities can cause head and neck cancer, like surgeries, then radiotherapy, chemotherapy can cause dysphagia. What are the signs and symptoms? Signs and symptoms include odinophagia, which is also called as pain in swallowing, throat clearing while swallowing, cough while swallowing, drooling, hoarseness, prolonged meal time, and weight loss or regurgitation, which is also which can be simplified as food or stomach acid backing up to the throat. What are the impacts of dysphagia in a person's life or in a patient's life? So the patient will have dehydration, malnutrition, aspiration pneumonia. He will develop aspiration pneumonia, compromise overall general health, weight loss, depression, and in worst cases, death. Coming up to the assessment part, we can divide this into clinical assessment and instrumental assessments. Clinical assessment is also known as the clinical swallow evaluation, that is CSE, or the BSE, that is the bedside swallow evaluation. To the instrumental part, we have mainly two assessments: so flexible endoscopic evaluation of swallowing and video fluoroscopic swallow study. So, what is clinical swallow evaluation? Also, bedside swallow evaluation. Uh, Sometimes it is also known as bedside swallow evaluation. It provides a roadmap to the diagnosis and treatment of swallowing disorders. According to ASHA, that is American Speech and Hearing Association, the purpose of clinical evaluation is to observe the signs and symptoms of dysphagia. A thorough CAC or BAC, that is clinical evaluation, should include all the demographic details of the patient, current diagnosis, record of treatment that has been provided to the patient, if any, or whatever the undergoing treatment is currently going. Medical history, brief medical history, also cognitive assessment, physical examination, oral, pharyngeal, and laryngeal examination, trial swallows, and at last, advice. So this is a performer that I have been using in almost all the patients. It contains the demographic details, as you can see, the diagnosis, medical history part, present complaints, why the patient is has come to you. There can be a lot of complaints, like patient might say, I have a cough while swallowing. There's a pain in my throat while swallowing. I feel something is there in my throat, that is also known as globus pharyngeus. And sometimes the patient also like complain ki there is food coming out of my nose or my mouth. So this is general examination. As you can see, we should record all these parts of the general examination. If the patient is oriented, stable, conscious or not, is he able to follow commands, which also we can notify as a cognitive assessment. If he is on oxygen support or he is on room air, is he able to sit with or without support? Then odynophagia, that is pain while swallowing, tracheostomy. If a tracheostomy tube is present, we have to mention what is the tracheostomy tube. It is curved, uncurved, or any other tube that is in the patient. Then frequency of suctioning required. Chest auscultational, also SpO2. Then we come to the oral peripheral mechanism examination, that is lips. So we all these lips, tongue, palate, we have to assess its function, its symmetry, its mood movements, and also the sensation part. Gag. Halitosis is bad mouth breath. So if a patient is having poor oral hygiene, then there will be halitosis in the patient. Trismus is basically uh, inability to open the jaw. Like the ideal should be three finger gap. Then laryngeal elevation. While we swallow, the larynx elevates. So it should go up till the level of the hyoid. So it has to be examined. Laryngeal crepitus, then neck movements. How is the cough efficiency? And I'd like to mention this cough efficiency is basically voluntary cough. We'll like to tell the patient to please cough voluntarily. So we can assess how the cough efficiency is. Then speech, then how his voice is, normal, gurgly, is there any tremor? Then we come to the oral trial. Oral trial, the protocol says that we have to start from the minimal quantity, that is 3 ml, 3 cc, then proceed to 5 cc, 10 cc, 20 cc, and at last sequential swallow. So what all we observe while we give the oral trial, we can observe anterior spillage, that is if there is any spillage of whatever we have provided through the mouth. How is the swallow initiation? Is it immediate or delayed? If there is any oral residue, again, we have to assess the laryngeal elevation while the patient is swallowing, then cervical auscultation. And we can, after that, we will look for the signs and symptoms of aspiration or penetration. That is, if there is throat clearing, if there is any post-swallow cough or any voice change. I'd like to mention gurgly voice or wet voice, we say. Then we can assume that the patient might or might not have any signs of aspiration or penetration. So we can write at last the impression we can write as clinically normal act of swallow. One second, can you go back? Yeah. So we can also there are two trials that we can give. One is the water swallow trial, that is called WST, and the other one is bolus swallow trial, BST. So we give the patient any other kind of consistency other than the liquid consistency. It can be a solid or it can be a blend consistency. According to the this evaluation, we can say if the patient is clinically fit or not fit for oral feeds. And further, we can plan if required any kind other investigations. Coming to the instrumental assessments, what are the objectives of instrumental assessments? Visualize the swallowing respiratory related structures, oral cavity to the esophagus. Assess the physiologic functions, sensation, coordination, effectiveness of swallowing, to determine the presence, cause and patterns of aspiration. Visualize the management of secretions in hypopharyngeal and laryngeal areas. Also, screening the anatomy and physiology of the esophageal area to determine if there is any cause and presence of esophageal dysphagia. Determine whether oral or non-oral feeding is suitable for the patient. Determine safety and efficiency of different swallowing management options such as postural changes, compensatory strategies, maneuvers, certain maneuvers, and change in consistency of food, etc. So first we have is flexible endoscopic evaluation of swallowing. It was first described by Dr. Susan Langmore and colleague in 1988. It uses the transnasal flexible laryngoscope to evaluate the swallowing before and after the pharyngeal swallow. Can be conducted at bedside, clinical, or in any OPDs. It requires passing a flexible laryngoscope into the nares over the velum to a position above the epiglottis, where we can visualize all the laryngeal structures. Before starting the swallow trials, anatomy, physiology of larynx and pharynx should be observed carefully and noted. Once these examinations have been completed, the food trials may be given. So this is a performer which I have been using in all the patients. Again, all the demographic details, diagnosis, medical history. Then we can mention from which nasal cavity the flexible scope has been passed. Then, as I said, we have to observe the physiology and anatomy of the laryngeal structures. So we can record how the vocal cords mobilities are of both the cords, right or left. Then if there is any pooling of secretions, the Bastian sign, that is basically the medialization of your lateral pharyngeal walls, while we say forcefully E. Then it is very important to mention the record the NGT positioning, whether it is going to the midline or any of the PFS. Then if there is any phonatory gap, then how is the laryngeal sensitivity? Should be, it is must to record the laryngeal sensitivity, if it is good or bad. Then how is the cough efficiency? And then if there is any edema in the larynx, which after radiation and chemotherapy, there is a lot of edema sometimes. Then we can give the patient with oral trial, proceed with the oral trial. So again, we have to start from the minimum quantity, that is 3 cc, 5 cc, 10 cc, 20 cc, then to the sequential swallow. We can give liquid. We can give any consistency that we feel the patient. We need to assess the patient. We can give liquid trials. We can give bolus trials. We can give blend trial. We can give solid trial also. While giving the liquid trial, we should assess premature spillage, that is spilling of the bolus before the patient initiates the swallow. Basically, this would give you an information that the base of tongue must be affected. The mobility of the base of tongue is not very good. Then whiteout phase. Whiteout phase is basically when you swallow, the larynx moves up and it touches the endoscope. So during that time, you cannot see anything. That is basically whiteout phase. Swallow initiation, how it is, delayed or immediate. Then post swallow, what all can we observe? In liquid trial, we can observe pooling. Basically, the liquid will pool in either of the valvula or either of the PFS or in the posterior pharyngeal wall side. So this would give us give us information that the pharyngeal muscles might be weak. Then if there is any residue in case of bolus, if we give bolus. So this is a pictorial representation. See, I've spoke about this pooling. So you can see here pooling in the valvula. And this was a bolus that was being given to the patient. It is in the valvulae. Then in the right picture, you can see aspiration. So post swallow, pooling, valvular, PFS, multiple swallow, also we observe residue, and also the not to mention penetrations and aspirations. If the patient, what is actually penetration and what is aspiration? So penetration is basically when the food is up to the level of the vocal cords. It is not passing down the vocal cords. And aspiration is when the food or the bolus passes below the vocal cords. And if any maneuvers or compensatory strategies that have been used, it can be anything. It can be postural changes. It can be a maneuver, anything. So we have to record that also. At last, we record. We score the patient, which is DSRS, that is your dysphagia severity rating scale. BRS is bolus residue scale. So we mention some points where the bolus residue is. It is in the pharyngeal, piriform sinuses, posterior pharyngeal wall, or the valvula. Then the last one is PAS, that is penetration aspiration scale. Then we go ahead with the plan. If we feel we don't need any further evaluation, we'll tell the patient if he can start on oral feeds or not, or if we need another evaluation, or if the patient should be kept NPO, we can write. Going to the next one, that is video fluoroscopic swallow study, or also known as modified barium swallow. So there is always a discrepancy between fees and VFS, which is the golden standard. But till now, the golden standard is the video fluoroscopic swallow study, because we can assess all the three phases of swallowing in this examination. So as I said, concentrates on oral, pharyngeal, and esophageal phases of swallowing. This dynamic study evaluates formation of bolus in mouth, tongue motion, coordination, timing, completeness of swallowing, epiglottic movement, laryngeal elevation, penetration aspiration, cricopharyngeal contraction, peristaltic movement, retrograde flow. That is also known as the regurgitation, stasis of bolus in the esophagus or any stricture, etc. This is an excellent test for evaluating oral, pharyngeal, and esophageal phases. This is the performa, or we can say the record performa. Demographic details again, then diagnosis, medical history. So we have to mention what contrast we have used, barium sulfate solution or gastrographin. Then again, quantity. In case of pediatric patients, we can start with 1 ml. In adult patients, we start with 3 ml, 5 ml, 10 ml, and till sequential swallow. The consistencies that we can try are thin liquids, thick liquids, and also blend or solid. All these consistencies should be tried in a video fluoroscopic swallow study. The recording should be done in a lateral plane or anterior posterior plane, that is AP, or oblique. So what all we observe in a video fluoroscopic swallow study? We can observe all the three phases, starting from the lip closure till the LES opening. So we can record lip closure if there is any anterior spillage, how the lip closure is. Lingual control of bolus while he swallows the bolus, how is the lingual control? If it is coordinated, incoordinated. Then in cases of solid mastication, how is the mastication? Is the patient able to masticate the bolus properly? And then propel the bolus, like the anterior part of the tongue will touch the palate and then propel the bolus to the pharyngeal part to initiate the pharyngeal swallow. Then how is the swallow initiation? Again, immediate or delayed. Then if there is any oral residue. Then we'll come to the pharyngeal stage. So in pharyngeal stage, we'll start from the soft palate elevation while we swallow, and while bolus reaches the pharyngeal part, the soft palate touches the nasopharynx, so completely closing the nasal cavity. We can mention it as a velopharyngeal competency, how it is. Then nasal regurgitation, if any. How is the laryngeal elevation? Also, I would like to mention anterior hyoid excursion. So the larynx not only elevates, it also moves anteriorly to close the laryngeal inlet, and for a safety swallow, it is it is necessary. Then epiglottic movement, again, airway protection. For airway protection, the epiglottis closes the larynx completely. So we have to mention how the epiglottic movement is. Then penetration aspiration, coming to the residue in any of the pharyngeal discs, that is piriform sinus or valleculae or posterior pharyngeal wall. Then how is the pharyngeal clearance, if there is any poor clearance or completely clearance of bolus. Cough sensitivity, if the patient is aspirating or penetrating, then how is the cough sensitivity, and other findings like if there is any presence of any osteophytes or pouches, that is diverticulum. Then at last to the esophageal stage, how is the peristaltic movement of the bolus. Then if there is any retrograde flow or regurgitation, how is the LES opening and stasis. Then again, we have to mention if we have tried any other kind of maneuvers or compensatory strategies during the study. We'll again mention here about the DSRS, that is dysphagia severity rating scale, bolus residue scale, and penetration aspiration scale. And again, last, we'll go further with the plan. Thank you.
Thank you, Mr. Kaustav. Really well explained. I think the way we do our nutritional assessments, you really explain to everybody how you do your assessment. And I think when they see the patient in the file, they'll be able to now understand at
Exactly.
which stage they are and then evaluate what feeds they have to sort of organize. I think I'm quite audible. Am I? Maybe we don't need it. Do we have question answers or?
My message to them is what I have not. Please try to avoid putting these people till unless all the assessments are done.
That's what.
not possible to get the assessment everywhere. All these things, they are very, very sophisticated things. 50% of them can be done by the swallow therapists are a very rare entity. वो बहुत कम मिलते हैं. So as two swallow therapists cater to some hundreds of patients, it's not possible. So as a nutritionist or dietitian, you must know part and parcel of this. At least use the clinical aspects to know where is the problem. For example, if I have a surgery of the left side of the pipe of fossa, which is a part of the pharynx, then you must tell the patient to bend it to the right side so that the food goes to the right side. So simple maneuvers which he said are very helpful in starting the feeding in this case.
Even the assessment forms are very well done.
Yes,
Beautifully done.
yes.
I mean, I don't know, I
At
wish they
least,
could have it in all the files for everybody to understand how to take it forward.
yes. At least we should know how to read this.
Yeah. Understand those reports.
Yes.
Very important. So I was really appreciating your assessment forms. It's very well done.
So now we move on to our next speaker, Ms. Sreemathy Venkatraman. Ms. Sreemathy is the Chief Dietitian, Trustwell Hospital, Bengaluru. She is a clinical dietitian and wellness nutritionist at Trustwell Hospital, Bengaluru. NEC member, IAPEN India, Chief Program Officer, Dysphagia India, Consultant Nutritionist, Divine Mother and Child Health Program, Consultant Dietitian, very elaborated. My God, you're wonderful. Consultant Dietitian, Zebra India, Gut Health Dietitian, Dr. Digest Clinic. She has a wonderful experience of 23 years in clinical dietitian, master level specialization, diet in health and diseases, Cal State, Northridge, and Seattle Pacific University. PG DND Nutrition and Hospital Dietitian, Certificate Course in Community Nutrition and Sustainability Development, Certified Diabetes Educator, Certified Bariatric Nutritionist, Certified ESPEN LLL in Critical Care Nutrition and GI Nutrition, and she has many publications to her credit, textbooks in nutrition and biochemistry for nurses and Read Elsewhere, textbook in nutrition by nurses by Read Elsewhere in 2019, and Nutrition booklet. Let's put our hand together for Ms.
Thank you for the nice introduction. Good morning, all. Thank you, IAPN Delhi chapter, Shilpaji, Dr. Dash, for putting this. This is a World Swallowing Week, internationally World Swallowing Week. It's
Camera.
So otherwise you come inside this on the podium itself. That would be good.
can I? You want to see?
here, you can.
You can see there also.
Yeah, because of the online. Yeah. So the World Swallowing Week is from 12th to 17th the world over. Dr. Kaustav, nice to meet you, and I will interact with you. I've always had a long association with dysphagia. I was privileged to work with many neurosurgeons and neurophysicians. I started my career way back in 91 with Public Health Center with neurophysicians. So this had a long association with dysphagia, not then, but when I came back to Bangalore. So I'm going to talk about the dietitian's role in the management of dysphagia, because this is where, what is our role? How do we have, without an interdisciplinary management, which I'm going to do post lunch, we need to know what is our role to play along with the SLPs, the swallowing therapists, the respiratory therapists, and so on. So let me just talk. The learning objectives for this is the prevalence, the science, the evaluation about us, the nutrition risk, dietitian's role, the multidisciplinary work we need to do, meal times, and what are the best practices, and definitely the theory versus practical setting, because when you see in the theory, it is completely different when you practice it. So prevalence of dysphagia, 1 in 17 people, though it is the best data, 1 in 17 people will develop some form of dysphagia in their lifetime. 1 in 25 adults annually are diagnosed. No statistics much is available for the Indian population. It is under-recognized. It is a hidden disability. And also we are not able to give it much now. For the past almost 5 to 7 years, more and more we are doing it in the Indian setting. Intervention is only when the weight loss is evident, so we need to really be proactive about it. And the complex process of swallowing, the SLP has already told about it. Dysphagia is divided into oropharyngeal and esophageal dysphagia. I'm going to talk more about the neuro part, and Dr. Shiv Shankar will speak about the other part regarding cancer patients and head and neck cancer. WHO has defined the difficulty or inability to move a bolus safely and effectively from the oral cavity to the esophagus and can include aspiration, choking, and residue. Can you imagine what we take for granted? It involves 55 muscles, 5 cranial nerves, and 2 cervical nerve roots. So it is a very complex process. When you deal with these patients, you'll be able to know these are the symptoms of dysphagia. There is coughing and choking, onset of breathlessness, unexplained weight loss, gurgly voice, having difficulty chewing. There is a stuck feeling in the throat. It is a hidden disability because we also see it in more of older geriatric patients. There are a lot of patients who are cognitively impaired, like dementia, where they will not know to voice it out that they have a difficulty in swallowing. And also post-COVID, we see a lot of patients with dysphagia. And also in old age nursing homes, more and more people are residing in old age nursing homes, even though because of the children abroad and so many reasons. So there are a lot of students here. I want them to take this as a profession, as a career, specialize as a dysphagia nutritionist, and try to have your own way of protocol. Let us come to a consensus, and we need all your things. So just look at this following video, what we take for granted. So it is a complex process, don't you agree? Yeah. So the thing is, causes of dysphagia, it is there even in children. There are a lot of, when I was speaking to some people in the NGOs and other things, they were saying, please concentrate even in the pediatric population, though today it is only for the adults. In adults, you can see that it's an old age, a neurodegenerative disease is Parkinson's. It's a progressive neurological disorder. So that has multiple sclerosis, ALS, dementia, where there is, it is very difficult for them to voice out. So head and neck cancer and other things, and also in children, and both in children and adults, you can see that even in cerebral palsy and also in stroke, traumatic brain injury, that it is very common, and we need to really rehabilitate them. There is a lot of scope for us as nutritionists. Disease category and prevalence of dysphagia, you can see that 70% of stroke patients will have it, 30% of TBI, and also 75% of neurological diseases and 40% in oncology. And causes of dysphagia, you can see from the neurological point of view, it's stroke, neuromuscular disease, amyotrophic lateral sclerosis, Parkinson's, multiple sclerosis, and myasthenia gravis. So causes of oropharyngeal dysphagia, it can be neurological disorders, there are structural abnormalities, it can also be a muscular disorder, it can also be where there is a disease in different junctions. So what happens is, there is a clinical consequence of dysphagia. So when you see that there are so many causes of dysphagia, where we come into picture as dietitians and clinical dietitians and nutritionists, malnutrition, dehydration, together with the SLP or the swallowing therapist, respiratory therapist, physiotherapist, nurses, of course the ENT doctors or the consultant who's in, whether it's GI or onco, and definitely the dietitians which is there. The whole common agenda for the patient is safe swallow, preventing malnutrition and dehydration is the first aim. So when there is malnutrition and dehydration, you can see that we need to prevent aspirational pneumonia. There is an immunocompromise. There is increased risk of infection because of this. And when there is malnutrition and dehydration, this also causes again an immunocompromise. Definitely there is poor wound healing. When you think about a person who's having a stroke and who's going to be bedridden for some time, depending on where the CVA is, and also there will be grade 1, grade 2, grade 3, so many bed sores. So when they try to grade as a nursing, when they try to grade the bed sore grade 1, you yourself should know we are not an island anymore, just only supplying food or making sure he's taken or soft diet, liquid diet, clear liquid. No, we need to understand how much the patient has eaten. I'm sure people who are doing it for liver and onco, they also see the nutritional adequacy of the patient before the doctor's rounds in the morning. We calculate how much of calorie, protein and other things. So also we need to know the amount of thing, whether we need to introduce a ONS, whether we need to request them to have a nasogastric tube, all these things. So we need to act with confidence. We need to have data in our hands, what happened the last 24 hours, what happened the last 48 hours. So poor wound healing is a big cost. So we need to, without nutrition, the patient will not be able to eat, prevent malnutrition, dehydration, and also the poor wound healing. So localizing the source of dysphagia. So I'm not going to go into too many things. There is like when you say when there is a ingestion of a corrosive substance, there is a stricture. Then it also happens not only in the neurological diseases. There are some cases where there is a cricoid web forms in the dysphagia, and there is achalasia where there is weakening of the esophageal muscles where it can't be. So it is multifactorial and we need to understand. So when Kaustav spoke about the dysphagia rating scale, the score, we need to know what is the score. They will tell us with the fees and the VFS. I request everyone to go and stand, and one time when they do a VFS or fees in your hospital, or if there is any other one, you will really know how it is going. You can even see the swallowing. I've done it sometimes because for me to understand how the bolus is going in, so that we know how it is. We need to do the consistency of the diet. The SLP or the swallowing therapist is the one who's going to tell this is the dysphagia score, this is the dysphagia rating scale based on the instrumental evaluation if it is there, or a bedside swallowing, because as India we have different situations where there are no swallowing therapists at all, where there is an SLP who will only come part-time. There are no dietitians also in many facility, or as dietitians we will be the only one who will know. We have to coordinate with the ENT department. So as we are the ones who, we read physiology, we read biochemistry, we in order to understand the physiology, the anatomy, the biochemistry, what is happening, because food is something very important. So we also need to understand how the swallowing, how the dysphagia score is. We need to understand their report, and they will tell us what is the consistency that can be given, and this is how we tell them what is the consistency of the diet that is to be supplied. Now, signs of aspiration, something sticking in the throat. Kaustav also pointed out the food that comes out between through the nose, through the mouth, and also there is severe cough. When the nurse is trying to feed them, we need to be there also. So that also helps to know how it is, the signs of aspiration. This is the IAPEN protocol that is validated internationally to for us to do the nutritional assessment. What I wanted to tell you is I'm part of the European Society of Swallowing Disorders as a member. I also be there in many meetings when they do the webinars and other things. So last year we did the same time we did, because it was more of online things. We did a dysphagia awareness video. More than 23 dietitians all over India gave a 30-second, less than a minute video in different languages. More than 20 languages was covered. I will show it to you in the post-lunch session. How about the interdisciplinary management regarding why we need to screen for dysphagia in almost 20 languages in India. And this was submitted to the international thing where they said, what are you doing for the dysphagia awareness in 2021? So this 2022, I'm glad to be here. So this is an E10 protocol which is validated internationally on how we have to do this, why my swallowing problem has caused more to lose weight. What does the my swallowing problem interfere with my ability? What we need to understand is, even in a Parkinson's patient where it is a progressive disease, they will be in so many dopas, liver dopa, whatever the dopa they might have to reduce the symptoms of their tremors, their rigidity, and all that. It is a progressive disease. They hate to eat with assistance. You need to understand there is a lot of psychological issues that is there in the play, whether it is onco, whether it is neuro, whatever the cause. It is very difficult for someone who has been independent so much, and by 40s, 50s, 60s, it can be the age, and yes, geriatric, it is more, to depend on someone to feed them. Very difficult. So when we have a Parkinson's support group on World Parkinson's Day, it comes in April. When you see, many Parkinson's patients will not try to eat in front of everyone. They will not go there, though they will be there. They will not go. And when we did a screening, many of them refused that they need assistance. No, we try to do it, they say. But when we spoke to the attender, they said, yes, we feed them at home. And whenever they go for a family function, wherever they go, they don't eat. So there are a lot of psychological issues are also involved. The Australian Dietitian Association has also come with their own nutritional swallowing questionnaire. So as Indians, where we have so much diverse, you know that every 100 miles there is a different type of cereal we eat, different types of cuisine we eat, isn't it? I'm basically from Chennai. In Karnataka itself, where I practice, the North Karnataka has a staple cereal which is jowar. Jolada roti, they call it. Some other pockets of Karnataka, ragi has the main cereal, and Bangalore is a very cosmopolitan population where we eat different. So food is something personal. Whether you live in Ireland, US, Australia, where it is, you eat your own khichdi, your parathas, your pongal, or whatever you want to, idli, sambar, dosa. Correct? Because food is something personal. We have grown up with that. So we can come up with our own nutrition questionnaire to screen depending on that, but this is one of the validated proforma which is used. Bedside swallowing test is done by the SLPs. They also do for the whether it is water, or they also do for, depending on the patient's ability, the oral motor evaluation. They do that. They also do a lot of exercises. They give a lollipop first to do it, and then they try about blowing the balloon type of thing where they try to do the blowing. There are a lot of people who use popsicle sticks to open, because the mouth opening is very narrow and they can't open. First they try, before all this is feeding weeks, they work on it. So it is depending on the lot of popsicle sticks. They do it like 1 stick, 2 sticks, then it goes up to 10 sticks where they put it. So this is how they try to do the mouth opening to be more, so the feeding can be better. So they do a bedside swallowing test. Guidelines for feeding people with dysphagia. Please look at this slide very carefully. The physiotherapist or the occupational therapist comes into role, because you need to make sure, if possible, if the patient is possible, he needs to sit in an upright position. Just like in an enteral feeding, we say to prevent risk of aspiration, we need to be in a 35 or a 45 degrees, where we insist like that it should be sitting in an upright position. Actually, there are a lot of other tools that are available, like a triangular pillow and all in the West, where they try to keep it like a wedge at the back, so it is in an upright position so they can swallow better. Place food in stronger side of the mouth. So what happens is, suppose if there is a severe, like a stroke, where the right side of the brain is injured, where there is an infarct, the left side is compromised, isn't it? It's the opposite side. So we need to know where is the insult. It can be an MCA infarct, it can be so many other brainstem injury where it will be very difficult to swallow. If they cannot swallow at all, they will be on peg feed for years. So there are different things where you need to, where Dr. Dash was also mentioning, like where you need to know which side of the mouth to give. So it is depending upon the stroke, which side you have to give it on the stronger side of the mouth. Patients should tilt their head forward rather than backward. They have certain compensatory mechanism which the SLPs will come in the rounds, and they try to rehabilitate in the patient. In feeding, patients sit at or below their eye level. In the subsequent slides, we can see that triggering different sensations stimulate reflux. And also you can see that they have certain consistencies. Temperature also affects it. Temperature, if it is warm, if it is cold, that also affects the swallowing. Monitor patients closely for signs of aspiration, which is very important. Now, factors affecting the consistency of the food. Content of the food. Definitely the content of the food is a thing. You can see that when you order for certain things like a kanji or a wheat porridge, when it comes to the patient's room, it is little bit more gelatinous. It is bit more thicker. It is not the same consistency when it is warm. You keep it closed for some time. The porridge has a different content. The fiber content. Most of the neurological patients have constipation. You know, as you're practicing. So fiber content also will have a different content of the food. So the water content, the starch content, you know that a tapioca starch, an arrowroot starch, your what do you see, your sweet potato, when you make it boiled and put it in a, each starch has a different consistency, isn't it? And also that how food is chopped, blended, ground, you know that how it is. Natural thickeners, there are a lot. I will talk in the post lunch session. The viscosity of the food, the way the food drops, that is there. The viscosity of the food is depends upon the consistency. Method of cooking, you know that dry heat makes the food hard, and also steaming makes the food soft, and while frying, how the makes the food crispy, isn't it? That's why we learn food science in our graduations. Temperature, cold temperature increases viscosity of the food, makes it crispy, food softer. Hot food increases softness. That's why the warm food, people like warm food. Temperature also affects the taste and smell of the food. Yes or no? Everyone loves warm food. There are people who even warm it for a curd rice and a plain rice and then take it out, then add the curd dahi, and then it's quite warm. So everybody loves warm food. Those are right out of the tawa. Who doesn't like a paratha right out of the tawa? Who doesn't like it? So that is what interprofessional collaboration. What is the dietitian's role? Dietitian has to work with a speech language pathologist or a swallowing therapist, so, and also a physiotherapist, an occupational therapist, and a respiratory therapist, and a nurse. This is not possible in all settings, but at least an SLP will score it along with the when the instrumentation is done or a bedside swallowing, and then they have a form which we need to standardize. Physiotherapist plays a very important role because of the positioning and how it is. Respiratory therapist, what happens is many times I feed the patient in my setup and will along with the nurse and a respiratory therapist. So when there is a cough after the SLP, of course, when they've scored the patient. So what happens is we have ready with the suction in the hand, the respiratory therapist stays there so that immediately it can be suctioned out. So it is very important for us to know. So once we do a few patients, we come to know what are the different things. But one thing I can tell you is they are so thankful to have that food in the mouth after months. The tears just runs down of that. Tears just runs down. Because something orally, you know that you can feed them peg-wise, you can feed them through the rice tube, but you know the digestion starts here. So when they have that taste also, I've seen so many people blessing me and just crying so much that yes, first time I'm having a kanji, and they really, really appreciate it. So this is something you're helping someone so greatly. So they will be so thankful. This is such an important, what do you say, an intervention as a dietitian, as a clinical dietitian you can do. So please look into it in your setting, what you can do. And dietitian's unique role, nutritional status, everyone knows that there is an SGA, you do a PG SGA for an onco. So I think even for dysphagia, we need to come up with our nutrition score. If there is not only just for a thing, but just like an E10 or a swallowing questionnaire and the nutritional adequacy. So you need to assess, interpret, monitor based on the nutritional risk, collaborate. Some roles will overlap with the other interdisciplinary stream. You need to have the shared skills. Then also the complementary roles. We need to have a very good rapport with the SLP, with the nurse, without nurses, you know that nothing can happen. They are the ones who give the medicine. They are the ones who give the nutrition. Also, you would have seen in the enteral feed or the peg feed or the TPN, and then the intake and output, the documentation. Which you, when you take your role very seriously, they will know that no, we need to really document this properly, because Yes, ma'am is very serious about nutrition. She really checks my intake output, whether it's your team, they know that. So, as a part of the interdisciplinary team, you know that when the nutrition is good, the length of stay is completely decreased in the hospital. They are weaned out of the ventilator faster, the edema is less, and they are weaned out of the ICU also to the ward. Now, in the this one, consider that. Thank you. Consider all medical diagnosis, your nutritional care plan. Correct. See, when you see a consultant, when you see an, they have their own roles. Aren't we the one? We are there everywhere because we have food, isn't it? Correct. So we need to know about liver, we need to know about kidney, we need to know about ICU, we need to know about neuro. We are truly, we can't say we are not in that like the best way. They say we are only a dysphagia dietitian, we are only an onco. Yes, there are monospecialty hospital available, but when you are working in a multi-specialty, we are also looking at different, when even in an ICU, when there is an 12 bed, 16 bed ICU, each one has a different diagnosis. And we need to know, we are reading the critical care notes of the day. We are talking about to the intensivist regarding the target volume and so on. So as a nutritional care plan, the first thing is consider all the medical diagnosis, multiple pathologies that is there. You need to know where the stroke is, which side of the body is weak, so that we feed it on the stronger side. Should be considered in total. We cannot work like an island. Okay, you just give him a soft diet, you give him a blended or something like that. Why is he not even in a ward, when they say that you're giving a soft diet, when you're giving a thing, you will say, okay, there is an aphthous ulcer or there is a mouth ulcer, that is why he's not having, so he's going to have a Zyte gel, so or whatever the gel, the mucane gel or whatever. So you're going to change the consistency of the diet for the patient, why he's not swallowing and so many, isn't it? So the temperature matters, everything matters. Decide on tube feeds or appropriate nutritional supplements when the patient is also on Rice tube, and also you know that when they start eating, they will have about 3 to 5 spoons or even 1 spoon, they start coughing. So you need to know how to give it. See, it is not easy to have that Rice tube, which is about almost 12 to 16 freca is the one that is usually used. 14 or 16 in most of the hospitals in India. Can you imagine a tube which is there for months, and then you're trying to give a pureed food or something? It is very difficult. Can you imagine something like that in your throat all the time for months? And then, so be very sensitive what he's going through. Just saying swallow, swallow or whatever, but please be there when there is a feeding that is going on. Information from caregivers is very important. History and onset of present difficulties. When there is a patient who is admitted for whatever reason, when they come, no one wants to come to the hospital. That we need to understand. With so many years of experience as clinical dietitians, you all know that no one likes to be in a hospital. We are not in a, they're already very upset that they are in a hospital or their loved one is in a hospital. So the first thing when they tell you, what is the first concern? Can he start eating orally? First thing they ask, or they will say, my son has not eaten for the past few days. That is why, with fever, with whatever may be the reason, the first thing they said is, my dad has not eaten for the past 4 days, my mom has not eaten, my sister has not. Isn't that the first concern? That they will say, oh my God, they've not eaten, they've not drank, they've not. That is the first concern. So history and onset of presenting difficulties, individual. You need to see the perception, the concern, the priorities. You know that when you have such a diverse population in our thing, we need to understand their preferences. This is not like the West. Yeah, when they say a coffee, it is now we call it a vegan, where it is you can say, is it a soy milk? It is now everyone is lactose free. Then they talk about different thing. Then say what, no sugar, no white sugar, date sugar, palm jaggery, coconut sugar, and then you start about soy milk, almond milk, peanut milk, you name it. So just a coffee alone or a milk alone has so many variations. You can understand that when we are dealing with this, you're going to ask about food allergy, food intolerance, IBS, IBD is on the rise, the food intolerance is on the rise, or out of their own volition, they are saying, no, I'm on a gluten free, I get constipated. So you need to understand so many things, isn't it? So you need to understand that potential risk, dietary preferences, eating, drinking, and swallowing history. Is he coughing? All they say as seniors, no, many people will also think that, okay, when they are, one thing we need to understand is when there is a senior that is admitted, the first thing they don't like to trouble their kids who are grown up. They don't want to be dependent. So they will not voluntarily say that, okay, that many seniors stop drinking after 6 p.m. or 7 p.m. They are scared to go to the bathroom because there is a fear of fall. They are dehydrated. And when they eat at home also, they have a lot of coffee. They just do this and this. What do you say? Just pass it on. They don't give importance to that. So you need to ask all these things: dietary preferences, the cultural awareness, religious conduct, consideration, the allergy. We are not going to give, though you say that egg is 6.6 grams of protein, when there is a person who is following a certain religious pattern or due to something, we are not going to give those 2 eggs as an egg flip or an egg blend into that. We are going to respect his, what do you say, preferences, isn't it? That is what is the most important. We need to give dignity in care. Danger of not blending to a safe consistency. So when I talked about the interdisciplinary, we are there only to prevent malnutrition, dehydration. The most important thing, we are there as part of a team for safe swallow. So the consistency is very important and messy and dissatisfying. It cannot have multiple lumps. When you look at a papaya puree, it should have a mono consistency. It cannot have even a one lump. Can you imagine one lump or few lumps and then think of it as a suji upma? When you have lumps, don't you get irritated? That is only for you, it's a preference. But there is an inability for him to, her or him to swallow that different consistencies because the brain or whatever, the physiologically, the anatomically is compromised to give that command to that when that 55 muscles are involved to swallow that. So you need to understand the reduced nutritional content. No one likes to have that consistency, which is just a brown color as a porridge with no this one. Reduce choice. Patients lose their desire to eat and avoid meal times altogether when everything is blended and given like that. Okay. So now look at this dysphagia nutritional adequacy calculator. When you have a person with a rice tube, and when you are giving, when you're telling the sister, we are also giving a pureed food in a small bati or a katori or a bowl. And then he's saying we are going, you have to tell the nurse team along as a thing. Sister, is he taking 5 spoons? He's taking 10 spoons. Please note it down. If possible, give them a separate sheet, including you can request the attendant.
5 minutes.
Yeah. Attender, and then you have to calculate and you can see that whether it is adequate or not. Increasing nutrient density is very important for us. She will have only those 5 to 10 spoons. How are you going to make it nutrient dense? By adding a walnut powder, what do you say, walnut powder, almond powder, whatever it is, maybe a few tablespoons of an ONS, which is more thick, making it more calorie and protein dense. By adding ONS, by adding whey protein isolate, by adding sweet potatoes boiled and mashed makes it more thicker. Skim milk powder, date syrup, jackfruit flour, all that can be done. You can do it. Risk factors of dehydration. You can see that it is multifactorial, and also dysphagia and dehydration is very common because the one thing which I want to tell you, very, very difficult to swallow water. Water is not the first thing that is given. Very difficult to swallow water. So that is why we usually give a blended food, okay, which is easier for them to take it from here to the back of the mouth, to the roof. Okay, dehydration is a relevant critical problem. 1/3 of inpatients dehydration is misdiagnosed and underestimated. Very important for you to see the intake output chart when you write the notes. It is not important for you at the back. First of all, the nutritional daily, your form, which is there after the nutritional assessment form, you have a daily form which you write, patient so and so, he's on rice tube, feed 200 ml every 2 hours. That should not be there at the back of the file. It should be there immediately after the nurse's notes or after the consultant's note. You put yourself the last page in the nutrition in a file. Nutrition is last in that hospital. I'm very particular. Immediately after the consultant notes, the nutrition notes is intake. I'm very particular about that. Most of the time, I also write in the daily notes in the consultant thing only. Because you put it last yourself, then the nutrition is considered last. So that really maddens me sometimes. Fluid and electrolyte requirements should be met via oral or enteral routes if it is not taking adequately. First measure to replace fluid loss should be offering thickened liquids of food with high fluid content. Sodium containing food and liquids must be avoided, especially in hypernatremia is common, so that we need to understand the sodium of the day. Mealtime observation, this is very important. Coughing and choking, please be there when the nurse is feeding. If possible, if you are allowed, if your protocol says that you're trained first, then you start feeding the patient along with the nurses, or you be there and then you'll also pick it up. Coughing, choking, wet, gurgly voice, you have to be at the eye level of the patient. Taking a long time over a meal, falling asleep, complaining, difficulty of drinking or swallowing, reluctance to eat certain consistencies, that should say in a geriatric patient, feeling of food getting stuck in cheeks. When you feed a stroke patient, you can see they keep it here for many times, and then later on they try to. And then tracheostomy is a different ball game altogether. Best practices, please look at this. Work together as a multidisciplinary team. Communicate the changes for all staff to be using the correct terminology, including your food and beverage department should know what is a dysphagia diet and a blended. Without you training them, sorry, it won't come to the bedside. Everyone should be aware of what type of diet fluid. So we need to have a form where the physiotherapist can write, where the SLPs can write, where we can write. So when the nurse or the consultant sees it, it is one form where he can see what happens to the patient regarding dysphagia. Patients with dysphagia are at increased nutritional risk. Consider food fortification, ensuring choice of adequate, suitable snacks and nourishing drinks. Look at this. I think you should be more explicit here in step 2 when he says then a miracle happens, occurs, right? So we need a theory is completely different, practical is completely different. One of the significant causes of hospital and geriatric malnutrition, especially of dysphagia, because they are not sufficiently or carefully screened. Dysphagia rehabilitation requires coordinated work by multiple units. It's a very specific area, and we did a world swallowing survey in 2020 when we did it. Dietitians responsible developing a screening tool, training protocols for the nurses, for your FNB, for your juniors, for everyone there in as a dietitian's team to identify and manage dysphagia in your hospital setting. Nutrition and swallowing checklist, maybe we can do it for the Indian setting. Take a key role in the treatment of dysphagia, improve quality of life, shorten healing times and reduce length of stay. Widely prevalent, but not just in specialized discipline. Even in post-COVID-19, you can see even in normal adult population, it's a hidden disability. You play a very important role in rehabilitation, and you should also know, you should exude confidence in your rounds. For that, you need to be knowledgeable first. You need to be, what do you say, understand the terminology, what the SLP is talking about, what the nurse is talking about, what the consultant is talking about, it can be because of the stricture, because of a corrosive poisoning. Is it because of a stroke? Is it because of a traumatic brain injury? Is it because of so many things, onco, all that. And then, so thank you so much.
Very nice, Sreemathy. It was a wonderful, very, very enlightening presentation. And I hope it helped all of us. Excellent. Sir has a question.
Maybe we can just take one question here.
No, your comments, sir.
I think it is a compliment.
Very well explained, Sreemathy. Congratulations.
Thank you.
A lot of teamwork here. Shows.
Thank you.
Hello. Am I audible?
No.
Rather, I have a request for all of you. Why? At a surgeon, what I am requesting. Now, I'll give one example to you. One of our staffs, and he accidentally took acid, and then he had a burn of the larynx as well as the pharynx. For nearly a year, we struggled with me, I and Alok. We did multiple, I think some 7, 8 surgeries on him. But somehow it was not successful. It was a very severe one. We took about a liter. So finally, we gave him an option that you need voice or you need eating. So he used to he used to have a high store. So he said, I need. We took out his larynx. He's only 36. And throughout life, he is without larynx. He has a tube. tracheostomy, and he is eating very happy in his restaurant. Now, what does it say? Say it's not simply providing nutrition into the body or giving boluses to it. The taste is so important, as especially as they grow older, elderly. You ask them, taste is everything for them. Why I'm saying this? This tube thing which you are putting is very distressing. It erodes the mucosa, it can cause bleeding, candida infection, severely painful. Even people are asked for mercy. So I want to die rather than putting the tube here. So what is my request is, you see, sometimes if the patient is partially disfigured, it is easier for the residents and the doctors to put a tube. Fully better patient कुछ बोलेगा नहीं, who is going to do and all these things. So that's where the assessment is. Please assess and tell the surgeon or the physician, you, sir, this patient is capable of taking swallowing partially. So I will tailor my feeding and all these, and let's try to get rid of this tube. Years together they used to. My corrosive patients for 2 years waiting for surgery. So that's my request, that first see whether this guy is capable of how much of percentage he is swallowing, and then tell her these things. That will be of greatest help to us in managing.
Thank you, sir.
Thank you, Sreemathy. Really well explained.
Thank you.
And as you said, it's really a lot of teamwork. It's not one person. And being with the patient and actually identifying with the patient. I always tell my dietitians, just see that the person next door or you addressing is your relative. You will never make a mistake. Because he's just a patient, then you treat him as a patient. But if you think he's your relative, I know you'll do it.
I think empathy is very, very important.
Important in this.
You need to feel for them. Empathy is very important. We are in a very noble role. And I think nutrition has come up so much, and it is up to you. This is the only field where you can take it to any level you want. You're there in every, you can take it to any level you want. Definitely. So I
Yes,
think
don't write it on the last page. Nutrition is important. And I also, Sreemathy explained it very well. You know, give concentrated nutrition because they eat 10 spoons. So, you know, just add paneer, cheese, just make it so nutritious so that it's just not khichdi. The khichdi is loaded with all those things that she asked you to do. So, very important take home messages. Thank you.
Thank you so much.
Announcement over here. We would request all delegates to write up their questions. Okay, you can write on a piece of paper and you can share it across to me or to Dr. Bhavna over there. So before we proceed for, because after this we are going to have a panel discussion in which all the three speakers would be there. So we would like to have the questions at that time.
So we've got another great speaker. Very happy to introduce my friend and colleague, Mr. Shiv Shankar. I know him as Shiva. I think everybody knows you as Shiva, right? He's Vice President, IPN India, Vice President, Asian Nutrition Society, Chairman, IPN Quality Award. So he does a lot of multitasking. Executive Member, IPN Dysphagia Core Group, President, IPN India Onco Nutrition Core Group, Program Director, NICC, Consultant, National Institute of Research, Instructor Designer, Certificate course on Onco Nutrition, Associate Editor, Member, ASPEN Global Nutrition Programs, and is LLSPEN Nutrition courses in various clinical conditions, Certificate course in Research Methodology, ASPEN's course in Clinicians, Compendium in Nutrition Support Therapy, is visiting faculty at Dr. BNM College, SNDT College, and has a lot of research and publications to his credit, both national and international. So over to you, Mr. Shiv Shankar.
Thank you, ma'am, for those kind words. And it's still good morning for me. So one question I would like to ask is, how many people have registered for ICNC till now? Can you please raise your hand? No one?
So everyone
You
in India
have
has to go out.
You have to. Thank you so much. And those who are not, yeah, thank you so much. You are going to miss a really wonderful event and a wonderful message. And if you are going to attend ICNC,
don't miss the China declaration. This is the one which we are going to make a very strong statement from our community to the physicians. So you have to be a part of that one. So that's a formal invitation I extended. Now,
Anybody not aware of the, anybody wants the link or any help for registration, then you can ask him right before he starts
people
the
are
session.
sure.
Delegate dysphagia group, okay? For the IPN.
Yeah, okay.
Now, Sreemathy has spoken so much. You may be wondering ki, what I have in place to really speak about. In dysphagia, what else you can really cover it up? She was totally, completely she had spoken about the dysphagia management. And I would apologize in the beginning only if I take a big pause in between the slides, because I didn't get even a 5 minutes to really go through these slides once I had made this one. And I couldn't download on my mobile also because it's a huge file. So that's why, excuse me if I take again a big pause over there. So what I'm going to talk about is this is the first one. What the slide actually I want to put it across to you all is the, you all want the Indianized things, or you still would like to follow all the Western countries what they are propagating? You all want, so we need to come together, work it out for that one. You have to accept it and you have to give your inputs as well. This is the first tool from IAPEN. We are giving it to our own community, not only the community, I would say, not the dietitians, I would say, it is dedicated to the nation because it is going to be used for the patients. You all go through this, you can take a snap of it. The last two lines we have removed now, which is going to be getting validated even in AIIMS also. We are going to get validated in the next week. And I'm quite sure there won't be any issues with this tool. And if you see must, MNA, NRS 2002, and any tool you take it out, any patient getting screened over there will not escape from this tool. And this can be a self-screening. You don't have to really ask the question for the patients. You can translate in any of the Indian languages or foreign languages, put it across at the registration table or outside the OPDs where the patient can read himself, herself, and go to the dietitian. That's what the screening we want. So this is one of the best tool what we can really come to take it to use it to for the betterment of the patients. Okay. So what dysphagia Sreemathy did speak about. So how different I can be, let me try the best way. And you all know how big the dysphagia is happening over now. It is the problems of dysphagia, why it is increasing is, the one thing is the increase in the population. The second aspect is the increase in our lifespan. So our lifespan is also increased from 47 years at the time of independence. Now it has come to 70 years. So the more the lifespan, the more the chances of people getting dysphagia, more the diseases are there, and even the geriatric population also, they also come under this aspect over here. Okay. So signs and symptoms I'm not going to talk about. She has already spoken about, but there are some things which we don't relate dysphagia to the directly kind of a thing. What we say dysphagia is something like difficult for swallowing. Is it so simple? But if you really see some of the things what Sreemathy mentioned, I don't want to repeat over there. But today's my talk will be more of a cough, like while the patient is eating, why does he cough, and how we can really resolve that issue. So there are many things like the drooling or the nasal regurgitations or even the vomiting. The food doesn't actually pass through the esophagus. It is stuck over there. I'll be elaborating on that one. Even that also gets classified under the dysphagia part. So the impact of dysphagia, if you are good, if you are going to see that the main thing what we are worried about is the aspiration. Again, then once the aspiration sets in, yes, there is a compromised immunity, then the fatigue and other things are going to be included. And when we talk about the dysphagia, we forget about the dehydration. Very well, Sreemathy did elaborate on that one. Till 1 year back, anyone you can relate it. Whenever we are going to talk about dysphagia or a patient coming to you dysphagia, how many times you thought that the patient can be dehydrated? I don't think we ever did that one, because we already focused we are only focusing on the food aspect and the consistency. And what consistency we had? Only the one soft diet, isn't it? कि खाने में तकलीफ है, soft diet है, इसको खिचड़ी दे देना. How many different varieties of food we were giving? We cannot count 5 foods for lunch. Khichdi and maybe a soft dal rice. Uske baad mein kya? We don't have anything. If you move to the south, you can say curd rice can be added. But if as I say, can you count 5 dishes for that one? It will be very difficult for us to. Yes, If you have one or two plan, yes, you can really beautifully plan. We can have a lot of ingredients put across over there. But whenever you are talking about the dysphagia, malnutrition along with the dehydration, we have to remember, and they all are interlinked over here. Poor wound healing or the increased risk of skin breakdown, that happens because of the dehydration. The psychological aspect, again what she said, I don't want to repeat over there. People don't want to, the moment the lunchtime or the dinner time comes, they go out. They don't want to be along with the families, or they want to skip the social events as well. They don't want to visit anyone's place over there. If they go over there, they feel they are a burden to the others. And there is a lot of sarcopenia can set in. You always see the patients who are already into the dysphagia kind of a prolonged period of time, they are never healthy unless until, because the concerns now what we have to address this one is like dehydration is a thing which we don't want to focus much over here, but the type of the diet what we are going to serve, whether it will be nutritious one, that is the concern over here. As you saw in one of the slides where Sreemathy did mention about whatever we plan, no, if you see the protein content, how much it will be, 1.2, 1.53, how many times we can really reach 10 grams of protein to one feed? It's really challenging for us. Okay. Further, it's a vicious cycle. It goes on impacting the patient, and however your intervention may be a very strong one, but again, the social isolation or the anxiety, depression, loss of dignity and the quality of life. This is again, these are the things which we never focus upon, because we are only thinking that what kind of soft food I can give. That is the only thing where I will be thinking about, and I think my work gets over once the diet is being given to the patient. But in cancer patients, normally what happens, this kind of a dysphagia is a progressive kind of a thing. More or less, always it's progressing. Today you gave a soft diet. After 1 week, the patient may not be able to even eat that soft diet, because the dysphagia has progressed into the higher grade now. Grade 3, grade 4. Now is only able to take liquids. But if you are not counseled the patient, after 1 week or 10 days, you keep on coming to the nutrition clinic, so that we have to again re-evaluate, or at least that patient can be sent to the speech swallowing therapist so that they can evaluate. But you should have the practice, as she said, you have to follow the speech swallowing therapist, what evaluation they have put it across to the notes over there. They will be guiding you what kind of consistency needs to be changed every time. So the quality of life, how far we can improve upon, that's a huge challenge. Taste changes, we don't consider or relate taste changes to the dysphagia part. If the food is not at all tasty, how difficult it is to consume. I understand psychologically only you get drained off over there. The food with the tasty, how I'm going to eat that one. The sight of the food doesn't appeal you. There are many of the times, how many times you would really eat a pureed khichdi every time, or maybe every 2 3 days, even if you eat, what choices you have got it. So these are the things, it becomes very difficult to address over here. Once the taste is not there, the patient really doesn't want to eat any kind of a food. Now when the grading comes, it's up to you which kind of a tool you would like to use it. But yes, we are going to come out. I would appeal to Sreemathy over here, and I'm quite sure she is going to promise that in 2023 she is going to come out with the dysphagia grading for the Indians. Okay, so this is one thing, everything we need to Indianize. We have to come out with the things. And as of now, if you want to adopt any kind of a tool, there is no standard kind of a thing. We are not following any of these things. We have 6 grades of dysphagia, which we in TMH we are following that one. And the kind of the modified diet, what I'm going to show you one of the slides. We sometimes place it on the patient's this thing, and we ask the patient which kind of consistency you're more comfortable with. So sometimes what happens, Friday evening the patient comes, and now the day is getting over. I really cannot tell the patient to come after meeting the speech swallowing therapist. Now they have to go and take the appointment after Tuesday, Wednesday, whatever the day he is going to get appointed, and thereafter we are going to see. Till then, what the patient is going to consume, you cannot really know. Oh, our protocol says after the speech swallowing therapist evaluation only, then only I'll plan the diet. But 3 4 days, you cannot starve the patient. We always say the every feed of the patient is very important. Every kg of the body is very important. Once you tell them that, they try to focus on their body weight slightly more than that. Even the attendants also will be paying more attention. Every frequently they will be weighing themselves and seeing whether there is a drastic change in the weight or not. So aspiration is again a thing which again we don't relate it to that one, but the liquids, as again Sreemathy said, while drinking they have a lot of problems over there. Then there is silent pneumonia, silent aspiration, which the patient also doesn't realize at times. I couldn't attend Kaustav's full this thing. Maybe if he had covered up that the silent aspiration, It's a very dangerous kind of a thing. The patient doesn't come to know he is already aspirating, and the liquid does pass through the the windpipe, and the patient later on develops the pneumonia and has its own consequences. So this again area we don't relate it to our practices. More or less, if you see head and neck cancer patients or anyone who is injured for the head and neck, they normally they are the more likely patients who can have silent aspiration. You can see it is something around 78% of the patient. It means that almost out of 10, 8 patients can be having silent aspiration, a very huge number. But we fail to identify these patients. Okay, this is she has already covered up. Okay, crisis. So this is where esophageal carcinomas certain times, the where the you can see the arrow marks where the esophagus has constricted. It has become a very narrowed one, and the achalasia condition where the next slide. The achalasia where I would like to focus it is like when we are recommending a diet, the patient complains you, I have a difficulty in eating the food. You gave a soft diet, and after 2-3 days the patient comes back to you saying that I eat what you recommended, but after 1 hour or maybe 30-40 minutes I remove everything, whatever I consume. How you are going to relate it to that one? You won't understand. You feel ki it's a vomit. It needs just maybe some kind of a physiological changes might be happening, or maybe some kind of side effect. That is why the patient is vomiting. It's not like that. Whatever the food is consumed, you can see at this place over here, the food is accumulated over there. It is not passing through the esophagus. So once the food passes through the esophagus, then okay, the patient will be more comfortable. But if the soft diet also, the food will be staying in the esophagus itself only, and the patient feels it's already the heavy chest, and he starts paining. It starts paining, and unless until he removes that, she is not at all comfortable. So that is where now you need to really ask the patients, okay, what exactly happens to you. When they say okay, after 1 hour or maybe sometimes 30-40 minutes or something, they have to remove this one, it may be a chance of achalasia. Again over there, the constriction, what you can see that maybe because of the tumor or maybe some other reasons as well. Not definitely it can be only the cancer may be the reason, but the reasons may be varied one. But these are the patients who also come to you, and we don't really understand what kind of food has to be given. Then again, you may directly recommend a NG tube insertion, but these patients can be put on a liquid diet. Why the consistency of the food is more important? You feel the patient is able to eat everything, so why should I be giving a soft diet? Our focus stops over there. आपको सब खाना खाने के लिए होता है, तो when you ask this question, the patient says yes. So will you be planning a soft diet for this patient? No, you will never plan. But when the symptom he talks about, it means that the food is staying at the chest and it is not going passing through the LES pressure. Then it has to be removed out, and then only is going to be relieved. So he has to be given a liquid diet, not a normal diet or a soft diet. And more, there are some studies which talk about giving warm water to these patients before the patient starts eating, so that it gets relaxed and the patient can have a little bit of soft diet, or maybe you can ask the patient to in between consume some kind of a liquids. It may be a dal, it may be a curd, it may be water itself as well. Even milk also can be given. These are some of the stenting which I wouldn't address over here. Okay, now we are coming to the Indian texture modified foods. In what way we can really come out with our own guidelines? As she said already, we have a so diverse kind of the country is so diverse. Our practices are so different. Every 100 kilometers, your language changes, your culture changes, your food changes, the way you eat changes, and the cosmopolitan population, they have their own challenges in a different way. As I said, the warm water is one of the solution for this one. So the roadmap ahead over here, what we can discuss about is like a very complicated kind of a thing you might feel as I move ahead with some of the slides, but this is what in store for us in near future. But this can be practical only if we start demanding for those technologies. Now we have to talk about the no, we are almost into the not underdeveloped countries. We are near to the developing countries now. So we need to really think about all old thoughts of the kind of counseling planning. We have to come out of all these things. So here if you can see the modifying of food texture and liquid thickness without compromising nutritional quality. I spoke a lot about ITSE in the year 2014 and 15. Thereafter, of late in the last 1 or 2 years, I realized it is not talking about the nutrition aspect. Very recently, I came across a study, similar kind of a statement they made, which I'll come across to that one, where the studies did speak about, they're only talking about the consistency, but they're not talking about the nutrition aspect. But we are nutritionists, we have to deal with the nutrition with the consistency of the food. So how is that you focus on only on the consistency and not care about these patients? Studies on bolus rheology. This is the rheological areas where again we have not, till now we have not spoken about. This is the thing which of late I started speaking about. When the patient wants to drink liquid and he finds it difficult and it starts aspirating and the patient starts coughing, it is a rheological flow of that liquid which is actually causing. What do we mean by that one? Of course, in schools we might have studied, but now we would like to have a implication in our own practice. It is a flow of the liquid, how fast it is moving, how slow you can make it. The faster it moves, the muscle contractions are not actually complementing the flow of that water. So that is why you need to change the consistency of that liquid. That is when now we can talk about the thickeners can be used over there. If you are going to add thickeners, how much of grams of protein you are going to add? I'm not talking about the calories. Let us focus only on the protein. 1 gram, 2 gram, can you add? No, you cannot add a single gram of protein. How is that? It can be then it can be a nutritious one. You have to focus on the nutrition aspect. Then what alternative you have for that? Let us see. The other statements are not that really important. I will keep on uttering those words. The rheological flow, what I speak about over here, you can see once the liquid is poured on the plate, how it spreads. And the other one, the ketchup, what you see, you have to put a lot of effort in the beginning to remove the sauce from that one. Why is it so then? This is what the rheological flow has something to do with our practice. So this is where we really start thinking about, and here the industry has to support us. They have a bigger role over here. The industry is over here. I would appeal to these people to really look into these aspects. What I'm going to talk about in the next few slides, if you can come out with the technologies and the kind of product all these dysphagia patients require, it will be a really great help. And 101%, the numbers are going to be increasing. Nowhere the numbers are going to decrease. There won't be any recession over here at any cost and at any time. Texture is a sensory multi-parameter attribute to the rheological flow and the structural properties of the food product perceptible by mechanical, visual and auditory. Again, the other two factors, that is the visual and auditory, we have never considered that one. एक बार खिचड़ी बना के दिए तो दे दिया. How it appears, how it travels from the kitchen till the patient eats. And as you saw that when it was made, what kind of consistency it was, by the time the patient eats what it is, it becomes a cake kind of a thing. And you had sent a pureed one, which is almost, can be, slightly thicker than a kheer. But in what way then you address the problem of the patient? You didn't. You can say ki banane ka dam to right tha, but the patient is eating after 2 hours. What I should be doing? That is not my problem, isn't it? This is the kind of statement even I would give. But we need to change over that. Can it be done? That is what the rheological flow, viscosities, and the industries, 3D printing and 4D printing is what I'm going to talk about are the necessary things. As of now, we are demanding for that one. Okay. The food industry has their own concerns. If I'm going to ask them to come out with the products which are really needed for our dysphagia patients, they say again the same thing. Whatever we prepare, by the time then we have a cold storage, we have to store the food. It has to travel from places to places. It has to retain its color, shape, taste, texture, and the nutritional aspect. How difficult it will be. So is it really feasible? If you're going to demand from us, what will be the cost if I give the dishes to you, which can be made in 10 rupees? I might charge even 100 rupees or 200 rupees. Again, in what way did I help you out? These are some of the challenges the entire industry or international level, they are still thinking about it. There are some things which have come out in a disposable kind of a thing, like instantly you can make the food and give it to them. So that's what we can ask for the industries. If you can help these people in such kind of technologies getting into the kitchen where it can be made immediately and can be sent, or maybe at the pantry level only it can be made, so that the patient when he wants to eat, 5 minutes before or 10 minutes before, the dish can be made and given to the patients. And these are all the things which aggravate the dysphagia. I don't want to go through because more important slides are there, so I'll be focusing on that one. We'll go ahead. Okay. All countries have their own texture modified guidelines for that one. India doesn't has. We are such a huge population. We are all such a hugely educated, nicely educated, and we feel that the Western people are really very intelligent and their all recommendations are, foolproof kind of a thing. They have done good work, but we can definitely do equal and maybe better than them. The only thing is like we are not able to focus on those things, and we feel undermined that no, they are doing something which we cannot match. It's not at all like that. We can really do. The only thing is like the research aspect or the innovation kind of a thing. This is not inbuilt in us, and we don't want to do something which is new. We don't want to try which is not in a kind of a contemporary kind of a thing which is being followed for years and years. This is the time now we have to change, and we can look out for the when all these countries can come out with these guidelines. What is wrong with us then, isn't it? And these are not, if you read these all the guidelines, whether it's Australian, Japan, or any countries dysphagia diets, they are very much simpler in nature, except for the ITSE. I would say the problem with the ITSE are slightly different. If you see the ITSE's recommendations, now they say ki liquid you want to, whatever the thick liquid you make, you take a syringe, you see in 1 minute how much of the liquid flows out, how much is retained. Or if you have a spoon tilt test, you have to see that whatever the food you take it, once you tilt it, some part should stick to the spoon and the other part can fall it down freely, or it should be a honey kind of a consistency. If you are going to talk in this language to the patient's relative to make the food like this, the patient's relative will really run off, or maybe the patient has a really good patience. They will wait for some time till you finish, but they will never come back to you. Guaranteed this one. You cannot tell them to take a syringe. You cannot tell them to go on, every time see the spoon tilt test or the 4 mm ka hona chahiye, 2 mm ka hona chahiye. You cannot do these things. So this is why it has failed over here. This is the NHS guideline, this is the Australian guideline, and this is Japanese. Japanese are 3 to 4 different guidelines. This is what for the Indian people we are proposing this one, and the dysphagia core group of IAPEN will take it forward, and they are going to come out with the guidelines as well in the next year. We can expect a much better this thing which can be tried, validated in any of your institutes. Any help is required, IAPEN is always ready for that one. Any studies you would like to do, we are going to help you out. We are already initiated even the ethical committee, which Dr. Dash is also is recommended for that one. And the ethical committee is going to help you out if you want to do something of a multi-center kind of studies as well. So you all are welcome, and really go through all these kind of recommendations what we are putting it across. If you have any observations, you are very free to put it across. Ultimately, we want people to accept it, just not for the presentation sake. We don't want to do that one. So in this also, you have addressed almost all the consistencies of the dysphagia, what it is required. These 6 consistencies, if you really see in any household, you can really match this one. Now you don't have to really tell which kind of a spoon or fork or syringe is required for that one. Along with this, we need the utensils, the kind of a utensil, the Parkinson's disease or the Alzheimer's. They really cannot control their hand movements. So they need a particular kind of this kind of feeding vessels, or the plates or the spoons, which are in demand and again can be procured from the industries as well. Now the 3D printing, what I'm going to talk about is what is the future lying for us. Now if you see the 3D printing, where the international community has already started using this one, we are lagging behind. Now you may, even after listening to this one, let me say what is 3D printing over here. It is nothing but of a same consistency kind of a food which you have to be doing very repeatedly without changing the consistency, the color, the texture, and everything, the nutritional aspect, and everything has to be similar. If you make a 10 dishes, 10 dishes has to be equal in every respect of that one. So this is what the 3D printing. Any example if I would like to give, the idli is the best one. Again, you can call it as a 3D printing. You can even have the softy ice creams, what every time the person keeps on giving it, that's a 3D printing. Nothing. The only thing is the terminology. When we use 3D printing, we think about big machines it will be, and a lot of people are involved, big area industries involved. Not necessary. It's not necessary. It has to be like that. But only thing, the technology has to be adaptable kind of a way. If someone wants to have a grade 3 dishes, or someone wants to have grade 4 dishes, it should be able to adapt to that one. So that there are many advantages of 3D printing. A modified texture will attract more attention during consumer purchase. In case of elderly people with swallowing problems, their need to consume pureed or texture modified foods can encourage better consumption. The present pureed foods constitute problem because of its unappealing look and the texture that can lead to food rejection and malnourishment. Much in the same way, texture can have a big impact on people with food aversions. Another group that can benefit from the texture modification are people with weight conscious, where you would like to really give in bulk quantity but with lower calories. Now, the international community is talking about the 4D printing. So, what is the 4D printing? I'll just explain you. We are not even reached to the 3D printing, even though we are using at home levels. Now, we need to industrialize it for the patient's benefits over here. 4D printing is something like what you made, it has to retain throughout the phase of till the consumption is being done. Not only the nutritional aspect and other thing, the color and everything, the textures, to retaining for days or maybe weeks. So that's again a huge challenge for the companies to make that one. The 3D printing is something like you make and immediately you have to consume, or maybe in the next 1 hour or 30 minutes you can consume. Idli you make and you eat in the next 1 hour. Yesterday you make idli and today you are not going to eat like that. So to remain the idli what you made 2 days back in the same kind of a formation of a freshness, is it possible? No. So it has to be instantly made. So that is what 3D and 4D printings are differing from each other. So these are the things which are already being in place internationally. The only thing is now we have to really come out with thinking that in what way we can design our own requirements and in what way nutritional foods can be given. If I say a pizza can be given with the fiber around 10 grams of protein or 15 grams of protein, which kid would refuse that one? Or which patient will refuse that one? You need to add just fibers, vegetables is already there, protein is again it is there because of the cheese and other things. Can we really make nutritious a patient who is so aversion to the food? And if you can really give a nutritious kind of such kind of foods, no one will ever say no over here. This was just a trial which I made with this patient who had this aspiration while drinking the water, and you can see the way it went on. He was not able to drink that. What I did was there was a supplement on my table, and you can see that that's around 300 to 400 ml of water. He mixed that one. For 2 3 days he didn't drink water. You can just imagine how it can. I asked him, do you have any problem? He said no. Almost 400 ml of preparation he drank, and that I was so happy to give him 240 calories and around 8.5 or 9 grams of protein with that one supplement. Now, if I had used the thickener in this and told him to go on drinking water, how wrong I would have been. Thank you so much. Yeah.
Thank you. Excellent, Shiva, as usual. So we're going to take a lot of initiatives. We finish with onco, we start with dysphagia. Very, very good
Thank you.
initiative and required for today. Any questions?
I wouldn't take the name of the supplement, but I can tell you, you take any supplement. Yes, any ONS would.
So much.
Yeah.
Go to the next session.
Thank you all for investing your time. Now we proceed for our panel discussion.
Ma'am, please be seated only.
I request Ms. Shilpa Chadha Thakur, Secretary IAPN Delhi Chapter. She is going to conduct this panel session as a moderator. To introduce Ms. Shilpa, she is Senior Consultant Dietetics, Asian Hospital, General Secretary IDA Delhi Chapter, Secretary IAPN Delhi Chapter.
Faridabad. Then we have our second panelist as Mr. Shiv Shankar. I would request Mr. Shiv Shankar to join in for the panel. He is Vice President Nutrition IPEN India and Vice President Asian Nutrition Society, Chairman IPEN Quality Awards. He is President for IPEN India Onco Nutrition Core Group, Program Director for Nutrition Insights for Clinical Air Efficacy, and Consultant at National Institute of Research in Reproductive Health. Our next panelist is Ms. Sreemathy. She is Chief Dietitian at Trustwell Hospitals, Bangalore. She is NAC member IAPEN India, Chief Program Officer for Dysphagia India Core Group, Consultant Nutritionist with Divine Mother and Child Health Program, Consultant Dietitian at Debra India, and Gut Health Dietitian at Dr. Digest Clinic. I would request our next panelist is Dr. Nancy Sahni. She is the Chief Dietitian and Head of the Department of Dietetics at PGI Chandigarh. She is doctorate from PGI Chandigarh. She is a registered dietitian with 22 years of experience. She is a gold medalist holder throughout graduation and post-graduation. She is core group dietitian from North India for developing pediatric renal nutrition guidelines and core group dietitian for Pan India for diet study on IBD. She has won many awards also and many paper publications. We welcome you, Dr. Nancy. The next panelist is Mr. Kaustav. So we had a wonderful talk from Mr. Kaustav. He's a consultant and chief diabetologist at Amrita Hospital, Faridabad. And he holds up a good experience into this field. And he's a specific person for the theme which we have kept, dysphagia. He's been MSc into diabetology and swallowing disorders from Amrita Institute of Medical Sciences, Kochi, Kerala. And he is a BSALP from 2013 to 2017. And he is a self-motivated, highly capable, expert professional with comprehensive experience with dysphagia that we have already seen from his presentation. We welcome you. So with this, we complete our list for the panelists. So it was wonderful pleasure hearing Kaustav, Sreemathy, and Mr. Shiv Shankar. So they were the wonderful talks we've been hearing. So from these talks, we could easily make out whatever the recommendations we have been making. So the recommendations, they have a significant impact, not only the patient, but onto the caregivers also. So while we are talking to patients or counseling patients, especially the dysphagia patients, we need to be little cautious about what we are been talking. For them, the food is not, nutrition is not only that food. The way Srimati has shared us the experience, the way the people cry, the patients are crying while they are having their first food into the mouth. So we need to think from that. With food, we have always an emotional linking. So when we have been emotionally linked with the food, then we need to think while our counseling patients also from that point only. So while we are making some sets, regulations, guidelines, or while we are discussing so many things about how to feed them, such patients, so my question first goes to Dr. Neetu, because before we start with the management part or other way ahead or the nutrition part, being a doctor, you've been seeing a lot of patients of dysphagia. So what do you think that mostly patients ask about? What are the major causes you are seeing into your normal daily OPDs and IPD patients in the hospital? The timings of dysphagia from start of the radiation therapy, because you are a person who are been dealing into specializing into radiation only. So the what kind of treatment or therapies you recommend after them? How do you treat these patients, and how firstly you proceed with these patients?
Thank you so much. Nice question. So mostly patients, as doctors have already discussed previously, so most of the patients come to me with complaint of dysphagia, the head and neck cancer. So we see two type of dysphagia. If we talk about dysphagia, when we see the patient, so it is the pre-treatment, the presentation with dysphagia, and the second is post-treatment or treatment-related dysphagia. So the pre-treatment dysphagia generally we see in patients of head and neck, like oral cancers, oropharyngeal cancers, laryngeal cancer, pharyngeal cancers, or sometimes even in lung cancers with mediastic nodes, which is compressing on the esophagus or esophageal cancers. These are the patients we mostly see in the pre-treatment phase of dysphagia. So the presenting complaint for them is dysphagia or odynophagia, that is pain while swallowing. So these are the complaints. Many times when we talk about the treatment, as we all know, radiation induces some side effects, which can be related to mucositis, mucosal inflammation, esophagitis. Sometimes there is altered taste because patients of, as we have, most of the things have already been discussed actually. So as we we see the patients of base of tongue, they have altered taste, so they do not feel the taste. मीठा खाएंगे तो मीठा नहीं लगेगा. They will feel as if some patients describe is that as मिट्टी कि जैसे मिट्टी खा रहे हैं. There is absolutely no taste. Then some patients present with thickness of saliva. So salivation is very important for oral phase of swallowing. So when the salivation is reduced or the saliva becomes thickened, they are not unable to swallow the food. So that is one reason. So these are the things we see during the treatment. Mostly when the radiation is started, in the initial first week or maybe the second week, nothing happens. It is mostly grade 1 dysphagia. We have already discussed 6 phases of dysphagia. Dr. I'm forgetting the name, Dr. Shiva has already described. So there were 6 phases of dysphagia. So initially we feel that patients are able to swallow with little water, and then gradually they are unable to swallow the semi-solids and then even liquids, and that is the time when some intervention is required, and we have to advise them for nasogastric feed or pet tube feeding or some other kind of intervention, whatever is suitable for them. I always involve my dietitians. It is not the last page, it is the first page for me. So it is a comprehensive cancer care management. So comprehensive cancer care is not radiation, surgery and chemotherapy only. Comprehensive means everybody is contributing to the management of cancer. So it is a dietitian. If a good dietitian is there, then half of the medicines can be reduced and taken care of with good diet. So all the proteins, vitamins and so many supplements we are writing, maybe they may be taken care of by good dietary advice what you may give them. So I always involve my dietitian from the day one of planning. When we are counseling the patient about so many things, we involve dietitian also. So dietary counsel is one important part, and for IPD patients we have dietary rounds every day. All of you also must be having like this. So they are evaluating the patient, what patient had in last 24 hours, and then they are advising according to the patient's choice and their requirements. So they are advising. For OPD patients also we are having on day one, and then they measure all the weight and some mid arm girth and so many parameters they note. And after that, on weekly basis, like we do every Mondays, we do our review. So I ask for a dietary review as well, so they are able to see how patient is tolerating and any specific diet requirement patient requires. One more thing I would say that dysphagia not only leads to dehydration, sometimes it leads to acute renal failure as well because of the dehydration. So you know what happens, ki creatinine बढ़ रहा है, and then we refer the patients to nephrologists and they start 10,000 things. But with little dietary modification, with little oral intake, we may reduce this kind of renal dysfunction. So I think.
So this is a very well stated point. Eating about food or eating and drinking is not only about the nutrition, or it is more about than the nutrition and the hydration which we have been giving to the patient.
Definitely.
So Sreemathy, I would like to ask over here, like is there any proper protocol you are following for your dysphagia patients while the patient comes to you? I'm asking for an OPD protocol.
So, for an OPD protocol, we always have dysphagia diet. So, the SLP would have seen it. They would come with an instrumental thing, even if it is OPD. They would have the instrumental score. With the SLP, they would have done the ENT, would have done the Ps or the VFS, and the SLP would have put the notes, and then only they come to the dietary department. So, we tried based on that, we try the consistency. My FNB is trained in dysphagia diets along with my dietitians who work with me. So when we say we need a puree, they know what is a puree. And we have put charts like lumpy puree, and this should not be like this, and how it should be like this. I will show in the textured diets in the afternoon about the different consistencies, why it is mixed. So we do training for the nurses and the FNB, especially because you know the attrition rate is high. And so every month there is a dysphagia diets training. So once the OPD, when they come with the dysphagia score from the SLP after all the evaluation, we do try in the OPD itself also to train the attender, see how it is given. And maybe with a soft tip spoon, you could have seen in the pediatrics, where they have that rubber-based spoon, where even if it is a steel spoon, they cannot eat it. So we have the rubber-based spoons. For an 8-month-old, a 9-year-old with the soft gums, they try to feed it. Have you seen it in the baby stores and all that? So we tell them you can give it. So it is a small thing with a soft tipped thing, and we try to first give the puree and other things, more of neuro in my practice. And yes, there are cancer patients also. We are a multi-speciality, but then we take it up like that. So even in an OPD, you can try it up in the room, and then we do. And neuro rehabilitation and rehabilitation is a big thing. So you play a lot of role when they come for the daily exercises, whether physio and other things. So we need to have a protocol. This is how we do.
The swallowing is very difficult in case like while we are doing swallowing, we do thousands of times in a day, and it is a kind of an act which we actually don't think for it. But in case of dysphagia, it is something which we change the mode of the eating and the drinking pattern. So we are just taking something, a natural thing away from them. So we need to have, like when we are doing the counseling, I think we need to think from that point of view while we are dealing with such patients. So Kaustav, I have a question for you. So, how do you like have a early dysphagia assessment in the patient, especially in the head and neck cancer, who are being treated with CTRT? Because you have covered into your presentation that you've been.
Can you repeat the question, ma'am?
So, my question is like, how do you early diagnose the like you have must have dysphagia assessment for these specific head and neck cancer patients who are being treated with CTRT?
So we have a set protocol in our institute. Every patient who comes with head and neck cancer, either treated with surgery or chemoradiotherapy, they have to undergo an initial swallowing assessment pre-treatment.
Okay.
Then, following the treatment, also one assessment should be done so that we can compare the differences, like how the things are going on right now, and accordingly we can start the management.
So the assessment forms which you have been
Those are
showing
the same
that we are using for it. So excellent. So
Clinical assessment
no, sir. In some cases, there must be a instrumental assessment, not only clinical assessment, because sometimes we might miss some things in clinical assessment. If a patient is having, suppose, say, lateral sensitivity is weak, he might not cough, and you may think that he is swallowing normally, but it might not be the case. So when you feel there are other signs of aspirations like distress or maybe a chest infection or something like that, then we have to definitely go ahead with the information so that we can know what the exact problem.
okay. So my next question is for Mr. Shiv Shankar. So I wanted to ask you, like, into your own practice at your institute, do you follow some kind of a grading for the risk, like while you are been detecting the dysphagia patient for mild, moderate, or severe risk in your practice? Do you have that? Because we were talking about the assessment sheet and all, since we have been do not have any specific for Indian scenario.
See, normally what we do is like at the OPD, the consultants OPD only when the doctor, they after meeting the oncologist, when they come out and they will be given a checklist. They have to complete all these things before the final diagnosis is being done. Where the nutritional assessment is one part of over there, and the assistant with the at the counter, whoever is sitting over there, they already been instructed that to ask the patient only one, that is a screening what we say. Do you have any difficulty in swallowing? Only one question they will ask.
Okay.
If they say yes, they will say first you meet the speech swallowing therapist, then go to the dietitian.
Okay.
Many of the times what happens that out of anxiety they come to us without meeting them. Then what we do, the chart what I showed, no, we tell them which of the consistency you are more comfortable with that. Whatever the consistency they mention about it, accordingly we are going to give diet chart for them. And we always tell them whenever you have difficulties, deteriorating conditions, first you go to the speech swallowing therapist, then again come back.
Okay.
And then one statement I keep on repeating, we all dietitians should be having the kind of a constructive kind of condition, which we all have, but somehow we don't use it. So this is where clinically you use that. The patient might deteriorate the condition in the coming few days, because sometimes the patient may not come back to you. And centers like AIIMS or TMH, where you get patients from many other places, not only from Delhi, you don't get surrounding states also people come. So once you are given the diet, if the patient goes back and is not compatible with the consistency what you recommended, your work is actually not done,
Done.
I would say.
Yes.
And you have misled the patient. You have done two wrong things at one time. And the patient feels that the recommendations were right, I am not able to take it.
Hmm.
The recommendation has to keep on changing as the progression is there.
Yes.
So
So
that
follow up
information
is very important.
that we have to do. The follow-ups are the most important kind of.
So while we are being doing the assessment, the follow-up protocols need to be also be at place, that wherein the patient has been again coming over to us whenever we thought of like the way that they are visiting the doctors. Again, the protocol should be to
Exactly.
visit a spelotherapist or a dietitian in the institute.
We
Okay.
keep on telling the patients, that you might have seen the TMH diet charts where we have the graph over there, put it across, and we ask them to plot, or they can come and get the plotting done from us. And we give the ranges. You should not go beyond those lines where the danger line starts over there. So that makes the patient more conscious.
Yes. So something beyond nutrition we need to talk about when we are talking about dysphagia. So over to Dr. Nancy. So Dr. Nancy, you are from PGI Chandigarh. It is a very big reputed institute, and you must be seeing the dysphagia patients too. So while we are talking about nutrition and all things, how do you take care for the specifically the nutrition intake of such kind of patients while you're dealing with, because we require follow-ups also. In first, we require the texture diets. We have some pre-assessment. We need to have a post-assessment also.
See, the assessments and all. First of all, can I ask a question to you? You talk so beautifully about like the way you manage the dysphagia patients. That is there something that before you know that this patient is going to suffer after surgery? So, is there something like this that you tell your dietitians to take care before to build up the nutritional status before everything happens, so that patient is in a state to handle the dip downs in the nutritional status? So, is it like I'm sorry, like I just
No, no, she always take care. I know that.
I was inquisitive because in my setup, specifically in pediatric onco cases, we don't let the doctors put the kids on chemo unless and until there is a certain standard of a nutritional distinct status.
Definitely. So we take on the baseline, the day one of counseling, we consult our nutritional therapist as well. And after they give us green signal, then only we start the treatment. Obviously, they will not be able to tolerate the treatment. Then what is the point in giving the radical treatment? So we do always. And Dr. Shilpa used to take care of our patients.
So we have worked together. So that is why I would say that the dental visit and the dietary visit, even in the OPD basis on the radiation for the radiation patients, we have been seeing that.
Because it is somewhere, this link is missing in a tertiary care hospital, like somewhere, like because
It really depends on like the way ma'am has been practicing. So
so it really depends.
I happen
on the
to have a
doctor.
chance to work along with her. So that's
So coming to the dysphagia patients in my clinical setup, all the assessments and all, they are done by the audiology wing. Everything they tell us that for OPD patients or IPD patients, that this is what is required. But then they do give us a statement, हमें नहीं पता ये 200 कैलोरी खाएगा कि 2000 कैलोरी. That हमने बता दिया that this is what they require. Now you see, like either what all are you feeding? If, like as emphasized by all these great personalities sitting over here, that food is just not. There are two things. It is just not for the physiological demand. It is a psychological. Have you seen, Kabhi? When you go to a marriage and you are given a hefty shagun and there is a vegetarian food for a non-veg person. या फिर आलू गोभी खाने आया हो गया यहाँ पे. So that way. So and you think of a person who's just getting this khichdis and dalias, कितना खा लेगा वो? So that gap, that is a very, very crucial thing which a nutritionist and only a nutritionist can understand. We have to do a lot of hand holding for these patients, lot of hand holding, lot of empathy goes, because all these texture modified diets, everything, there is some negative vibe in the mind of a patient as well as the caregiver. So this is where we have to chip in. Like kids, dysphagic kids, kids with dysphagia. He was like cranky, not having anything. He said, "I want to have Maggie noodles." And the therapist, the audiology wing said, no way, you can't push the noodles inside. So what we did was took the taste maker, Maggie taste maker, and we mixed it in the porridge, and he was happy. I mean, he was satisfied because then oregano, we use all these things. See, to be very frank, the tertiary care hospital cannot afford these things, but we tell the parents to get them. Now, one case I remember of an 85-year-old female, and the audiology wing telling me that there is not such a problem this female is creating. That fuss that she's feeling choked, she can't have. But her tests say that she can have this grade of a thing. So, from a very good family, VVIP status, but all the servants around, there was no kid around. So she was depressed. And then, she was a Sardarni, I remember. And next day, what I thought when, while coming to my office, I go to Gurudwara and something struck me. I said, okay, I'll take this prasad for her. And I took a good helping. And I mean, see, I'm just emphasizing that empathy point over here. And and I was like, I got prasad for you, and I got a voice from the this thing, the आवाज जो आई थी, वो ये था कि you will get well. And the female, she was reluctant to have that porridge. She had that whole prasad, and then I told the relatives that what you can do is that make this prasad in milk instead of water to increase the protein content. So this is what we can do. Small quantity, good quality. Similarly, दाल देने की जगह मूंग दाल हलवा दोगे तो दाल का प्रोटीन भी आ जाएगा, फैट भी आ जाएगा, एनर्जी भी आ जाएगा. चाहे 10 चम्मच खाए, 5 चम्मच खाए, at least there'll be certain sort of nutrition.
So you have
Then-
some protocols like preset recipes for such
Yes,
patients.
yes, we have.
So
we
can you
have.
name a few into share it with our audience?
First and foremost, as a nutritionist and a dietitian, you should be empowered enough to know the portion sizes, the nutritive value. For example, 100 gram of skim milk powder gives the nutritive value equivalent to how much milk? Anybody?
It's a question to the dietitians. There's so many dietitians over there.
So that is why this basic thing should not be missing in you. This should be like this. 100 grams of skim milk powder is equivalent to how much milk in protein and calories?
Anyone?
Anyone? Can you explain it? You can't explain this to the caregivers.
So
If
3 tablespoon means 30 gram of it.
So see, it is equivalent to 1 liter.
Yes.
So if you're putting 50 grams of SMP, you are giving 500 ml milk of protein and the calories. So this is where we, I mean, to be very frank, uh, we are lacking. We know everything, but all these numbers should be like this. जैसे doctors को पता होता है कि ये दवाई इधर देनी है. That way you should know. I'm sorry to say, but then I've seen the portion sizes. You cannot explain the portion sizes. Itna ka, itna ka. You should be like this katori 80 grams. This will give 500 calories. This will give 15 gram of protein. That way, in a clear way, you tell the patient. So we have made the recipes like that. Even if we make.
So can you name a few recipes?
Like,
I'm very keen to know about that.
Like custard. Custard is one thing people, the population really likes, and it is discussed. So it is easier for them to have. So we add skim milk powder in that. If in a 100, 200 ml katori or 150 ml milk, I'm adding 30 grams of skim milk powder, 40 grams. So it becomes like, quite a good number if we talk about proteins and calories. Then we make eggnogs also. Then we keep उसको skim milk powder so because PCI is a tertiary care hospital. So what we can afford is we can get skim milk powder from around here. So we add it. Yes, supplements we are adding weight reducing supplements and all, but not to each and every one. Then there are soya based feeds also with protein supplements. So all these 1 liter at least gives 1 liter at least gives 16 to 1800 kilocalories and 60 grams of protein. So that way. Then
So assessment of these kinds of patients with suffering from dysphagia is similar to a normal person which we are seeing into
Assessment in the sense what personally I do is like if it is a 2000 kilocalorie diet, so 1000 calories at least or 55% has to be from carbohydrates. It becomes 275 grams of carbohydrates. 15% has to be from protein, 75 grams of protein. These numbers should come automatically in your mind. You should not have a pen or a paper or an book to see that. I mean, it should be so automatized. If fat, then rest of the percentage from fat, it comes to around about 33 to 35 grams of visible fat. Now concentrate on carbohydrates. Yes, if you concentrate on carbohydrates, क्या क्या है? अनाज, उसमें क्या दे सकते हो? सूजी दे सकते हो, दलिया दे सकते हो, custard दे सकते हो. If you have some, ragi or something, you can get that. साबूदाना को भी आप उसको करके because it sticks. So if your the audiology being says or the swallow SLP person says that it is okay, then that you have to synchronize with that. Then carbohydrates, अगर 275 है divided into 3 to 5 this thing. So this is a calculation. It will be very quick and you will know. राशन पानी सारा उनको भी बता दो कि भाई ये राशन है पूरे दिन का इनका अब इनके केयर गिवर्स will make sure that at least 75% of it is inside the patient. Similarly, protein 75 grams. So that way, I told you about the skim milk powder. I told you about the eggnog. Then some, of course, ONS we have to use somewhere. So that way you can moong dal halwa. I told
So
you.
you need to actually convey that for the nutritional adequacy, we need to might require a requirement for an ONS also. But
omega-3 fatty acids, please don't forget that. Flaxseed oils you can add. Fish oil is not palatable and it smells. So, flaxseed oil is the best.
so whatever
fat.
the best things which are being suitable into your areas, local areas, and what best you can extract from that, that has to be utilized into it. Basically, we are setting a new set of rules for such patients. We need to be very much empathetic towards these people. So we need to think from that point only how we can include those foods which they love to eat. Srimati wants to add on to something.
One thing I want to add is you're already giving a 200 ml feed and you're trying for the patient. Everything goes to the same place. Psychologically, he's full. Do you think it will be easier? It is just like feeding a kid. Geriatrics are also kids.
Yes.
So what I'm saying is when you're trying to give her, when do you try the dysphagia urate food? What do you think? You have to give it before the feed when he's hungry so that he will also eat before. You cannot give 200 ml to 50 ml feed and then flush it again with water 200 plus 50 ml to 50 ml feed and then you're going to try that 5 times foods. It is time for the feed. Try to give it first in a different consistency. The same kanji, the porridge can be given in 2 different consistency. One in a shaker which can be poured through the tube. The other one in a whatever the thickened way you're going to give it. Ask them to try that 8 to 10 spoons first and then try to give the feed. Afterwards, depending on the adequacy of this, maybe they can delay it after some time. Or at least he has tried it. When he's hungry, he's going to cooperate better and he's really hungry and he's going to eat. So these are the small things you have to train the nurses to do it. The genuine thing is we need to make sure he's eating and the tube is off. That is the main thing.
So the important point before recommending anything, we need to see the impact of it, how it is going to impact onto the patient's life, emotionally, and as such, he needs to be satisfied with the food. So if he's not satisfied with the food, he would not be able to follow your instructions also. And also need to take care of the caregivers also who are going to feed him. That is a most important point. And my question goes to Kaustav. You want to add something? Yes.
We have a huge population of dysphagia patients. So I would like to ask, has anyone heard about phagophobia? Phagophobia. So basically, this is a fear of food, fear of eating food. So ma'am has just mentioned about a patient who was reluctant to eat. So we came across this kind of population also. So we have to devise some unconventional ways to make it. All the assessments will be normal, but the patient will say, no, I feel like I'm choking.
I would like to add one thing. Practically what I say, patients love that Cerelac seed. So, and if you see, it has a good lot of caffeine and protein. So, and I remember my parents' days. So, and this is now, I mean, if I get that taste, I really love it. So, I mean, I've seen people loving that Cerelac. So, you can always experiment with baby foods, and they have good amount of calories. If you don't add water, don't add milk and make it. So it goes down very well.
And some patients from eastern side prefer sattu.
Yes.
Water. So this is also gajar ka halwa, ghee ka halwa, all this matlab moong dal halwa, sweet potato, kheer and halwa.
So, Kaustav, I wanted to understand from you, how do you decide, like, when we are seeing the difficulty in patients, so even the texture way, it is not feasible. So, how do you decide for the PEG or the NGT?
It's a good question. And actually, there's always been a thing like PEG versus NGT.
Mm.
So, if I feel that after the assessment and everything, if I start the patient on oral feeds and if I feel the patient would recover from, I mean, he would be able to eat 60 to 75% of the feed orally, then we can go for planning removing the NGT tube. NG tube. So, PEG tube is basically recommended when a patient, when we feel that the patient require other mode of nutrition.
So
Other
that means
mode of
that the
feeding.
different texture diets are not suitable for
Any texture of diet is
Any
not suitable
texture.
for the patient.
So then you-
And if it exceeds, like if I feel if a patient won't be able to eat for longer than 4 months or
Okay.
5 months, then we can go ahead with the PEG because PEG is a much more better option than NGT for a longer period of
So
time.
what sort of patients are being specifically rooted into this?
I would say a lot of patients are diffuse axonal injury patients. Their prognosis is very poor. They might take a longer term. Then, as I mentioned about one patient, I was
Yes.
seeing that patient in
Okay. Great.
at first, corrosive injury patients also sometimes take a longer period of time, and some patients does not. We cannot start even orally for the lifetime. So,
Okay.
whenever we feel that the patient would require more than 6 months of time, then we can recommend for patient.
So, Mr. Shiv Shankar, would you like to highlight something like while we are taking up the patients for NGT or PEG? So, you being from the nutrition side, how do you decide on to the nutrition adequacy into these things? What kind of recommendations from the nutrition recommendations for such patients?
That's a huge challenge. The compliance. You can plan 2000 calories, 80 grams of protein, but how much the patient is taking, you are never sure of how much the patient would be compatible with and whether the support system is available for the patient as well or not. So what we do is like we try to understand when the patient comes for the follow-ups and is continuously losing the weight. Try to understand what is the reason. Is it the support system? Is it the non-compliance of the patient himself, psychological issues, or is it the financial aspect, or what it can be? So accordingly, you have to come out with a solution for that. Most of the time, the compliance is poor because every time you can't, every 2 hours, it's very difficult to make a feed and the attendant to come and feed the patient. So again, an extra person is required over there. We tell the patient that you don't have to depend upon anyone for your feeds. One thing, it's so easy. You can make your own feeds, and there are many means. Not exactly you have to go to the kitchen and make the feed, put it in the mixer, and every time you don't have. There are many other options are also available over there, and we have given a number of options in the diet charts as well. And the issue with skipping of the feeds is it becomes more important when there is no consistency in the calorific values. If you are going to plan 8 feeds, if all 8 feeds are going to give 2000 to 250 calories and 10 grams of protein, in calculation, it is so simple 2000 calories, 80 grams of protein, you have planned.
Yes.
If the patient misses out on 1 or 2 feeds, doesn't matter ki what counseling you are going to do. You are going to tell the patient to see that in the night, during the night time, you can add a feed over there or not. If you have some feeds giving around 12 to 15 grams of protein and one feed giving you around 4 to 5 grams of protein, and the patient is missing the 15 grams of protein feed every time, or maybe most of the time, still you are doing the wrong thing over.
Yes.
So we keep on telling that even if you miss out the feed, all the dietitians have been very well told that you have to equalize the feeds and see that if the patient is missing the feeds, night time they can really utilize. At least for washroom, they are going to get up in the middle of the night. They can keep the feeds next to them. Feeding themselves is not actually a difficult thing for an NGT tube. It's not even the PET tube is also not that difficult. They don't have to really wake up someone to feed themselves. So these are some of the things what we keep on telling. And the compliance goes poor if the first feed of the day gets delayed. So simple it is. So we tell them ki if you miss that 7 o'clock or 6 o'clock of feed, I don't mind you taking at 5 o'clock in the morning. The first thing you do, don't do any other work. First you take the feed. Thereafter you go for walking, you get yourself freshen up and other things. But if that gets delayed, you are not able to meet even the 7 feet throughout the day.
And not able to meet the cut. Yes.
Yeah.
So can I add on to that?
Yeah.
So the main thing is this is in a cancer scenario where they can feed. If it is a stroke patient where he's paralyzed and bedridden and traumatic brain injury and other things. So what I want to tell you is 8 feeds is a given. But when they come for a follow-up, the patient would be sarcopenic, muscle loss, too much bed sores maybe, and all that. So you need to really emphasize on the 8 feeds. I get very mad if they even miss 1 feed. Why I'll tell you is if you say you can't miss even 1 feed, they'll miss 1 feed, it's okay. 7 feeds. And after that, when there are visitors who comes to see the bedridden patient or whatever it is, in the end, what they will say is, I had a patient who was about 40 and had some neurological disease and he was on rice tube. The influence that the visitors have, the relatives had is completely true. So they started with a wheatgrass juice. Then they spoke about, I never give a fruit juice in any of my feeds. For me, every feed is important because the fruit juice, zero protein. Please don't give any fruit juice. Zero. Antioxidants can be given after blending it with a different fruit puree, your whey protein, your skim milk powder, and everything. Pomegranate juice, red in color, increases blood. Then they will say wheatgrass juice. This is great for the brain. Then what happens is, so by the time that patient came back to me, I had to admit him only for nutritional rehabilitation. Nutritional rehab. I requested the neuro to say, sir, put him inside for me for at least 2 weeks, then we will do it. Because he was so young, and when I spoke to the wife, it was wheatgrass juice, it was pomegranate juice, aloe vera juice, because to had the grade 1 bed, so it was starting, somebody said it's great for the skin. And by the time when they had it, it was, though I had counseled it for the 8 feeds, 5 feeds were going, and in that 3 feeds were nil protein. So you can imagine how the patient comes. So you need to be understand the practical thing. So morning there will be, when Shiva mentioned, the first feed should be definitely given, because once you start correctly, you tend to at least have it 90% of the time. 8 feeds, 7 feeds will go. When you start late, everything, but there are practical issues. There would be, the patient would have passed motion, then there would be physiotherapy visit because they're paying 1,000 rupees for the physiotherapist to come at a particular time to do that thing. But so you need to talk to them about that. Okay, there will be a bed routine in the morning. So as he said, start at 5:30, no problem.
So it's very important that they should not miss out any of the feed.
Any feed.
And this is a very common scenario in the hospital too, because when they have been taking up for the test, almost like 4 to 5 hours have been gone in that only, and they are missing out almost 2 to 3 feeds into that.
Yeah, totally agree. And neuro patient, we don't feed after 10:30 most of the time, because there is a risk of aspiration. Most of them are geriatric, not like a cancer where you can compensate it in a late at night, because the risk of aspiration is more. The attenders sleep off, they won't know when he's coughing, and they're here to give it at the 45 degrees in a bedridden patient. So start in the morning correctly, even if it is 5:30. Even if you can't make the kanji and bring it to the room temperature, take the ONS, that many scoops, that much water, warm water, pour it first. So the first time you start correctly, you end correctly. That's my practical.
Okay, so we have some. Please write your questions. Please write your questions and give it to me. I'm already holding the paper for many of the people. So these are the open questions I'm just sharing because we have the dietitian, we have this fellow therapist, and the doctor over here. So the question is like, first I would ask about the nutrition itself. Can desi feed, that means the normal blenderized feed, can completely replace the artificial feeds? In terms of everything, we need to. Who would take the question? Shiva is going to take the question.
Because I have many cases.
Yes. So we need a very clear, crisp answer to this about the nutritional adequacy. Will it be able to focus on the requirements of the? Yes.
The answer is very positive.
Okay.
Not necessarily you have to depend upon awareness. Maybe in some of the presentations, if you are following my presentations, at one time I'm going to present at least 4 to 5 patients without any ONS. They're just not maintained. They put on the weight as well, and the muscle mass, they have put on the muscle symptom. I was told to speak against the ONS in one of the conferences which happened in this year in the month of March in Mumbai, and it was totally a lost battle what people were thinking about before I started talking to the presenting to the audience. And I did challenge that one. Even if you want that, any kind of a feed with equal consistency without the ONS. I say that ONS is more idealistic, but that doesn't undermine your home feeds. That we need to really work it out. The question was like how you are going to manage with the throughout the day and number of days and maybe number of months. A patient normally, there are many patients who are on NGT feeds for 8 months, 10 months, even for a year as well. Even if you have a coffee vending machine kind of a thing, and you have your preparation at home, which you normally make for a child, so that itself can be utilized with a kind of a machine where you just put that much of spoons, just soybean powder this much, skim milk powder this much, cereals powder this much. You have the preparation made over there. Again, here there is a technology intervention over there. But there are many patients who only on milk. I have the photographs where the patient has written over there. Other than milk, I don't take anything. At the max, the dal soup and the cereal preparation, whatever is the part. And he, if you see his weight and the way he has maintained and is so confident. So nowhere he was affordable for the wellness, but yes, he had the tabela. That was the advantage over there. But underlining point is that yes, we can definitely manage. ONS is not the only answer. Yes, it's the best, but you have the alternative available for.
So blenderized feed, from your point of view, they are going to they're equally capable of taking care for the nutrition content, like while it by the micronutrients part or protein parts or the
Yes,
irrespective of the digestion part,
what we do,
the absorption part or something.
See, if the patient is taking through the NGT, your the entire digestive system is available for you. If you're feeding into the jejunum, then you, okay, little bit of concern will be there. Then you have to really think about it, how far we can go. The counseling and the recommendations, what you do has to be very liberal. And if you are going to tell that you have to take only these things, that's a difficulties. But you tell them that you take whatever the normal feeds you are taking, but add this much of the amount to your normal feeds. Once you come to know, say for example, we have a very standard kind of a thing. Every 60 kg patients, we always tell one handful of almond and walnut. That happens to be again 50 grams. A big hand, I would say. So taking those 50 grams of dry fruits, adding to your feed, you are automatically going to increase around 300 to 500 calories depending upon what you are going to use it, and again 15 to 20 grams of proteins. And along with that, all micronutrients are also coming. So what you tell them, every time if they are going to blenderize the khichdi only, yes, there will be some deficiency.
So I think we do not have any set protocols for the blenderized feeds, because in every units from various, if we talk about various institutes throughout India also, so we have the different types of blenderized feeds which have been used, and I have like personal experiences with many of the hospitals while I was doing audit for them for the kitchen and all. So I couldn't. There has to be some kind of standardization protocol. I think IPEN can work on to that also.
So nice.
Yes, that's a point which came into my mind immediately.
And it will be done.
Yes, because I've been seeing the practicing people been doing those kinds of blenderized feed which actually cannot cater to the requirements. The nutritional adequacy is not been met with those.
Yeah,
So
but
they've
there
been
must be different cultural
Yes.
backgrounds. People will use ragi
Yes.
and people will
Education
use
is very important into this, because
That's
we
why
have
we cannot tell that
Yeah,
you
it has to be
use
cultural.
rice and you use these vegetables.
Yeah.
Give the flexibility.
Yes.
You can use any of these, but
Localized
this much of
things.
amount you have to use it.
Yes.
So you are addressing. Yes, yes.
Yes, yes. With the localized kind of a thing which has been. You won't believe that I have been, while I've been doing an audit, I came across a blenderized feed which was using a glucose biscuit, 4 glucose biscuit into a milk. So how would that go to? I was totally amazed.
If trans fats instead.
Yes, the question was correct from yes.
Also true other way around, that the artificial preparations can really completely supplement or completely replace the basic feeds.
They can completely replace also if the feasibility is there, sir. Affordability and other parts need to be taken care.
In critical care,
Yes.
it is the norm now.
Yeah.
So there
It's
you
a
don't
norm.
use any blender.
So is there any study which has compared this desi blenderized feeds?
Yes,
with
sir.
the
There are
traditional-
studies. There are many studies. There are many studies.
Indian studies we have.
Yes,
There are
not
very
much
few, one or
Indian, but
two
we
studies
have
are
many
there.
studies into
What
this.
they say?
They have always been ONS has always been kept on the upper side into all these.
The questions come over there and
Yes,
try
sir.
to
That is
answer
what I
But
initially.
what Shiva is saying is right. If you just do blenderized khichdi, it's not going to get it. But there is a lot of lactose
I-
intolerance. There are a lot of food fats with dahi nahi dena. So it does become difficult to
Yes.
achieve 100 grams
Yes,
of feed
yes.
if you're looking at 1.2.
So
and
that is where
1.5.
this point came across, na, the standardization of.
Gluten are not a concern for Indian population.
No, but
To be very
in a neuro, I cannot give milk. They are lactose intolerant
they-
in the sense in a geriatric. They
Yeah.
go
So we need to
into
have an.
severe. They have bloating. They don't digest, and the other thing is they have diarrhea also.
I would
They
go
do
with
have.
a mixture
So, sir,
of
actually in
both.
India,
So I like
blenderized
that
feed
you
needs to be
blend
much more standardized. There needs to be some set protocols for that. Because everyone in their institutes have been using a very different kind
there are
of.
very simple tests to know which patient has gluten problem, which patient
Yes.
Yeah, yeah,
lactose
that's been
intolerance.
there.
They already have so much of antibiotics, they will have lactose intolerance.
No,
And
for
raw egg is
bedridden,
also out, so I would not give eggnog to my patients.
Yes, I
There
got
is a lot of.
Yeah, yeah.
So I would do a very fine mixing of ONS with blenderized. I don't think we should just say.
And most important is the emotional part also comes over here also into the feed, because all the caregivers want to have their normal local food. They want to give juices, they want to give fruits, which actually is not going to provide that nourishment to the patient.
Yeah, just
Practical
1 minute,
issues.
I'll give you very funny example. One of my patients who is on feeding genostomy. Now, this boy, whenever his mother gives him to give feeding genostomy feed, he will say that no, 2 to 4 p.m. you have to give me this feed. This blended khichdi, mutton, and all this you need to give this. Morning you need to give idli and ye all mixed up blended to me. And what does it show? That this guy is mentally prepared to this type of food. And all of our digestion and feeding problem are controlled by the center.
Yes.
Goes down. So one of my questions there was whether whenever we give a tube feed, can you give some ham feed to this guy? That give something to chew, and while the tube feed is on, so that he's more satisfied. With good hormones, they start flowing, and they are good for his body.
So I think that
That is
has
the area
always
of
been there if the patient is allowed to eat orally, sir. That's
no, he's not allowed to eat orally. He'll just chew
chew
and
it
throw
and
it away.
throw it up. Yes.
I mean, aromatherapy can help over here, I think.
Yes.
If I'd like to add one thing,
Yeah, yeah.
I've actually done a study now in hospitals where people think chicken soup is so healthy. You make a chicken soup and sieve it, you will realize if you've used 100 grams, 85 grams will be on the sieve.
See.
I
Yes.
had a patient who actually lost weight because he thought he's doing chicken soup. Then I showed him, show me what's left on the sieve. This patient was from Dhaka. What are you doing for this patient? Or boiled eggs into a feed because I told him raw nahi dena. It's all left in the sieve. If you actually do the calculation of a khichdi, you actually only achieve 10 grams of dal, and that's the only thing that goes into it to get it the right consistency. I don't think we can achieve 100 grams till you actually use some 100, 120 grams is impossible in doing it.
So we have one more question. I would.
Teach them, but I don't think we should have a mind block.
Yeah.
And all of them do have a lactose intolerance. So
Okay.
खांसी होती है, बलगम होती है, दही नहीं देना. That's the only thing which will achieve a
No, ma'am, that's a psychological thing. Like dahi की feed लेंगे तो खांसी
हाँ,
होगी,
so
psychological. And coconut water is taken
ठंडा हो जाएगा, नींबू भी ठंडा.
coconut water is
Kiwi
Yeah,
and
please.
beetroot से तो
It's working?
hemoglobin गाढ़ा हो जाने वाला है.
No,
No raw eggs.
stopped around 12 to 15 years back.
Yeah.
Nowhere
No protocol
at
for
any time
raw.
we even recommend the undercooked one. Not to food it.
Yeah, Sreemathy, you were adding on to something.
Answering your question regarding the
But
GI.
raw eggs we never give.
So let's listen to what Sreemathy has been adding on. Yeah, Sreemathy.
So the GI, yes, when they are in the jejunal feeds, they can do it. But for a neuro where the risk of aspiration, they can't. But as you said, we can give some puree thing and they can spit it out or whatever it is. For even some consistency, a few spoons can go for the jejunal, for the psychological. As you said, the gut and the brain is connected. Definitely, it really helps in the hormonal thing and other things. But for a neuro, where the risk of aspiration is very high and they have told that they cannot give it at all. Yes, we give only these things, and lactose intolerance is very common in a neuro. So we don't give milk in a sense that because most of them are bedridden, their digestive because of the gut and the brain connection. their digestion is really impaired. So we don't give milk at all. Maybe give it in the form of skimmed milk powder and other things. In the ICU, it's only scientific feeds and continuous feeds and not a blend rice feed in the ICU. Once they come to the ward, yes, then we start.
With the aging
Next part of my question was to Kaustav. Actually, with bedridden patients, is there any technique for suppose the person is paralyzed below the chest? So naturally swallowing is fine, but he is bedridden. Is there any technique to particular technique to feed them or tell them to take care while swallowing?
So this will all depend on the assessment that we have done. And if we feel the patient is not aspirating, then we can simply make the patient in an upright position and we can feed the
We
patient.
can, yes. So next question is maybe Dr. Neetu like to answer it. Like, do you have any swallowing concerns been seeing in post head and neck cancer surgery patients?
Headache is the area where the major concern is dysphagia and odynophagia. So we see during treatment, from the beginning, we see the first complaint could be difficulty in swallowing, like in base of tongue and pharyngeal cancers, I said. Then during the treatment, even after first week of treatment, some grade of dysphagia starts, which they may, with some difficulty, they may continue, and we try to pull on for at least 3 to 4 weeks, and then only we ask for some kind of NG tube. I personally do not prefer NG tube because of the dependence. One thing, because it is very difficult to pull them out of. Okay. Okay. So it is very difficult to take it out. Patient becomes dependent on NG tube, and another thing is because of the muscle atrophy, the swallowing reflexes becomes poor. So after that, they require a lot of physiotherapy and lot of training to get back the normal diet. And in chronic phases of treatment, also there could be some neurological damage, or there could be some what you say strictures and fibrosis, which may lead to long-term toxicity of dysphagia, which may require constant dilatation, Buji, and maybe dependence on some kind of assisted feeding. So in head and neck cancers and esophageal cancers mainly, we see these kind of problems which can continue for longer period, maybe after 2 or 3 years, also after the treatment is over.
So my next question can be taken up by any. I was eager, so sir, I have taken up this question in initial phase only. So alcohol demands in dysphagia patients. No, it's a
Yeah, dries up the. I mean, you can't say yes to it. Definitely, it'll dry the. It'll make
Shiva
the
has
swallowing
something to
good. Something good.
We had one alcoholic patient, and with the consent of the treating doctor, we did allow him.
Oh my God.
With the immediate
Doctor withdrawal.
we cannot really make a statement over here. So it's just for the just a casual statement.
So, sir has to say something about it.
Sir, please.
Aerated drinks have been allowed?
No.
No aerated drinks, sir. Because otherwise also the carbonated drinks would,
It will cause a lot of
yes,
pain and
the swallowing issue will be, yes,
regurgitation,
that,
burping,
yes, that will be,
gastric motility.
yeah. Yeah.
I would like to add one point to sir's question, sir. You asked about specific maneuvers and techniques, right, sir? So, yes, sir. In some cases, when we do the assessment, we do video fluoroscopy or P's, we also try the maneuvers and other compensatory strategies. Say head tilt, head turn, head back, chin down, and even supraglottic swallow. That is an airway protective maneuver. Then Mendelssohn maneuver. Then all those maneuvers we try. If we feel the patient is benefiting from those maneuvers, definitely will recommend the patient with those any specific suggestions.
The next question is like either Kaustav or Sreemathy can take this thing. If there have been, what kind of problems, if you have ever faced for a mentally challenged boys, like if for this dysphagia part only.
Ma'am, the problem that sometimes we have to tell the patient to follow certain maneuvers. There's a certain steps like for supraglottic swallow, the patient has to take a deep breath and hold the swallow.
Okay.
Then while holding the breath, he has to swallow. He or she has to swallow. So in some cases, we are not able to make the patient understand what he or she has to do. So yeah, definitely, ma'am, we do face problems in part of the cognitive thing.
So in such cases, how do you handle these patients? Then what is your?
We can depend upon the consistency management. We can depend upon some other postural changes like we pull his head and tilt to the turn or tilt it to the side wherever the patient is able to swallow. That's it.
So the next question which you have asked, sir, it is pregnant dysphagia patient you are specifically asking?
Advanced stage of pregnancy, if you have to give them enteral feed or liquid nutrition, so any special care for them?
The cause of
So-
dysphagia, sir, in pregnancy, are you
Yes.
talking about GERD, which is too much? Or
Yes, in which they are in later age, last trimester and all.
Last
They're not able
trimester,
to, yes.
because of
One,
that GERD.
and those people who get pregnancy after being operated, for example, corrosive injections, they are young ladies.
Okay.
They don't want to have pregnancy after that.
Okay.
So, is there any concern people so far as the nutrition is concerned?
From the nutrition part.
Definitely, sir. There would be a lot of nutritional inadequacy, micronutrient wise also. They will be only taking a very, very limited restricted foods and other things. Maybe there are some tools where you can get those thickened fluids which can be controlled how it is flowing into the mouth. So, for example, when an 8-month-old has those sippers with both the handles, and then they try to control the amount of fluid that is going in, that is one of the things which we can see. That there are shakers which are available, which has a bigger spout, which is thick, and you can see it is not only thickened fluids can go in, so we can tell about the consistency depending on the amount of skim milk powder or the ONS, whichever they are doing, and then we are giving. So we need to make sure that whatever they are eating in between those nutrient dense thickened fluids has to be given, which can give extra protein so that the compromised the growth of the fetus is not compromised.
In patients, especially particularly for students, I need to say that those patients who have dysphagia associated with reflux. For example, in surgical tooth, we operate the patients and then suppose we take out in carcinoma esophagus, we take out the esophagus completely and join the stomach to the neck. And then there is some problem with the anastomosis joining, then they develop partial dysphagia. And at the same time, because we don't have any sphincter down below, then you have reflux.
Yes.
So after feed, they should ensure that the patient for 2 hours the 3 hours takes gastric emptying. So for 2 to 3 hours, they should not lie down.
Yes.
They should move around and they should not mix liquids with solids. Those are the advices they have to take. And if a patient can afford, there are recliners available in the market. And they
Yes.
can adjust at 15 degree by eating, and it becomes otherwise sometimes it becomes very difficult to give them off with their special be and let them create a cumbersome process.
Yes, and there are some body pillows are also available which are fully that helps also.
So one of the question I would take, she's Sonika Khanna. She's present over here. Okay. So she has specially asked, like, can we use sprouted wheat or cereal grains flour to maintain the consistency or the fluidity upon cooling the food? So, like as for the 4D printing.
Yes,
We can use, definitely.
yeah, definitely you can use it. There's nothing. I don't see any contradictory matter over there.
And one more question. This is also by you only?
Yeah,
All these. Okay. So she's also eager to know that do all of us present over here think that we need to integrate homeopathy, naturopathy, Ayurveda along with dietetics specifically for dysphagia?
I'm not in favor of that.
No, we cannot have a common comment like that.
Very difficult.
You Ayurveda, the first thing you'll stop is curd. And milk. You don't know where to start from.
So each one has its own
Yes.
science.
Science
Homeopathy
with
has a completely different science.
But
We cannot.
I had attended a webinar of American Medical Association wherein the oncology department had specifically mentioned all the homeopathic
Yes, they
medicines, etc., to control the esophageal reflux that they are having in oncology patients and other patients, so that their food gets down the guts easily and it eases digestion. So that's where my curiosity came, because I keep on doing researches and also.
See, if you
Yeah.
are,
So can we intervene such medicines that have that can stabilize the food within food intake and can help in digestion?
So only if like someone has gone through.
he will debate on that. But see, there is one part, for example, dysphagia or no dysphagia. I'm just talking about the, like if we say ki, okay, put haldi in milk and have, so it is redundant if you don't put a pinch of black pepper and a little bit of fat, or it has to be a full fat milk, because the curcumin the bioavailability will not be there. So this is a truth. So, there is a truth, but then you just extract that truth instead of just making a story out of it that it will do this and that. But yes, if you want to have curcumin and if you want to have that antioxidant and anti-inflammatory thing, you have to add a pinch of black pepper plus a little bit of fat to make it bioavailable. So, this is science.
If
The question was,
I'm the person to address. Yesterday, I just completed a 2009 program on this. There was a homeopathic specialist alongside me, and we discussed about this. The, we call them are prokinetic agents. Prokinetic agents, they control the peristalsis for propagation of the food forwards. At the same time, they relax as they go on, if you goes on, they go on relaxing the sphincters in a controlled manner. So you might have heard about nigrosulfuride, the etopride. So all these are prokinetics, which we used to tell the patient to take. Obviously, the dietitian knows about it and we have prescribed. You have to see that half an hour before they giving the feed, this thing has to be given if it has been. Similar things are also there in homeopathic as well as allopathy. There are certain foods they claim that they increase peristalsis of the gut and move propagation. I want what to comment on this because it's a completely separate science. What we discussed is allopathy, Ayurvedic, all these are not essentially desi dawai. These are also internationally things that have come up from Germany and all those areas, and they are really effective. And how much effective I can't say, but you should not practice yourself. You haven't been prescribed because you will be really responsible.
Correct.
Especially, like for example, so commonly used pan L, pantosid L, T, like that. All these have a very potential effect on the heart. So, if you are giving these medicines, you must know that the patient is not having symptoms. Yes. Go by the experts advice. You start, they are there. Flux is there. Who are like in diabetes, the instance is very less. There, these things do. Definitely. Not in all cases. And it's not required. If the patient is okay, then suppose a patient who has a stroke, everything is fine. That should be given. Unless you see that he's having lots of gas, protein,
yeah, in similar lines.
I think hospitals are merging the two science. I know hospitals who are getting Ayurveda consultants to the hospital. Homeopathic is available in hospitals. I'm not taking names of hospitals, but it's a science, absolutely science. I'm an ardent follower of homeopathic. जो एलोपैथिक नहीं सॉल्व कर सकता वो होम्योपैथिक नहीं इलाज है. Let's not. I think
the choice has to be.
Yes.
The choice has to be the patient.
Yeah. So there are different sciences basically.
The question is, the question is,
you have a merger of the two sciences.
ma'am,
So we are seeing right now also we are different types of people being.
mixing two therapies is a questionable thing.
Yes, yes.
But
yes.
mixing some kind of an element which is proven to be beneficial,
Yes.
then you cannot call it as a therapy. For example, even the curcumin is Ayurvedic only identified.
Yes, and been
thing.
widely used for the
There is
cancer
nothing
patients.
wrong in using that over
Yes,
here. But you are going to use it as a homeotherapy, then mix up with our own therapy, then the diet therapy, then the
No,
allopathic.
but Shiva, don't we use Karela and
Yes.
AC seeds for our diabetics? So what is that?
Exactly.
That is
So,
Ayurveda.
and they have to be tested first. I
There-
stated
there
one
are
of the
studies on
studies which have come out like that, which has to be made public and more trial has to be done. Then you can adopt.
but they are not curative as
See,
such.
the
Not
thing
sure
is,
if they have-
Secondly,
They're supportive.
You're not saying it's profit.
Yeah.
No, no.
Yeah.
see,
See, there's
Americans
one more
will-
reservation. One statement I'll make. That's it. There's one more reservation. Keep in mind that herbs are very much contradictory in cancer patients undergoing chemotherapy.
Yes,
So
yes.
anything you would like to try, have a word with the consultant, or else you will be blamed for everything. Whether it's a good thing happening for the patient or bad, but definitely you'll be blamed. So that is why it's better that if you're going to use anything out of your normal practice. I was called by one of very senior consultant because I used Isabgol. And when I justified, it's not a Ayurvedic product. You are questioning me for the do you have any Ayurvedic background or what? Why did you recommend? It's not an Ayurvedic therapy I was using. I was using one element which is proven to be curing the not curing addressing the question of the constipation. So that's how you are going to incorporate certain kind of an element, not as a therapy.
Actually, this Isabel thing, the same I was also questioned because, the patient, the immunosuppressive drugs, the doctor told me that, the unka kam ho jata hai,
Get absorbed.
so, yeah, I mean, you can't give them, so it was that then I justified because when I calculated his fiber intake, it was too low. So then he was satisfied. But you can't, because the Indian diet is good in fiber. So if the fiber is okay and over and above, you should not give, more of it because it can have an effect on the effect of the immunosuppressive drug. So this is what.
the other thing is, Americans will say St. John's wort or ginseng or anything being there, I'm telling for so many years. For us, we are already practicing Ayurveda in the sense like night golden milk or whatever in a wellness patient itself. It is a part of our lifestyle. It's part of living. So I can tell you a thing. When I graduated, when my grandmother read it in Tamil, it was there, half of Tamil and half of English. She called her son, which is my father, and for this you sent her to college. Because it is a way of life. It said food science, dietetics, and food service management. So it said in Tamil, Sattunavu, Parimaradal, that means you're giving it,
Give it.
service. So she's like, for this you sent her to college. She scolded him. For this you sent her to college and graduate. So it was a part of life. So when the Americans are saying St. John's wort, ginseng, golden milk or whatever, curcumin, we are already doing it as a part of life. When there is a cold, we give it so and thing. But you can't see this is an Ayurvedic treatment I'm giving. We are telling that as traditional thing which we follow, we give a majjige, we give a buttermilk, we tell it for bloating, we give this, we give probiotic in the form of curd or something. It is part of our food system. So
Diet
the
itself,
Americans try to-
Srimati, diet itself means the way of life.
You know, Ayurveda doesn't have food recommendation itself. They don't have a dietetics part because Ayurveda is dietetics.
So
So is the Ayurveda.
I need to actually, sir, need
So
to
you
add.
cannot say that okay, we are giving like that. So don't talk about from the American point of view. We are
But,
giving only through food what can be.
Only a month back, you'll be surprised to know, and might be some of you knowing, that in America, turmeric milk was presented in a huge conference. As if it is
There was a news. Yes,
Their
No, I was
charges so
surprised
many
to
dollars
see
for
that they were
golden milk.
golden milk.
regarding the curcumin.
This is known as golden nectar.
Regarding the curcumin, I have the opportunity to do a research on this effect of curcumin on colorectal cancer.
Okay.
Curcumin has lots of effects.
Click a picture, please.
But I want to put a word of person.
Okay.
One capsule of curcumin, 500 milligram curcumin capsule is a product of 250 grams of turmeric.
Yes.
Can you eat 250 grams of turmeric?
No.
It's not. So whenever I give, half of my patients had to leave the trial because they were not tolerating the turmeric capsule. The curcumin capsule. because it is a very, very potential gastritis present, and you should be very careful in giving them. If the patient is complaining of gastritis, bloating, think that whether you are giving supplement to this patient. It's a very, very potent.
So we would like to wind up this panel discussion. We have lot many other questions also, but we have in the end group discussion. We have one more panel discussion. You can put up your questions again on sheet of paper and hand over to us. We will be meeting post lunch. It is 1:22, and we'll be joining together within half an hour. 12 minutes. 1:22 it is. So I can continue for another 10 minutes. 8 minutes. Okay. So he has given the permission, so we can go ahead. So we need to mind whatever the recommendations we are going to give, whatever the statements we are going to make it for the patient is going to have a huge impact on the complete life of a patient. So please be very careful while you are prescribing any kind of a thing, whether it is a homeopathic or any kind of a thing which needs to be in consultation with your doctor while the patient whom you are treating, that needs to be taken care of. With this, I will move with the next question. So the next question says, in neuro patients, how we can recognize early signs of dysphagia, because it starts with slowing peristaltic movement in gradually.
Early signs of dysphagia, ma'am.
Yes.
In most of the neurological patients, the thing they come up with is difficulty in swallowing pills. They will feel difficulty in swallowing tablet or a pill. And sometimes they might show distress. Sometimes they might show the choking feeling or cough. So all these are the signs that we look for. So immediately, if the patient is, if a neurological patient has any of these kind of symptoms, then they should get the assessment.
Dr. Neetu, you've mentioned about the different types of exercises, the physiotherapy to give relief about dysphagia. Initially, you have spoken about it, but can you throw some more light onto it? Like what kind of exercises and recommendations you normally follow for your patients?
Generally, I send my patients to our physiotherapist and solving expert, like we have Dr. Kaustav there, and they help our patients out. It is like swallowing the water, then throwing out. Then there is 100 ml test which they try to swallow, and there are some maneuvers which they try to do. Even for Christmas patients, like blowing the balloons and this popsicle sticks for opening the mouth, these kind of physiotherapy we advise. We generally send our patients to physiotherapists, and they carry out certain maneuvers to increase swallowing reflexes. And I think Dr. Costa would help me out with
So,
this.
ma'am, that we have been following a certain, we say, performer that we have in our institute. So there are almost 5 to 6 exercises which say the dysphagia management works in 2 ways: either direct therapy or indirect therapy. So direct therapy is when we mix the exercises with the food. Like, so I'll say patient has to swallow with holding his breath. So that comes into the direct therapy. Indirect therapy, if we prescribe them those exercises as a prophylactic thing. So we have like jaw range of motion exercises, tongue range of motion exercises,
Okay.
supraglottic swallow, Masako maneuver. So Masako maneuver is called, basically in general terms, called tongue hold maneuver. So where you have to hold the tongue between your teeth and then swallow. So there is a pressure
Do
that
you
is
follow for all types of dysphagia
Yes,
patients?
not all types, but it can be followed in all types,
It
mostly.
can. It can.
So if a patient who is undergoing radiotherapy, chemoradiotherapy,
Okay.
so this exercise, set of exercises are really beneficial for them for the short-term dysphagia thing, and also the long-term dysphagia complications that might occur later after 6 or 7 months.
So next question is related to nutrition. So anybody from nutrition can take this up. How do we ensure for the hydration part, the water intake part in such dysphagia patient?
I've already answered that in my presentation. So any more elaboration you can.
You
So
need
the
to
more
tell because
elaborate
it is a
question
specific question from sir only. So he needs to.
I did mention about that, the isocaloric is the way I go around. And if you're giving 2000 calories, it has to, you have to do at least 2000 ml of fluids along with that one. Maybe if you feel that it's during the summer season, we always tell them at least half a liter more they can still consume for that one. And if at all, if you are giving concentrated fluids, then extra water has to be still recommended. And if they have aspiration, what I showed you that during my presentation, that is
Yeah.
what I normally do. See, whenever you are drinking, see that it's in a liquid form, so that you get the nutrition also, and you get the
Hydration part also covered. Yes. So flavoring agents are in case of dysphagia patients while we've been.
Flavor fatigue does set in at many patients. So we keep on changing the flavors also at times.
How do you do that? Like,
But it's preferably it has a neutral flavor that is more preferable, so that they can mix up with any of their liking kind of preparations.
but flavoring agents as such, it is permissible for using into your
Flavoring
food
agent-
preparations or anything like.
No, additional we don't recommend anything.
Additionally, you
Additional
don't.
flavoring anything we don't recommend. Whatever the ONS might have, or anything which we are recommending with the original preparations, that only. Additionally, we don't recommend.
Okay, so they're not, guys, any kind of
We
a
have not tried that, but if someone has used, so
You
anyone
want
has
to-
used,
comment?
So artificial flavors we don't recommend, but if it is a natural flavor like a cinnamon powder, or if it's an
Elaichi or
elaichi
yes,
flavor
fennel
for a
or
moong dal
yes.
halwa, it can be. You know that our own governmental things outlets, they have essences which are natural. I found it in Kerala, Flavors of India. They have cardamom which is in the form of liquid. There are everything that is there which is authentic because it's from like a khadi type of thing, and it's available online. So, and it's form of a liquid.
Liquid essence.
So, yeah. And it's not an artificial essence like a vanilla.
It is a natural essence
Naturally,
extraction.
that has been, they've taken the extract and done. So there are different flavors that are available like that. So even a one drop in a moong dal halwa type of a cohesive consistency will have that extra thing. So naturally, we have a lot of spices. That's why we were invaded. So if you use that as the kitchen spices for different flavors as such, I think it will have better acceptance for these consistency.
So I have just 2 minutes to conclude. So the last question is like, we all are from the different fields. So what are the areas of research in this particular subject which are there and which are lacking? So one by one we can start on from here.
So, traditionally, what happens is, ma'am, when patients come for radiotherapy, go for radiotherapy, chemoradiotherapy, or say surgery, so they come to us after the treatment, coming with a lot of complications, like I have cough, I leaking, I have pain, I have like early complications and late complications. So what we have done is we are trying to regularize those visits early treatment. So during the CT simulation day or before the surgery, they plan a visit to us. We get the assessments done, and if required, also apply some of the manuals. And for chemoradiotherapy specifically, then we give those performers, set of exercises to them to follow throughout the treatment, and it has been beneficial to them. So there are a lot of undergoing researches going on, and we have been trying to apply aspiration prevention protocol also, which is currently undergoing in the institute.
Okay.
And also upcoming research we can do is on ultrasonographic study of swallow. So there are still researches going on.
Sreemathy.
As from the dietetics field, we are only now familiar with the term dysphagia. So we need to have what do you say, like a eat-and protocol or a swallowing checklist, nutrition and swallowing checklist first that has to be formulated. The other one is the interdepartmental communication where everyone can have the same chart. So when the SLP sees it, he will know the nutrition adequacy or whatever it is. So the interdepartment one document has to be formulated, which would help a lot in the cohesive. How do we manage the patient for the benefit of the patient?
Uh, as our nutritional therapists are so active, I think most of my challenges are being taken care of by you all people. Challenge for me is loss of taste and खाना खाने का मन नहीं करना. So there is no dysphagia as such, but they still do not eat because they do not feel like eating. So that is a challenge for me, and maybe you all can help it out with some new recipes or something.
Yes.
I feel is nutrition should be considered as a adjuvant therapy with any kind of a treatment which is undergoing.
Yes.
So it should not be a sporadic kind of a thing, nutrition will be given an attention. And nutrition is such a kind of a thing only the dietitian really cannot handle. There have to be multidisciplinary approach as well. But the treating consultant has to keep a follow up of the diet. He or she has to keep on asking whether you are following the dietitian's instruction or not, because it is something their verdict, their words are more impactful for any patient to come to the dietitians again. It's not a one-off kind of a thing. You took the diet. Yes, when the consultant are going to question them, we have the diet chart and we're following. But is there an impact of that one? The doctor has to really go through that one and again push the patient. No, no, I don't think this what going on is right. You have to have a frequent visit to the nutrition clinic and see that any modifications are required. So adjuvant therapy, it should be considered in that manner.
Yeah, I second him because when the nutritionist says anything and the doctor says some other thing, the patient always follows the doctor. So so it has to be in line both of the thing. Secondly, the teamwork is very important, and like Dr. Sreemathy, she put that the networking of all the areas, the nurses, the cardiology, the nutritionist, the doctors. It is extremely important and it is tough in a tertiary care hospital. If it is a small setting, it can be, but we find it very tough to, because the days, OTs, OPTs, they're so different. The round days, क्यों synchronization होना बहुत मुश्किल हो जाता है. Thirdly, I felt that this flavoring things which we were talking about, aromatherapy also helps like people. Some have you seen like when we enter a airport and there is a cinnamon bun type of a thing and we already start feeling hungry from the gate itself.
Yes.
That it smell. Maybe we had a full meal, still we feel hungry. So I've seen patients they do benefit from aromatherapy, maybe medicine or whatever they feel. I mean, some puja type of like chandan or this thing. So they feel good. It is all about good vibes and feel good factor. Food is all about emotions. And fourthly, my advice would be that to all the dietitians that please watch what you are telling them and you should know what you're instead of coconut water, it should be coconut milk.
Yes. So thank you for all the advices which you have given. I think delegates have been benefited by it. We need to be a lifelong learner. It's okay that we need to advocate certain things onto our patient, but it is okay to listen what patient wants to actually say. That is also equally. We need to know that we realize that everything is not flexible, but we can make it to some extent to be adjusted to our patient's needs. So with this, we close our panel. I'm really grateful and thankful for this wonderful discussion which we had, and it would be ongoing post lunch. It is 1:30. The people sitting on my left side will kill me if I'll not close. So thank you all. We'll be back over here in the hall by 2 p.m. But before we conclude this, I would request Anita ma'am to present mementos to our panelists.
Congratulations, Shilpa. Very well conducted and excellent panelists. So, three cheers for them. Yeah, so we shouldn't forget our paneer and our grated cheese in our feeds and roasted besan. Try and give them all those things. And give them a little tip. Yesterday only when I told the patient, make soup and put it in an ice tray and put it in the fridge and take out 2 cubes. She says, wow, I don't have to make a soup every day. So just make it very, very simple for them and identify with them and we won the battle.
That's all can you can also have a photograph. Yes. One by one, let's have a photograph first. Thank you, Sreemathy. Just wait. I'll take it. Acha, Anjali, you are clicking? Okay. You talk, I'm so motivated. Thank you, Mr. Shiv Shankar. They have been excellent presenters. And Kaustav, you were amazing. It was pleasure to have you. I would like to you to stay over here till the group discussion. Yeah.
And your CV says it, motivated.
So Dash is not there.
Good having you here.
Thank you, Dr. Neetu. If you request Dr. Neetu, you should stay back till the group discussion.
And she missed the flight.
No. Madam is from here only, na? She can stay back.
That's okay.
Is Dr. Dash here? Okay. No, ma'am ka reh gaya na. Ma'am. We need to really thank you. Yeah, Babu. I'm not ready for Dr. Dash. He was supposed to be here. Thank you so much. So we all will be back over here by 2 p.m. ये भी ले करेगा तो उसको फोन कर So, welcome you back all. I think you all had a good, sumptuous lunch. It will be difficult for us to keep the eye open, but I think the session which we are going to have will actually give us more, will be feeling more energetic with these talks which we are going to have now. For session two, we would like to invite our chairpersons. I would like to invite first Mr. Shiv Shankar. He is Vice President IPEN India, Vice President Asian Nutrition Society. Again, we introduced him. And our second chairperson is Dr. Sumant. So, Sir is Fellow Phonosurgery in Medanta. He is MCH from Head and Neck Surgery Oncology from AIIMS New Delhi, and he is also FHNO Fellowship Program Coordinator for MICC Max Vishali. Presently, he is Associate Consultant Department of Head and Neck Surgical Oncology, Max Institute of Cancer Care, Delhi NCR. And his expertise into general EAT procedures, head and neck oncology, skull base, airway surgeries, conservation, laryngeal surgeries, uh, laser, transoral, ultrasonic surgeries, rehabilitation. We welcome you, Dr. Sumant. So we have the speakers. First speaker we need to introduce. Yes.
It's really pleasure inviting me, my friend Sreemathy. She is the NEC member of India, IAPEN India, Chief Program Officer of Dysphagia Core Group. She is consultant nutritionist at Divine Mother and Child Health Program, consultant dietitian at Debra India, gut health dietitian at Dr. Digest Clinic. She has 23 years and above experiences in clinical dietetics. She has done her master in specialization in diet in health and disease, Cal State Northridge and Settle Pacific University. Nutrition and hospital dietetics, certificate course in community nutrition and sustainability development. She has done certified diabetes educator, certified bariatric nutritionist, certified SPAN LLL in critical care and GI nutrition. And she has publications in nutrition and biochemistry for nurses and textbook on for nurses. And then she has one more book, Neuro Nutrition book. Welcome, Sreemathy. And
Thank you so much. Thank you for the wonderful introduction, Shiva. Yeah, my topic post lunch is interdisciplinary management and role of textured dyes and thickeners. So, dysphagia is a truly debilitating condition. You can see that when they try to swallow, it is very, very difficult for them. That's why I put those both pins over there. And next slide, please. Yeah, so morning everyone spoke about dehydration and malnutrition. So here you can see that almost more than 30% malnutrition already. Sarcopenia is a big issue in our country, and also many studies are there that sarcopenia should be prevented. Aspiration, yes, there are also silent aspiration, and pneumonia is a risk, and also asphyxiation. So the thing is, morning we saw this, that as dietitians, what are the role? We need to make sure that along with the SLP team, we need to make sure it is a safe swallow. And the other one is, the goal is to prevent malnutrition and dehydration in the patient as an interdisciplinary role which we play. So higher risk for malnutrition, I'm talking, this is my 19-year-old traumatic brain injury patient who was in critical care shifted. You can see how much muscle he has lost, just a 19-year-old. Dysphagic patient are at particularly high risk of micro and macronutrient deficiency. So they don't like this altered consistency. You can see even an 8-9 month old, when after weaning from 6 months, you can see the blended diets which the mothers give, everything putting in a mixie because they take the vegetables out. They want to make sure everything is eaten by the child, and then the child lands up to be a picky eater if you don't introduce it in the right time. So the same thing here is, when you see everything in a brown color and all very, what do you say, mud type of consistency. And maybe first few days they'll eat and then they really become fatigued with the taste and the texture. Less nutrient dense means we are unable to give that much nutrient density, but we can do it. We look at it. Difficulties in tolerating large fluid volumes. They can only eat only to a certain extent. To maintain, so the goals of nutritional management to maintain and ensure adequate nutrition and hydration status, implement the correct and safe texture modified diet. So once the documentation is given by the swallowing therapist regarding what texture that can be given, and we can try to make sure that the correct and the safe texture is given to maximize nutritional intake while maintaining safe eating and to prevent aspiration and choking. Early detection of dysphagia with an appropriate nutritional support is very important, and we need to make sure, because this is an extended hospitalization and increased mortality because of this, we need to ensure that the interventions are at the right time and the follow-up is very, very important. Now, first we are talking about morning. We spoke about the dietitian's role. Now we are going to see that how it has evolved internationally and what from Indian point of view, what is the best we can do from the dysphagia point of view. So there was a national dysphagia diet internationally that was there, and the viscosity and the liquids. So when Shiva spoke in the morning, they spoke about the consistency, the viscosity. He also showed about the ketchup and the porridge, all that. So the way that is there, so thin, nectar-like, honey-like, and spoon-thick was the one that was there in the National Dysphagia diet. And there was so thin, there was a water, and then this was too generic even for the international standards, and they came up with the ITSE later on. So viscosity is only one of a number of relevant parameters of the liquid flow when it tries to come out. So there is a density, there is a yield stress, there is temperature, there is elasticity, there is propulsion pressure which is there. Drinks can be thickened with different thickening agents. I just want to ask you, what are the thickeners which you use in your setting? Okay. Corn flour, then? Guar gum. Okay. You get it as a paste. What is the consistency of the guar gum? A gel, a paste, what do you think? Is it like more like a peanut butter type of a spread? What is the consistency of the guar gum?
That depends. Generally, we get that the consistency in that gel form.
Gel form. Yeah. Anyone else other than the corn flour and the guar gum? Sattu. Yeah. Yeah. Basin. Anyone else using any other thickener? Okay. So drinks thickened with different thickening agents or naturally thick may have the same measurement or apparent viscosity, but they will have different flow characteristic in practice when it comes. We also saw that when it is made in the food and beverage department, when it comes to the bedside, what is the different things that can be there. The nature of the thickened drinks makes them impossible. You can't just say with only one viscosity measurement, especially for a diverse country like India, it is very difficult. So we need to talk the same language. When you say SGA, when you say NRS 2002, when we say that MNA for, so there is a standard which we follow. This many question, are there weight loss? We are asking GI symptoms. We are asking, is the patient GTC, as we say, is it inappropriate? All those things we are asking. Same thing, we need to come up with a checklist where we identify the patient, and then do the morning we show the EAPEN protocol. Like that, we need to talk the same language, including to the SLP, to the ENT, to the physiotherapist, to the respiratory therapist. In addition to variations in flow associated with drink characteristic, flow rates during swallowing also are expected to differ depending on a person's age and the level of impairment of swallowing function. So you can see that in a dementia patient, in a person that like an Alzheimer's, where they have cognitive impairment, they will even forget that they have eaten. So you would have just fed them. The nurses would have just fed them. Then when the attender or the caregiver comes, did you have lunch? She'll say, no, I've never had it all. This is an example from my mom's point of view. So she would have eaten just then, maybe half an hour. When I go to visit her, she'll say, my mom will say, no, I've never had anything from morning. My sister-in-law is starving me. She will say, because they cannot recognize, they don't remember. So when you have a cognitive impairment thing, it is very, very difficult for them to know whether they've eaten, whether they are full, their taste. Sometimes, yes, they are in and out of that thing. Sometimes they recognize you. So in a geriatric population, it's very difficult. When it comes to Parkinson's, it's a progressive thing. They have those different, as I told you, the levodopa and all the dopas to decrease their rigidity and their movements. So what happens is their constipation level is high. The protein intake has to be adjusted accordingly based on their medication, so it is better absorbed. And then what happens is, this is the other thing, is where you need to tell them the correct consistency where they can control, and they also want to be independent. So why standardization is important is, determine the number of food texture and drink thickness level. International standards, they are doing it. We'll talk about the H3, and whether you tell us, we can discuss, interact and say how is it feasible for India or not. Develop culturally sensitive standard names. The khichdi, the pongal, or even the same kanji, which is a ragi huri ittu in Karnataka, which will be a kanji porridge, a sattu in the east, and this, everything will be different. The grains will be different. The consistency will be different. So we need to see how to standardize for each region, not just because of the whole country like the West. Develop detailed definitions for each level of food texture and drink thickness. User friendly, definitely it should be inexpensive, because after how I came, one more thing is, I had developed a thickener, I will talk about it. One of the persons from a hospital called me to say, our hospitals cannot afford an imported thickener, which is about 3,500 rupees. One of the companies had it. Now I think they've launched it, but it was 3,500 rupees for a neuro patient. Definitely we cannot afford it. Make sure that if you can do something about it, we can do it. So it has to be definitely inexpensive. And when we spoke about the guar gum or the corn flour or whatever we are saying, it needs to be nutrient dense. So even if that 5 spoons they are having, from the nutritionist dietitian point of view, whatever we are giving, if we could give that 5 spoons to be more fiber rich, because constipation is very common in a neuro patient, and we need to make sure that, and they can't chew and eat if it is dysphagia, or whichever the dysphagia patient is. So we need to make sure that we have the same standardization, micronutrient, nutrient density, definitely inexpensive, easily accessible measurement methods. Morning we showed that syringe, you cannot wait for it to come through that. No F&B is going to do that for us. So for determining classification of food texture and thickened drinks. Now, when you order, this is a papaya puree. This is exactly when you order from the ward to try for a puree. See how it has come from the F&B. It's common. There are multiple textures here. So how will the patient swallow this for a dysphagia patient? Definitely they cannot swallow. So a lumpy puree. So we need to train the F&B. So we need to talk the same language is what. So that the standardization is there. This is multiple textures. He will not be able to do. This is papaya puree for dysphagia, which is very easy. These are original slab for me, which I've taken from my book, which I published. So papaya puree, it has to be, it is so nice and it is thick. It is like an alwa. It just goes down. And because of the taste, it is really nice. The aroma, the taste, little bit sweet, and they really like it when we give the papaya puree the first. And most of it is available, economical, easy for the F&B to store it also. Now, so the texture should be correctly defined for the F&B. And also we need to talk among dietitians itself. When we write it, we need to know what is the dysphagia diet that you're going to do. Examples of clear liquid, examples of thin liquid, nectar, thickened kanji, and the pureed diet and the soft diet, the blended soft diet, everything has to be. So among us, we need to know what we are expecting the F&B to give. Then we need to train it, and the nurses also should be aware. So now what happens is, texture correctly refined. There are more than 24 food textures have been identified. Only 8 of these textures are considered most significant in treating dysphagia. Now, monitor, very important, aware, prepare, and we need to adopt. Now, build awareness across facilities, sectors, to all impacted clinicians should know, professional association and their board. So we need, from an IAPEN India point of view, we need to have a standardized language. So we talk so that an interdisciplinary communication is also in the same way, communicate who, what, where, when, why, and how it can be done, how it can be impacted. So even when we try to convince a consultant, whether it's neuro, whether it's GI, whether it's any other neurodegenerative disease or anything that tender, we need to have a data. So he is taking better with this consistency. He is better hydrated. So we need to see how effective it is in your department, in your facility, and how it can be. So you'll also be convinced. Maybe you will get a better idea, and you can also share it with the fraternity in our country. Now, assess processes and protocols that may need to change. Morning we spoke about a checklist, and the other one is the having a same form where all the multidisciplinary can write their documents, so it is there in the same thing. Correct? So then train clinicians, stakeholders, all staff involved, including nurses and FNB. Now introduce new ITSI system, because we need to make sure that yes, they have certain standards, but we need to Indianize it and make sure what works for us. Okay. And so this is the ITSI protocol which I wanted to say. I've attended their thing. I've also got it certified. But the thing is, I thought it was personally, when I talk, even I've spoken many times with Shiva, because he also deals with dysphagia and cancer patients. We need to have an Indian standardization for the foods, because it's completely different. We don't have a folk test. Half the time we don't. 2 millimeter, 3 millimeter, all that will not work. As I said, we have region wise foods, so we need to do it for, if not every state first, at least start it for the 4 region, north, south, west, east. Okay, that is very important. So the ITSI framework, what they have done is the drinks which is thin, slightly thick, mildly thick, moderately thick, and extremely thick. And when the last slide Shiva showed what the Indian diets were, so it was had some common things. So we need to see that what are the common 8 to 10 foods which we give for each consistency. Try to see how to Indian standardize it for each region, and then we will have some common standards for that. Now, this is the flow test, which, and this also, the syringe which I tried, when I tried to get it, it had to be a little bit specially ordered. It was not the normal syringe. So I had to tell my pharmacist to get a particular syringe with that and then he had to get it. It took 1 day. So it's not common. We cannot standardize this for, as I told you in the morning, when there are some facilities, there is no SLP. There are some facilities, there are no dietitians also. Or either one or either or only will be there. So we need to train the nurses a lot, isn't it? So it is not easy. There are a lot of instrumental things that are also not available. Everyone doesn't do a FEES or a VFSS. There are the only done bedside swallowing also in many facilities. So many same recipes, better self-check tools, and different naming conventions has to be done. It's not difficult. Each region, if a group tries to volunteer, and we need to do it from the dysphagia core group point of view, is my request. I will put in a form. I think all of us are in the WhatsApp group. I'll pass it on to Shilpa or Bhavna and all, and we'll do it. Anyone who's an IAPEN India member can become a dysphagia core group member for free. You have to just fill the form, so that when we try to do a study for the West, East, North, West, when we try to standardize, we will know not this many hospitals are interested and we can do. For example, I wanted to actually do a swallowing survey, which we did 1 year before. It was not even 100 responses I got. This time, few weeks ago, I released it with one of the SLPs. Only 50 responses, 54 to be exact, till yesterday night, and it's more than 1.5 months. Because people, we need to communicate, better way of communicating. So please join Dysphagia India if you're an IAPN India member, and then we will try to see how best we can standardize for our country. Now the syringe test video, we'll see how they have done and see how it is complicated for this. Next slide. So once again, set of thickened liquids and comparison for evaluation. You can see that there is grade 1 to 4, and from thin to thick how it is done. So the same porridge, whether it is a sattu or a ragi huri ittu is basically a sprouted ragi porridge. They say huri ittu is basically flour, which they give a sprouted ragi porridge is given because it's better digestion because of the enzymes and other things. You're all clinical dietitians, and that is what we give for the bedridden patient because it's better easily digested. So the same thing can be prepared from grade 1 to grade 4, isn't it? Any porridge for that matter, correct? So this is how, and there are different products which they have done in HC. And this is a folk pressure test, which is, I thought was a little bit impractical for our Indian setting. And why do we need to standardize? I already spoke about it. So the top down flow. So what they are saying is adjusting the minute. We need to make the new tools of the trade how best we can do it. Rules with the millimeter, the fork, and all that is not possible in our standard. Now this is our this again I took it from my book. The rice key. This is the other one. The right side is the apple puree. So the apple that is pressure cooked after removing the skin or with the skin, and then you have to blend it. In the morning, we were speaking about the enteral feeds also, about the consistency. One of the thing is, see, the consistency matters when you give through the rice tube, the frecka, the 16 or 14, whichever you're doing. So when you give a khichdi through the rice tube, when it has to be in a different consistency, blend it. The egg that is added, you cannot eat, we don't do an egg flip or an eggnog because of the raw egg. What we do is we boil the egg, we grate it in the carrot grater, and then we blend it with the khichdi, which is coming out of the pressure cooker. So that is how the FNB has been trained, or when we counsel it. So every single thing matters, isn't it? Cooking has a different texture. The same thing how it is. So that is an apple puree, and this is a khichdi which is there, and this is a thick veg soup. Again, it is multiple consistencies that cannot be given. Adding calories and protein to the diet of a cancer patient or a neuro patient. Nutrient dense, making every safe swallow count. You have to add the calories, add the protein. Morning we showed even an ONS was added. It depends upon an almond powder, walnut powder. You need to add micronutrients. It can be a flaxseed oil. It can to give that omega-3. You can add a walnut powder which is sieved, roasted and sieved. Whenever you roast it, it is better digestion for a bedridden patient. So then again you sieve it and then it comes as a fine powder. Adding fiber, it can be done in different, including what do you think will be very cohesive? Can anyone say other than your isabgol or a psyllium fiber? What do you think? The in thing now in many years now, what do you think is a fiber that can be added for any patient who's on an enteral tube or even for this patient? Anyone who can say for food, from the food point of view? Which one? Oats. Okay. Anything Indian? Ragi. Okay. I don't agree, doctor. Bajra. I am telling for a bedridden. Yeah. Okay. Fine. Guava pulp. Excellent. Moringa. Moringa, girls. Moringa. Moringa. I'll tell you why. The drumstick stick. And you just pressure cook it along with the khichdi on top and just remove that, what do you say, that fiber. It's without the stick. Flavor is excellent and the fiber is huge. And of course, now all is moringa and spirulina and other things. All it needs, it's a few rupees. And anyone, if you see that in a dal rice, when a mother gives, she adds this, usually with a ghee, and then they add this for flavor. Not from the sambar, but from the boiled point of view, because it would be like an 8 months, 7 months type of baby. So you can add that for fiber. Really cohesive. It really blends very well when you do it. Excellent flavor. And of course, the micronutrients. So we need to make sure that we understand what it is. So, and this is a apple puree. Apple puree, which is the food rheology. Rheology is very important because it tells about the science of identifying. We are trying to do it with a reputed institute, the rheology, because we need to know the texture of it, the science of it, how it is. So the viscosity, they can test for our khichdi, our pongal and other things. Hopefully IAPEN India can come up in another 1 or 2 years. With an understanding of these textures, and it becomes possible to measure and relate any given food to the how to chew, how to manipulate and swallow that item. So this means the diet is not just a puree, a mince chop. You need to finally go into the matrix of each food that has to be done. Whether it is a morning beverage, what you're going to give. If it is lunch, it is mid-morning, all those things. So that is very important. So food textures, you can see that the food texture share descriptions that are similar. So adhesiveness, how it sticks, a pongal which is a gel. Cohesiveness, how it blends. Then the firmness of it. So if you see a resistant starch, a sweet potato or a thing, how it is the firmness. So depending upon how you boil, the firmness is different. The biteability, isn't it? And the hardness of it. So if you keep the same potato starch, becomes a resistant starch like an overnight oats. They can say overnight oats. We can boil the same potato or the sweet potato and keep it in the fridge and you take it out, you know the resistant starch is more. It is a prebiotic for the gut, and also the difference is the hardness is different. Springiness, viscosity, and shear. So the way you do it, a shear can be a gajar ka halwa, it can be the way the viscosity, it applies only to liquids. So teamwork is very, very important, as we need to work with the SLP, we need to work with including the psychologist, which is very important because they're going to motivate the patient and all that. So the interdisciplinary team, best practices are useful professional tools because they offer guidance. A good standard guide the practitioner need to know. We need to have the common document, maybe we can communicate better. Informative for the patient and the caregivers is very, very important, because the way you counsel the patient when the patient is good, going home, that is very important. Training, nursing, and caregivers, that is the most important. Nursing team, without the nursing team, I don't think we will be able to do this at all. So they need to understand what is a dysphagia diet. They need to understand the cohesiveness. They need to understand the different textures that cannot be there in one puree, correct? So those things has to be there for the patient. Now, the principles of thickening I wanted to come. So see, there is a thixotropic in nature. How do you thicken a liquid? So when you add a guava gum, it's different. When you add a corn flour, it's different. When you add when you add a starch, it can be the same arrowroot flour many hospitals use. So that also. So the thixotropic nature is, it shows their thinning behavior, how it is. So the different characteristics that needs to be there, the thickener which you are going to add should be generally regarded as safe. So that is very important. Now, instant food and beverage thickeners are available, and this is the common thickener, and the palatability is the most important. Whenever a food company tries to introduce a food, what is the first thing they see? From a food company point of view, whether it is a PepsiCo, whether it is a Britannia, whether it is any other company, Nestle or whatever it is, for the biscuits or the noodles or what is the first thing they see? Nutrition is the last. Palatability. Without taste, it will not sell. It will not sell. First thing they see is the taste. And what is the preferred taste in India? According to a food company, you need to be not only in nutrition, you need to know the industry as well. If there is a new product coming into the market, whether it is wellness, whether it is therapeutic, you should be the first to know. Doesn't matter what it is, whether it's junk or no junk. You need to know. Food safety, what is the recent FSSAI, if FSSAI has done, you need to be a 360 degree person, because food is everywhere. And you need to know the wellness, because for example, a cosmopolitan in a city like Bangalore, when they come, they will already know fully about it and they'll ask your opinion. And if you look at it as if you've never heard it for the first time, there you lost your respect. So you need to know. So what is the first thing? What is the preferred taste in India? Sweet. Cadbury, sweet Edriconda, they say. What is it? Correct? Sweet is the most preferred thing in India. That is why the first thing they try to do is they have a sweetness flavor to many of the things that is there for the industry. The first is the sweet. So this is how the positioning, how different textures are there. What are the different, if it looks like this, how it is a different, what do you say, a blend, a green, an orange, a red, a white or something. This is one of the mealtime thing that is followed by one of the hospital, where it says the positioning, it tells about the diet, tells about the texture, what drinks to give and what. So if we come up with something different, yes, we can take positive points, pros and cons and everything, see what works out for us, and then try to do this. So it can also have a form like this person is on a high fat or MCT, which is you're going to add this high protein. Then you can say that what is the, he cannot eat, he has different textures, which is more of a red flag for him, he might aspirate, so you cannot give it in that consistency. The physiotherapist will look at the positioning of it, or the occupational therapist, and then you can see down if there is a thing, we can give the SLP number or something. So all the interdepartmental communication can have it. So this is
everyone.
one second. What I did was for the European Society of Swallowing Disorders, I did a poster 2 years ago. It was COVID starting that time, and it was accepted. When that person from the thing, they said that 3,500 rupees, very expensive for a neuropatient and other things. I worked with a CFTRI scientist who was ex-scientist, and he's working in someone, and we came up with a thickener. The thickener was a tapioca starch, and the tapioca starch was medical grade. Tapioca starch is usually used to starch clothes for the stiffness. Okay, so we cannot use a normal tapioca starch, he told me, because he's a food scientist. So he said, ma'am, you cannot use tapioca. Why he came up with the tapioca starches? It had more micro minerals compared to a normal starch, and it is economical. Tapioca, you can get it in India and it's easier. So he said, no, we need to get a medical grade. Understood. So then we got a FSI label, his factory had it and all that, and we got this. And the cost was 350 rupees. 350 rupees was the cost of this. So we tried in different hospitals, including one in Gujarat. We did multiple hospitals in Bangalore, including mine. And we tried it. After COVID, I had a problem. Then the factory closed down and I couldn't do it. And I was looking for funding and other things. But as a nutritionist, what my thing was, I added a lot of micro minerals to it. Selenium, zinc, magnesium. I had it prebiotic fiber also, the fiber a little bit more, is because I knew neuropatients, most of them were constipated. So I wanted to give that thickener to have something in it and not just an arrowroot flour. Even the commercially viable, the 3,500 rupees one was just a starch. Nothing else was there in it. So you can use our arrowroot flour, corn flour, but from the nutrition point of view, if we are using a thickener, don't you think it should have something to it? So that was the one. So this got accepted in the poster submission, and they were really amazed that it can cost that less. But we gave it for 500 rupees because of the FSI label and different things, and after that we couldn't. It's not clear. Yeah.
Hello everyone.
So I had
Thanks. This is
let it
10th
be talking. I had
Congress
done this,
poster
and the scope
presentation,
was given with
poster
every
number
pack,
PB02.
and we trained our FMB
Dysphagia
for
in
that.
respiratory diseases, stroke, and brain damage.
So this was for my ESSD thing, which I did for that. Barriers and solutions. There are barriers are numerous, but the solutions can be done by good communication, building relationship, interdepartmental, person-centered practice. We are already doing interdepartmental. When you're giving an enteral feed, we know when the physiotherapist is going to come and do his exercise. The nurses know how to manage the feeding, so all the 8 feeds can go. Isn't it? We are already doing. We need to just speak the same language when it is dysphagia. Person-centered practice, innovation and training, and also the dysphagia management information has to be done. Training the nursing staff is very, very important. This training should include many things that also we need to standardize. What are the different trainings we need to give the nursing team? Modification of the positioning and the diet, because the occupational therapist or the physiotherapist should know. There are a lot of tools that are available in the West. It is just a triangular pillow which gives so much support when the patient is sitting upright so that he has better swallow. Okay, we use straws in a Parkinson patient to drink it effectively. We can use the pediatric cup where with a spout which can thicken liquid can go and not completely, where with so much shaking he cannot do it. Even in this, at least he will not embarrass himself by putting everything on. That stops them from even trying, is what I'm saying. So we need to understand the patient's limitations and then come up with solution. Management of behavioral environmental factors, and definitely oral care. I think after this someone is going. So the checklist for best practice, we need to interdisciplinary dysphagia team meetings has to be there, current menu recipes has to be there, challenge the kitchen staff with various things, train the new facilities. You know the attrition rate is very high in the dietary as well as in the F&B, isn't it? So we need to train them. We need to retrain the facility staff when they come back. Nursing team has to be done. Definitely important, provide discharge education for the patients or caregivers. And then as we work further, what is the thing which we need to do? If you please give me more points, I would be very happy to put it. This is the limited points which I could come up with. defining roles of individual groups. As a dietitian, what you need to do, as a for the neuro, for the cancer, for the thing, and with the SLP, how are you going to work? Because they already have a set of things, because they are in this for a very long, they concentrate very well on this. They have their own way of diagnosing and all that. Setting individual protocols to begin with, then getting feedback from patients and groups and revising the protocols and sharing the experiences in every forum. That is very important. Last 2022 December swallowing week, we released this video, which is to increase the awareness for dysphagia, which is what was the theme last year. So I just want to please bear with me for 2 minutes, and I hope this inspires everyone. World Swallowing Day is observed in December. The Dysphagia core group of IAPEN India has created this video to raise awareness about dysphagia, which is difficulty in swallowing. It has been recorded in various languages in India to create awareness about this hidden disability. Let us watch this video. Thank you.
नमस्ते। डिस्फेजिया यानी निगलने में कठिनाई, इसकी जांच अवश्य करवाएं और कुपोषण से बचाव में मदद करें। धन्यवाद।
નમસ્તે, ડિસ્ફેજિયા એટલે કરવાની તકલીફ. તેનું નિદાન કરાવો અને કુપોષણ થતું અટકાવો.
नमस्कार. डिस्फेजिया किंवा अंधगेल्यास होणारा त्रास, यासाठी आपली तपासणी करूया आणि कुपोषण होणे टाळण्यास मदत करूया.
നമസ്കാരം. ഡിസ്ഫാജിയ അഥവാ വിഴുങ്ങാനുള്ള ബുദ്ധിമുട്ട് എത്രയും നേരത്തെ പരിശോധിക്കുകയും തന്മൂലം ഉണ്ടായേക്കാവുന്ന പോഷകങ്ങളെ പ്രതിരോധിക്കുകയും ചെയ്യാം.
प्रणाम. डिस्पेजिया के लेल स्क्रीन जे निगले में दिक्कत होत अछि आ कुपोषण के रोके में मदद करैत अछि. धन्यवाद.
ಡಿಸ್ಪೇಜಿಯಾ ಅಂದ್ರೆ ನುಂಗುವ ಸಮಸ್ಯೆ. ಡಿಸ್ಪೇಜಿಯಾ ಅನ್ನು ಪರಿಶೀಲಿಸಿ ಮತ್ತೆ ಕುಪೋಷಣೆ ತಡೆಯಲು ಸಹಕರಿಸಿ. ডিসফ্যাজিয়া অর্থাৎ খাবার গিলতে না পারা অপুষ্টির জন্য ভীষণভাবে দায়ী, তাই এটা নিরাময় করা খুব প্রয়োজন.
வணக்கம். டிஸ்பேஜியா விழுங்கற்கடுமை, விழுங்குவதில் ஏற்படும் இடர்பாடு. அதை பரிசோதிப்பதன் மூலம் நாம் ஊட்டச்சத்து குறைபாட்டை தவிர்க்க உதவும்.
नमस्ते. डिस्फेजिया यानी कि निगलने में कठिनाई, इसकी जांच कराएं और कुपोषण को रोकने में मदद करें.
डिस्फेजिया किंवा अन्न घेण्यास होणारा त्रास, यासाठी आपली तपासणी करून घ्या आणि कुपोषण होणे टाळण्यास मदत करा.
డిస్ఫేజియాకు తనిఖీ చేయడం చాలా అవసరం. మింగుడు సమస్య వలన వచ్చే పోషకాహార లోపాన్ని నివారించవచ్చు.
ନମସ୍କାର। 12ରୁ 18 ଆମେ ୱାର୍ଲଡ ଡିସ୍ଫାଜିଆ ୱିକ୍ ଭାବରେ ପାଳନ କରୁ। ଯଦି ଆପଣଙ୍କୁ ଖାଦ୍ୟ ଢୋକିବାରେ ଅସୁବିଧା ହେଉଛି, ତାହେଲେ ତୁରନ୍ତ ଯାଇକି ଡକ୍ଟରଙ୍କ ପାଖରେ ନିଜର ଚେକଅପ୍ କରାନ୍ତୁ। କାରଣ ଯଦି ଆପଣ ଖାଦ୍ୟ ଠିକ୍ସେ ଖାଇପାରୁନାହାନ୍ତି, ଢୋକିବାରେ ଆପଣଙ୍କୁ ଅସୁବିଧା ହେଉଛି, ତାହେଲେ ଆପଣ କୁପୋଷଣର ଶିକାର ହେଇପାରନ୍ତି। ଧନ୍ୟବାଦ।
ഭക്ഷണം ഇറക്കുന്നതിനുള്ള ബുദ്ധിമുട്ട് പോഷക കുറവ് പരിഹരിക്കുന്നതിനായി ശരിയായ രീതിയിലുള്ള പരിശോധന.
नमस्कार. डिस्पेजिया मतलब निगलने में कठिनाई की जांच करवाएं और कुपोषण को रोकने में मदद करें.
வணக்கம். டிஸ்பேஜியா உணவு விழுங்குவதில் உள்ள குறைபாடு. இதனை சரியான சோதனைகளின் மூலம் அறிந்து அதன் மூலம் உண்டாகக்கூடிய சத்துணவு குறைபாடுகளை தவிர்க்கும்.
डिस्फेजिया यानी कुछ को भी घोंटे में तकलीफ, एका जांच कराई और कुपोषण होए से रोकी.
வணக்கம். டிஸ்பேஜியா அல்லது உணவு விழுங்குவது சிரமம். முதலில் உணவு விழுங்குவதில் என்ன காரணம் என மருத்துவத்தை அணுகி கண்டறிந்தது. பின்பு அவர்கள் கூறும் ஆலோசனைகளை பின்பற்றி குணமடைந்து இத்துடன் வரக்கூடிய ஊட்டச்சத்து குறைபாடுகளை வராமல் தடுத்துக் கொள்ளலாம்.
नमस्ते. डिस्फेजिया म्हणजेच आहार गिळण्याचा त्रास, आणि ह्याची तपासणी जर आपण लवकर केली तर कुपोषण पासून आपण वाचू शकतो.
नमस्कार. डिस्पेजिया घटकों में तकलीफ से बचाव में कुपोषण की रोकथाम होगी.
डिस्पेजिया यानी खाने को निगलने की समस्याओं से बचने के लिए अपनी जांच जरूर करवाइए और कुपोषण से बचे रहिए. याद रखिए, स्वस्थ शरीर ही अच्छे जीवन की पहचान है. धन्यवाद.
नमस्कार. डिस्फेजिया म्हणजेच याची लवकरात लवकर तपासणी करा आणि कुपोषण होण्यापासून अस्सलाम वालेकुम. डिस्फेजिया ग़िज़ा के निगलने में जब दुश्वारी हो तो उसका मुआयना करना, जो कि ग़िज़ाइयत की कमी को रोकने में मदद देती है. शुक्रिया.
டிஸ்பீஜியா என்பது குடும்பங்களில் ஏற்படும் சிரமத்தை ஆரம்ப காலத்திலேயே கண்டுபிடித்து சரி செய்வதால் குழந்தைகளுக்கு ஏற்படும் ஊட்டச்சத்து குறைபாடுகளை தவிர்க்கலாம்.
So many chapters helped us to do this, and this was the awareness because last year the theme was to create awareness for screening was the thing that was the world was following week has told us. So this is what was released last thing. I'm very happy this year that we are in this prestigious institution with the IAPEN India Delhi chapter for giving this opportunity. Really thankful for that, and I think we can take forward because more and more awareness has to be done. So the goal is to improve the food experience because the palatability is very important with safe, nutritious and tasty food. I think there is no second thought about nutrition safety. So not every disability is visible, dysphagia awareness. So this is a hidden disability and that is why we need to be more aware about it. Thank you so much.
That was impressive presentation, Sreemathy, once again.
Thank you.
Any questions? We can take a couple of questions in the interest of time. We may restrict
So
to
we'll be having it in the panel
panel
discussion.
discussion. Great. Thank you, Sreemathy.
Thank you so much. Thank you all.
For the next talk, I would like to invite Dr. Varun Surya. He is currently holding the position of Assistant Professor in the Department of Dental Education and Research in AIIMS, New Delhi. He had experiences previously as a senior resident in Maulana Azad Medical College and with the numerous publications in both national and international journals. His area of core interest is dental hygiene, and now he's going to talk about the oral hygiene related prophylaxis. Over to Varun.
This one. You can make it full screen. It's working.
Yes.
This one, no? Yeah. Okay, afternoon everyone. So I will be taking a topic of mouth and dental care in healthy, dysphagic and in patients unable to take self-care before and after. Yeah. So as you know, oral health is a very important factor even for normal patients like us, obviously, and it becomes very important in patients suffering from dysphagia, especially those who are at risk of aspiration. So as you guys do in these patients some sort of dietary modification, such as alteration of food texture and thickening of fluid, so it can increase oral retention. And when there is increase in the oral retention, means food stays in the oral cavity for longer period of time, it can facilitate the growth of microorganisms. So this stagnation of food can increase the risk of number of diseases like dental caries and periodontal disease. So what is oral hygiene basically? See, oral hygiene is practice of keeping your mouth clean and disease free. So it is important for all of us obviously to keep our mouth disease free, and it involves simple procedure like brushing and flossing of teeth and visiting your dentist regularly. So what is the importance of oral health in dysphagic patients? So as you know, dysphagia is a risk factor for aspiration pneumonia, which also includes other risk factors like poor oral hygiene, periodontal disease, untreated dental diseases, and denture wearing. Patients who wear dentures, they keep their dentures in mouth for longer period of time. So when you keep some artificial object in mouth for longer period of time, there will be increase in the microbial growth, and this kind of increase in the microbial growth can increase the microbial load in the oral cavity, which can lead to serious complications. So how to manage oral hygiene in such patients? So there are three principles which we can use. First one is obviously mechanical cleaning, which the patients can do themselves. It involves simple toothbrushing. Toothbrushing, there are different types of toothbrush, regular size, small size, so we can use them depending on the patient requirement. Then chemical agents we can use is chlorhexidine, which is a normal mouthwash, which we normally use for ourselves also. What these mouthwash do, they decrease the microbial load in the patient's mouth, which can provide them some relief. And then we can also go for professional oral care scaling. What you are seeing in the animation is a scaling method in which we remove the calculus which is deposited on the teeth. Okay. So role of oral healthcare provider in these kind of patients. So first of all, what we do, we evaluate the current oral hygiene. Now this is important in Indian scenario. Why? Because in India you see a lot of patients having some sort of habit history. Some patient having tobacco chewing habit history, or BD smoking and certain like of things. Some people are fond of eating too much of sweet. So obviously oral hygiene differs in different kind of patients. Then we can make recommendations to health professionals involved in the management. Introduce and demonstrate oral hygiene. Means India is a country in which still we are lacking behind on education, and we can tell the patient obviously how to do it, but to demonstrate oral hygiene practices is very important, because most of the patient will not understand when you say you have to do like this, like this. So it's better to demonstrate them how to practice a normal oral hygiene. And then finally we can review on regular intervals. Once you told the patient what to do and you demonstrate the patient how to do it, then feedback and review is very, very important, because again patient competence comes into picture, and we have to keep following up on regular basis. So implementing effective oral care, depending on the severity of dysphagia, we can have different sort of protocol here. So I have divided the dysphagia into three categories: minimal dysphagia, mild to moderate, and moderate to severe. So minimal dysphagia or normal patient or normal people like us, what we can do is we can have normal oral hygiene routine in which we can perform toothbrushing 2 times a day. The toothpaste is also an important component here. Normally what we use in our homes, it contains fluorine or fluoride, which provide protection against dental caries. And for minimal dysphagia also we can do the same thing. Now for mild to moderate dysphagia, we can have toothbrushing bit, but the toothpaste should contain high quantity or high amount of the fluoride. The normal fluoride content in the toothpaste is around 1000 ppm. What we recommend or what we can recommend to the patient is using a toothpaste which contains around 1500 ppm of fluoride. Second most important thing is that these kind of patients have difficulty in spitting. So what we recommend is that patient should use low foaming toothpaste. Means झाग जो है वो कम बनना चाहिए, otherwise it can lead to aspiration also. Okay. One important factor here is it is also applicable to all of us, that with increasing age what happens, that we have seen lot of interdental caries, and interdental caries become very important in patients, any patient. And the problem is that interdental caries are difficult to diagnose in the early stages. Anyone have any caries in the audience? Any treatment?
All of us must be having. Nobody wants to say.
Yeah. So what we have seen in our unit is that normal persons, who brush 2 times a day and who floss their teeth, with age, what happens that because of the changes in the periodontal ligament and everything, we see lot of interproximal caries. And when we see this kind of caries in the normal person, obviously it will becomes increased in such kind of patients. So the problem again is that difficult to diagnose, and once it becomes too deep, the caries become too deep, it causes pulpitis, and that pain is very difficult to bear. So for that we can recommend interdental cleaning. For interdental cleaning we normally use floss, but floss is difficult even for a normal person to do, Means you go to a dentist and they will recommend to do floss, and I don't know how how many of you can actually do floss, because it is difficult to perform even for a trained dental surgeon like us. So what we recommend nowadays, that there is a floss, water based floss. I will show you the picture later on. That floss uh, release water at a high pressure, so that will wash away all the bacteria, all the food debris from your oral cavity. Now for moderate and severe dysphagia, what we recommend is that you should not use toothpaste. So you can only use a toothbrush. You can slightly damp it, but no toothpaste. Why? Again, because in severe dysphagia, again it becomes difficult for the patient to spit. So again, it can lead to complications. But then, if a patient is not using toothpaste, there will be increased risk of caries or other oral diseases. So what we recommend is topical application of fluoride, and this is easily available. You can go to any dentist, or you can go to a dental unit of any hospital, they will provide it. So these are different types of interdental toothbrush easily available in the market. They comes in different shapes, different size. So people of different age groups and different priorities can use them with ease. And this is a procedure where we apply fluoride on the tooth. It's a very simple process, hardly takes 10 to 15 minutes, but the outcomes are very, very important and very beneficial for the patient. On the first picture, you can see that acid, because which comes from the bacteria, because when there is retention of food in the oral cavity, so there is accumulation of lot of bacteria there, and bacteria, as you know, they produce acid, and the acid will weaken the enamel. Enamel is the outermost layer of the tooth. This is the most hardest layer in our body also, and once it becomes weak because of the acid produced by the bacteria, it can cause dental caries and other periodontal disease also. So reducing the risk factor for dental decay. So as I've told you that we can use, we can advise toothpaste with high fluoride content, values around 13 to 1450 ppm fluoride. When we use fluoride, what happens that fluoride incorporate into the dental structure, it makes it stronger, so it will be more resistant from the attack of the acid produced by the bacteria. So it will provide very good benefits against the dental caries. So now many toothpaste have the added benefit that they do not produce too much of foam. Okay, so the agent which produce foam in our toothpaste, what we use in our houses is sodium lauryl sulfate, which is a common foaming agent. So there are a number of toothpaste available in the market which do not contain this sort of foaming agents. Now there is a special category of patient with profound dysphagia, in which we don't give any oral form of nutrition. So profound dysphagia or inability to maintain adequate oral intake for nourishment and hydration requires non-oral form of nutrition. Now logic can be that when we are not putting food in the oral cavity, so there will be no microbes, but in actuality it will attenuate the growth of microbes in the oral cavity. Why? Because when we eat something or when we drink something, it flushes away the microbes. So when we are not providing the food or water through the oral cavity, obviously there will be accumulation of microbes in the oral cavity. So lack of mastication and fluid intake, increased buildup of calculus. Calculus is nothing but tartar. It's like a stony kind of accumulation in our teeth, behind the teeth, which can result in dental problems and periodontal diseases. Periodontal disease means there will be loss of the jawbone around the teeth. What happens with the increasing age? There will be bone loss and the tooth becomes mobile, and this becomes more important in patients having poor oral hygiene. Now, sorry. So posture is also important factor when the patient is on the bed. Patient bedbound patients or immobile patients. So when they are keep lying, what we can do for them? We can raise their head by around 30 to 45 degrees Celsius degrees. Then mechanical debridement, again, since it becomes difficult for the patient to use a normal size toothbrush, so what we can use is the small size toothbrush, which is pediatric toothbrush, easily available in the market. Then in the market we have electrical toothbrushes also, but again it depends on the patient's dexterity to use it. If it is not possible or the patient is poor and patient can't afford it, what we can recommend is just a piece of gauze wrap around the finger and you can clean it after the food. Then interdental brushes also, they are important for preventing interdental caries. Now, how many times we should do it? Ideally, after every meal, we should be doing it because the amount of bacteria will increase exponentially after the meal. Okay, and this is the time where the maximum damage will occur to the tooth structure. So, mechanical cleaning should be ideal after every diet, 3 times a day, 4 times a day. A special mention of the edentulous patient means patient without teeth who use denture. You can advise them if there is no need. See, when we need dentures, when we are meeting someone or when we are eating, so that is the only time a patient is requiring denture. So you can tell the patient to avoid wearing denture as long as possible, because denture obviously you are putting some prosthesis, you are putting some external device in your mouth. They will not have very smooth surface, so there will be mechanical retention of the food they are eating, and obviously there will be growth of the microbes. Again, microbes increase, they will cause damage to the teeth also. There is no teeth and to the mucosa also. So this is the image I was mentioning. This is a water-based water floss. Nowadays, we recommend it to every person, patient, non-patient. These kind of devices help to clean the teeth interdentally. You can use them not regular basis, only once or twice a week. Why? Because they release the pressure, they release the water with a lot of pressure, and too much usage of them can actually cause damage to your mucosa. So if you are using it or you are planning to using it, just use it once or twice a week. Now, toothpaste, as we have discussed earlier also, toothpaste should be fluoridated because it provides protection against the caries. Again, toothpaste with reducing or non-foaming agents are preferred. High fluoride content is what we recommend. Now, the decision to not use a toothpaste is subjective and it should be considered with the oral healthcare provider. So these are some of the non-foaming toothpaste, although they are not easily available in the Indian market. But we are living in an era of online shopping, so we can easily, get access to them. Now, use of other chemical agents. The most common we use is chlorohexidine, which is applied as an oral swab. I think this is the normal mouthwash which we use normally in our homes. So same can be used for the patient. Then there are number of alcohol-free formulation. What is the importance of this? That they prevent drying of mucosa. Patient is already ill, already lying on the bed. So drying of mucosa will further complicate the situation. And then right now we are also having some gel forms. So gel form is easier to apply. Then after doing everything, mechanical toothbrushing or using the mouthwash, post oral care, because whenever we are using this kind of thing, they put a lot of irritations on the surrounding structures. So what we can ask the patient, or what we can recommend is applying some sort of moisturizing agents on the lips and around the oral cavity. One special mention is that avoid petroleum jelly. As a doctor, I always, recommend not to use petroleum jelly on any part of the body. I think it is easily available in the market. Number of brands promote petroleum jelly in the market, and it's not what we can say, not good for our skin. So in these kind of patient, obviously we should not be using it, because again it will cause drying of the mucosa. Now, two special mentions. First of all is patients with salivary, that is pooling of saliva. Now, in these kind of patients, pooling of saliva mainly occurs because of the impaired clearance rather than the excessive production. Now, too much of saliva in the oral cavity, obviously, what it will do, it will keep on drooling. It doesn't gives a very pleasant picture. But the second most important thing is that when the saliva drools, it causes a lot of fungal infections around your oral cavity, lot of itching, lot of redness. So this is a common picture which we see in terminally ill patients, saliva drool, and you see lot of fungal infections which will cause again discovered to the patient. So these kind of things can again increase the periodontal diseases. And finally, so patient with xerostomia, as you know, this is drying of the mouth. So what we again recommend is high fluoride toothpaste. Then we can also recommend the patient to frequently sip the water. Now there are number of commercially available products for the dry mouth, like dry mouth relief fluoride mouthwash, and nowadays we also have spray form, so it is very easy to apply. So these are some of the examples of the dry mouth relief gels and spray which we can choose. So to conclude, and individualize, because different patients require different needs. They may be belonging to different geographical location, different habits, depending on whether they are using some sort of tobacco chewing or some sort of their oral hygiene. What we can recommend is we can have an individualized oral hygiene regime which can improve their quality of life. This also reduce the risk of adverse health sequelae in individuals with dysphagia. One of the problems in India, or you can say throughout the world, is that we keep medical health and dental health separate, which cause a lot of problem to the patient mindset. Obviously, oral health is the most neglected part or neglected part of our body. We just keep taking care of the outer part of the face, but we neglect the oral cavity, which is very, very important, because once the bacteria enters into the oral cavity, it can enter through your teeth, it can enter through your gingiva. Once it enter into your blood, it can go to any part of the body. So the message what we can take is that oral health is very, very important. And nowadays, as you may have heard, that the cost of a single tooth is equal to cost of a diamond. If you go for an implant means an artificial tooth, it will cost you around 50,000 to 1 lakh rupees. So it's better to take care of your oral health, not patient also, but obviously our oral health also. Thank you very much.
Thank you, Varun. You perfectly emphasized the importance and the need for oral prophylaxis and the care for this. And I really appreciate the importance that you've given for the oral prophylaxis, because oral cavity is the gateway for your diet. So whatever the consistency and whatever the diet you give, it will go from oral cavity. So prophylaxis and the hygiene is very important. As primarily an oncosurgeon, I always look into oral cavity hygiene before I assess on this thing. What is the care? So it reflects the patient's profile and everything. So yes, caries, the mastication, because the first step in swallowing is the oral phase. If oral phase is not prepared well, your propulsion phase and the rest of the phase has been affected. I really appreciate it. Thank you very much.
So we'll take in the panel discussion. So thank you, chairpersons. It was a wonderful session. Thank you, all speakers too. We'll move on to our second panel discussion. And for that, I would like to invite Dr. Bhavna Gandhi. She's registered dietitian and chief dietitian with Lokpriya Hospital, Merit. She is PhD into nutrition with certified diabetic educator and trained bariatric dietitian, keto dietitian, naturopath, yoga master, and a pranic healer. She's been RD representative and former executive member of ITA Delhi, treasurer of IAPEN Merit Chapter, Association of Diabetes Education. She's with Nestle Nutrition Institute, International Confederation of Dietetic Association, associate member of RSDDI UP Chapter, and many awards and accolades to her credit. We welcome you as a moderator for the panel discussion.
Thank you, Shilpa, for your kind words. Good afternoon, one and all. First of all, I'd like to thank the organizing committee of IAPN Delhi chapter to give me this chance to conduct the panel discussion. A warm welcome to all of you for the panel discussion. Thank you so much for investing your time. As we are seeing post lunch, it's very difficult to have an audience, which seems to be. But yes, we'll try to keep you awake. Don't worry. We'll give you a good nutrition feeds. So today, since morning, we had an amazing discussion on dysphagia, causes, treatment, role of MNT, management. We had a great feast from our eminent speakers regarding the role of texture, diet, thickeners, the protocols, everything, the mouth and dental care, all. So, as discussed, dysphagia management is interdisciplinary management. We require professionals from different disciplines for better management of dysphagia. Our goal today is whatever we learn here to come up with something, a new practice guideline, as being discussed earlier, that one can apply to be more successful in one's own institute as well as the practice. So today we have an amazing panel on dysphagia practice essentials. The first of all, I'd like to call upon Dr. Sumant. Please. Sir, I've already been introduced as the chairperson for the session. So, Dr. Varun, he has been a speaker. I like to call upon Dr. Divya Chaudhary. She is a dietitian with Rajiv Gandhi Hospital. She has been currently working as a chief dietitian with the rich 18 years of experience. She is member of MASCC, member of the Guidelines and Research Committee of IAPEN Core Group of Nutrition and Diabetes and Renal India. She has many awards and achievements. Excellence in MNT 2020 IAPN, written a chapter on cancer and malnutrition for doctors. Welcome you, Divya. Thank you, sir. Now I like to call upon Mr. Anil Kumar. He is speech and dysphagia therapist. We welcome you, sir. Please come. He has a rich experience of 12 years. He has been a postgraduate in language pathology from AIIMS, Mysore. He has been working in various setups and different types of communication and swallowing disorder patients. He has worked at Chandigarh, Madanta, Chandigarh. He is working as a speech and dysphagia therapist in Max Super Speciality Hospital, Saket right now. We welcome you, sir. We have Miss Anjali Bhola with us. She is presently working at AIIMS New Delhi. She is a compassionate registered dietitian, a nutritionist. She has got many experience and awards and many publications to her name. To name some is acute phase proteins in acute viral hepatitis and cirrhosis of liver, assessment and comparison of nutrition status in patients with liver disorders and normal healthy individuals. So I welcome all my eminent panelists, all the dignitaries on the desk. So since morning we have been listening regarding the dysphagia, the management. So to begin with, sir, I asked Dr. Suman the very first question. Can you brief us the causes of the dysphagia? Just a brief.
So, first of all, mean the difference between so common but both are relatively different. So anything that is painful is colonoscopy. So most of the structures that is affected from oropharynx to your piriform sinus that can cause your colonoscopy. But if dysphagia is a difficulty in swallowing, so it can be it is like a more of pain, but it can affect right from your oropharynx to what's saying. So the anatomical structures are same, but your pathology and your alimentation that can cause is entirely different. So you need to differentiate first thing. What is it really a dysphagia or not?
So any kind of a special test to be done, like is it a dysphagia, or do you find any kind of a difference how to assess the different kind of dysphagia in different kind of patients? Like it could be head and neck surgery patient, it could be because of Parkinson's. Do you have some special test or special category to do so?
Yes, first most important thing is the clinical history. So clinical history will give you more than 50% of your information, whether it is related to your oropharynx structures or is related to odonophagia or dysphagia regarding your onset and everything. But when it comes to your clinical tools, so first thing you have to assess for the subjective assessment. So if you're dealing with a stroke patient, okay, so you need to evaluate his cognition before assessing, before selecting which tool you have to select. So usually the common tools you see is the questionnaire tools like your MD Anderson kind. Why I mention MD Anderson is the only scale that has been validated in head and neck. Rest of the scales you can use, but it's not validated. Okay, so this is a subjective tool to assess. There are objective tools to assess on the same. Your like video fluoroscopy, your fibroscopic examination with the sensory test. Okay, and the TNE also you can use. So there are a lot of things, but it has to be depend on a patient profile.
Thank you, sir. Mr. Anil, will you like to add up something?
There are so many things. So
Yeah.
I think it's enough.
Thank you. So my next question is to Dr. Varun. What kind of mouth and dental care is required in dysphagic patient? Although you have given a very detailed presentation, but I'm asking with a special reference to oral hygiene regarding the head and neck cancer patients.
The problem with all the patients, whether dysphagia patient or any patient having oral cancers also, first of all, patients may have some sort of habit history. First of all, we need to educate the patient to leave the habit. In India, the main habit is obviously tobacco. So motivating the patient to leave the habit is very difficult. I have seen the patients who are having surgery tomorrow, and today they are chewing tobacco. So it's very difficult. So in dysphagia patients also, since we have seen such kind of patients. So the first step is educating the patient. Then we should tell them what to do. Again, how many times to do brushing, how to do flossing. Then we should demonstrate them. We have a special unit in our CDR, public health dentistry, which do this work. They demonstrate the patient how to do proper way of brushing. Actually, there is a proper way of brushing. We have different protocols for brushing also, for flossing also. So this is very important for any kind of patient and also for normal individuals like us to know the proper way of brushing. Okay. The third step is obviously to follow. So when you call the patient again after 2 weeks, 3 weeks, and you ask the patient, "Ki aap log kar rahe ho, nahi kar rahe ho," and he will say, "Yes, I am doing it." Just by examining the oral cavity, you can find out whether the patient is following it or not. So it's very easy in our case to see the results of feedback. Okay. So these 3 steps to tell the patient, demonstrate the patient, and review. These are the 3, you can say pillars of maintaining a proper oral hygiene in this kind of patients.
So this is applicable to all, as you said, for
Yeah.
not for the patients but for us
All of
also. So just to add up, any yoga for dysphagia improvement in oral and mouth care
Yoga will
also.
do its part, but it's not very specific in case of dysphagia patient. And one more thing I want to mention is, right now we are putting a lot of emphasis on herbal toothpaste. Many of us may be using herbal toothpaste, but we don't recommend herbal toothpaste in dysphagia patient. Why? First of all, it does not contain any fluoride. Since it is not containing fluoride, so it will not provide any relief for dental caries. And second, the most common problem we have seen is lot of burning sensation after using herbal toothpaste. Maybe they are using too much quantity of ingredients. So we normally don't recommend any kind of patient to do herbal toothpaste, which may be controversial because government is pushing lot of effort on this. But maybe we will find some sort of mild variant of herbal toothpaste, which we can recommend to the patients.
One more question to you. So if one is having a bad mouth odor, generally we see it in dysphagia patients. So what do you suggest for that, for the maintenance of that?
Bad mouth odor or halitosis is mainly occurs because of accumulation of food. So the root cause is again the patient is not maintaining the hygiene, especially the tongue part. So it's very important to clean the tongue on regular basis because there will be accumulation of the bacteria. We have papillas on the tongue. They are finger-like projections in which the food accumulate very easily. So this is the main cause. So what we can recommend to patient is to keep the tongue clean on regular basis. That will solve the purpose, and also we can recommend to them mouthwashes. So that will solve the problem.
Thank you. My next question is to Mr. Anil.
Yep.
So does patient suffering from dysphagia have difficulty in moving food from mouth to throat?
Yes, they have this type of difficulty.
You are not audible, sir. Maybe you need to, yeah. No, it's on. Just
Hello.
drag it
Is it
forward.
audible?
थोड़ा सा आगे कर लीजिए उसे.
Hello. Now
Yeah,
audible?
जी जी.
It depends on patient to patient and depend on the disorders also. Those who are stroke patient, they have difficulty the food moving from oral cavity to oropharyngeal cavity and pharyngeal cavity. And even though you are cancer patient, they also have the same difficulty. But again, we have to do the assessment and clinical. We have to use the clinical tools also. There are instrumental parameters in instruments that we can use it.
Thank you. So, does food stick immediately or does food stick after swallowing? Means, is it so that the moment we put it sticks, or is it after swallowing that it gets stick?
After swallowing.
After swallowing, it gets sticks. So, as we say right now, we are discussing the patient is having a problem in swallowing.
Yes.
With the dysphagic patient, as it's common. So, my next question is to you, Dr. Divya. So, what are the swallowing safety food tips? What you tell to your dysphagic patients?
See, you have to put in a lot of effort once you are counseling the patient. See, food is very easy to understand because everybody understands the basic terms like dal, chawal, roti. And everyone says, no, no, we understand, but it's exactly not the case. So once you counsel a patient who is dysphagic, what I teach my patients first and foremost is that do not mix liquids and solids. Because the patient is actually having not big appetite. It is difficult or painful for the food to swallow. So they will do it like bas jaldi se kha lo and you are done. It's like a task for them to eat a small katori of dal also. The first and important thing is not to mix any solid with liquids. The next advice I generally give it to my patient is that you have to space your meals accordingly. Sometimes they're posted for a test, sometimes there's a biopsy or whatever. There are long gaps of fasting, or sometimes if they come for a radiation. So the doctor will ask them not to have food before the radiation. So it is important to nourish themselves during those gaps. So that is also important that you have to space the meals accordingly. Third thing for these patients, which I tell them is whatever you take, either solid or liquid, it has to be nutrient dense because we have to provide them basic calories, vitamins, proteins in small quantity only. They are not able to take normal quantities of food. So the meals, whatever they are taking, should be calorie and protein dense.
So you want to say it's quality over quantity, what we really work upon, right?
Definitely.
So as you are saying, the patients are missing. So have you trained your nursing staff also to keep a track, or your dietitian goes and check in the other round that whether the patient have taken the proper intake or not?
We follow the approach that since the dietitian cannot be there always with the patient, so whenever the nurse is there, yes, they do check and let us know. And whenever we are on rounds, we generally take rounds 3 times a day, specifically for these patients to check.
Yeah.
So, and we keep on asking the nursing staff.
Thank you. Yeah. Yeah, please.
Ma'am, there was a question that you asked about the bolus propulsion part.
Yeah.
So, like we have oral phase of swallowing, pharyngeal phase of swallowing, esophageal phase of swallowing. Likely, we can classify them into oral dysphagia, oropharyngeal dysphagia, pharyngeal dysphagia, and also esophageal dysphagia. So, it is not necessarily if a patient is having dysphagia, it means that he won't be able to propel the bolus from the oral cavity to the pharynx. That's what I'm.
Thank you very much for your input. So, Dr. Anil, Mr. Anil, will you like to give the 3 main points for safe swallow, if we say like Dr. Divya have given us?
To avoid the aspiration is first thing.
Yeah, 3 main swallow.
Yes, yes. Aspiration and second is to give the period food depend on the patient condition, and that we have to do lots of research on that area.
So we can say it's an individualistic approach.
individual.
You cannot say it categorically ki one blanket fits all. It doesn't suit all. It has to be done properly with the individual patient, taking care of each and every aspect, right? Dealing with all the disciplines. So my next question is to you, Miss Anjali. Do you use any special cutlery or crockery, especially to ensure that there is a safe swallow for your patients?
Usually it's not in the hospital, but we guide the patients to use it, like the spoon which we use for the kids, जो थोड़ा सा ऐसे टेढ़ा रहता है, I think Sreemathy ma'am
Yeah,
had
Sreemathy
shown
ma'am
it.
showed.
That kind of spoons we tell them to use, and maybe if they have more of difficulty swallowing, they can use a straw kind of or a sipper kind of a thing. I counsel them for in the OPD.
So what do you do use in your IPD, because yours is a government setup?
Yeah,
So
IPD means really difficult task to be taken, like, but we try the best, whatever the spoon or the plate, katori, whatever is available, we tell them to use the best out of it.
Okay.
It's a government sector, so we are little stuck to certain protocols and certain things. We cannot provide certain things. That's
so we may ask our patient
Patients.
attendants also, and we may give the training to the attendants
Attendants,
also
and we show the
to
pictures कि
feed
ऐसा
the
ले आना
हाँ
है,
ऐसा ले आओ या ऐसा खिला दो या
खिलाना
इस
है,
तरीके से
हाँ,
खिला दीजिए.
we guide
So
them.
right.
And like we give them boiled potatoes, like mash करके चम्मच से थोड़ा दही डाल दो, mash it with दही और दूध and then give it. ऐसे we guide them that.
Thank you. Mr. Anil, I just want to ask you, do you initiate swallowing exercises before
Yes.
the actual feed?
Again, it depends on the patient to patient.
Again.
We do definitely.
So how many days before, or just 1 or 2 hours, or means can you just enlighten us on the same?
Before giving any food, really, first of all do the assessment, clinical assessment based on performance, and after that we'll make a puree food, maybe custard or some papaya, some anything puree, and we can test the patients how he's swallowing, and if he's not swallowing, they can give some swallowing exercises, swallowing maneuver. There are so many things we can.
I'd like to add a comment on it. So the question you asked is like you go proactively for the patients with the disease. So I'll take this an example in related to head neck. There are a number of head-to-head trials that come back. Okay, even with the highest follow-up of 1 year, none of them has proven which is the best one. Okay, so there are even the trials like proactive trial, which is registered in USA to run USA now. Right now is going on. They are 3-arm trial. They have a proactive, reactive trial, intense and low intense. Even with this kind of setups, right now they're trying to evaluate this phase. So, if a question, this still is a field of we'll need to explore on this thing. And second, the cause of dysphagia, if it's related to head and neck, okay, if it is with the oral resections or it's a pharyngeal resection, they need to be tested in a 1-to-1 ratio. Okay, you can't compare an apple with a orange, right?
Exactly.
So you have to, I mean, you needed time to test this. Yes, they are limited data to prove that a proactive approach is a better, okay. But if his patient is having, like you prepare it from 2 weeks before.
Okay.
2 weeks before you prepare the patient, if going for CTRT. If your patient is already in a reconstruction, you start the enterical feed once your flap insert is done. Okay. Even with your American College of Gastroenterology, they say that start your enterical feed 24 hours and try to reach the full stage by 48 to 72 hours. That is the difference.
Yes.
Or if you can prolong, you can prolong it. So it's a mainly tailored. Yes, you can get an answer, and we can get an answer probably by these trials like proactive. And when it comes to your stroke patients, also a lot of trials like active trials that everything is going on. Hopefully, by the end of the decade, we'll get an answer.
So as we are trying for the nutrition part also, we'll get the standardized thing done for that also. Thank you very much for your inputs, Dr. Suman. So I just want to ask, a very common observation is that there is decrease in saliva being observed in the dysphagic patient. Will you like to give your inputs on the same?
Yeah, I'd like to extrapolate everything. Like, yes, dysphagia patient has a low saliva thing, but if in my field, I usually see the patients with head and neck, okay, head and neck malignancies. In head and neck malignancies, because of your radiation, you have a decrease. So that is
Yes.
the early complication and the late complication also. So in kind of early complications, that's why we asked to keep oral hygiene by adequate hydration. So that's why we always assess the intake output during the pre-op, post-op, and during the radiation also. And thanks to the technology, right now we are coming with the new protocols like IMRT. IMRT because the baseline secretions is from the parotid. Okay, even if you knock off the submandibular gland, also your baseline is maintained. So the amount of xerostomia in the era of cobalt and right now with IMRT is entirely different. But still, I agree the patients right now experiencing xerostomia. The second question I would just want to dysphagia patients related to the stroke. They tend to have dysphagia. I mean, this hypersalivation. Sometimes they have hypersalivation because of drooling.
Yeah.
Okay, so these are different set of patients. But yes, we have an answer and we have solutions.
So drooling is different from lack of saliva. Both are
Yes,
different.
but still the total outcome is going to be an entirely different thing.
Yeah,
Drooling,
that-
yes, obviously he's having hyposaliva. Systematically, he's having hyponatremia and other issues.
Right.
It's complete xerostomia, yes, this is more proportion towards cause dysphagia compared to yours.
Right. So, Dr. Varun, will you like to add up to this? Like in case of decrease in saliva, what all kind of mouth and dental care you will see?
I mean, what happens when patient is having decreased saliva, called as xerostomia, drying of mucosa, so patient will suffer from lot of burning sensations. And saliva, but it provide a mechanical action. It washes away all the debris, all the microbes. So because of decreased saliva, there will be growth of the microbes. It will cause dental caries. It will cause parenteral diseases. That will make the life of the patient more discomfort. So it's better whenever patient comes to us, first of all we should treat the dental problem. The patient may be having some sort of dental caries already. Our patient may be having some sort of parenteral disease already. So before starting any treatment, we should always address those problems, because those problems, if they are not addressed, they will not keep increasing, and they will cause a lot of pain and discomfort to the patient.
Right. So, Mr. Anil, will you like to add up to this that is there any kind of a tool what you use for mouth opening, or do you suggest any exercises to make increase in the saliva so that a patient can be relieved with the symptoms?
For oral cancer patient, we can use the some mouth openers we have.
Can you name one or two?
Mouth opener.
Exactly. It's okay.
What is the name?
Yeah, please.
I'll help you. So,
I'm asking
mouth
that.
opener usually.
yeah, that's commonly used in Tata, the phone and the phone.
Even
we used to, when I was a main, like we used to send the patient for CDR for that. So, right now, I'm in a private practice and I can still seen options in Amrita and even international levels. In international levels, like you have a terabyte. That is the only device that has been done on RCT and just check the feasibility. India has come up with techniques with their own philosophy, is the Orabyte, which is of the pocket-friendly kind of thing. And for the patients in a government setup, yes, we still following the old techniques with this thing. And in fact, in Max, I think recently it has been uploaded in your pharma department also, the terabyte, which was developed by our director, Dr. Pawan Gupta. So it's a very less cost. I mean, it's some $800. Okay.
Okay.
And it's like a simple mechanical device. You have a calculating device, your mouth openers. Yes, we follow this thing, and he's right now Scottish. So he's in Amrita. I think these people also they're using the same kind of devices. But yes, same thing.
So
there are
you have
lot
a
of
full-fledged department over there. So you are having all the latest things coming over there. That's great. So any kind of exercise, Mr. Anil, to increase the saliva for the dysphagic patient? Any particular exercise or so? Not exactly.
There's no exercise, but we can medicine, I think.
Okay. Right.
There are some studies which mention that having good oral hygiene will stimulate the saliva form.
Exactly.
Even I like to add even when I am around, although it's not my cup of tea, but still I do counsel the patients keep brush kiya karo, clean your mouth and take your bath. Because these things help you increase your appetite and you feel good.
Good enough,
Yeah.
right.
Although it's not my cup of tea, but still when I'm around,
As in the morning we discussed with the aroma also, you feel like eating.
But when patients मुझे नहा लिया, doctor साहब ने बोला नहीं, मैंने कहा यार what do you wait?
Hygiene is very important. Now we say in post-surgical patients, right? So
apart from this, like any exercises or the question is recommend. Yes. The first and most thing as a surgeons, like we always say, is maintain your hydration.
exactly.
Maintain your hydration. That will keep on going. Your saliva output is 1.5 to 2 liters. Okay, you carry with your hydration. If you dehydrated, the first thing to knock off is saliva. You're sweating, everything goes because sympathetic stimulation, parasympathetic stimulation, dry your system out. Okay, you have to be hydrated. That's why open your mouth, whatever is a dental surgeon or anything. You by looking at the tongue and the mucosa, you can see he's dehydrated. Yes, follow the saliva. I mean, just you can go ask for patient hydration. That will take care of this. And medications, that's Prilocaine, there's cholinizing with a dose of 1.5 micrograms. That can help you with this saliva.
Right. My question is to you only, Dr. Suman. So we generally find that the tracheostomy is being done in the morning. We have discussed it also in the patients, post-surgical and surgical patients also. Many time it happens. So any special care in feeding the patients with tracheostomy? It should be deflated or inflated while feeding, or any particular point you like to put in?
So first thing, first question is like, why didn't it cost in this
Yeah.
case? Okay, is it to protect the airway or to secure? I mean, like secure the
Yes.
airway or to prevent the aspiration? Okay. Second, the timing of your feeding. What is the position of the feeding? All these things need to be assessed before you take a call. Its cuff should be deflated or inflated. If you're doing a feeding for aspiration kind of thing, or for what do you call, like for a protective or bleeding, you can't take the chances of the cuff deflation and aspiration. Okay, so obviously you have to give the feeding with like cuff inflated. If you're like if you're done this for securing an airway for you're doing a major surgery or airway obstruction, yes, you can give a feed without inflating the tube, but you have to make sure that patient is in sitting position and there is someone who's looking for the patient, that if you tend to aspirate, someone will help you. Okay, and the amount of the bolus you are looking. So if I'm doing a tracheostomy and the day one, I'll not start the liquid. I'll start the semi-solid. I'll do the solid. Then I'll slowly untaken towards the liquid. So it is a tailored manner. Everything has to be properly monitored.
Right. So again, it is individual approach. We cannot go with one thing. Ke, haan.
It has
Although
to be
we are
dynamic.
trying to
It has to be
standardize.
dynamic and it has to be evaluated on everything. So evaluate the patient and from the first just from the surgery. What are the things that have been compromised and what are the things that going to affect because of your surgical ablation and what are you doing on table to reconstruct it. Then you take on this thing because the feeding everything comes later.
Right. Dr. Varun, will you like to add up anything special care for tracheostomy patient for the regarding the mouth and dental care? Any means maybe use of betadine? I don't know.
No, ma'am. Basic steps will do.
It'll be the same.
Yeah.
So can you emphasize on the role of betadine as a mouthwash? Do you
Betadine we
recommend?
use, yeah, we use betadine, but we use it for surgical patients only. We don't recommend betadine on normal basis.
Okay.
We use because its taste is not patient friendly. Patient have better compatibility with the chlorhexidine. We normally recommend only chlorhexidine. Surgical patient we do.
Right. Mr. Anand, will you like to add up for the tracheostomy patients? Any special care to be taken care of?
For tracheostomy, we have to just prevent the aspiration, and the feeding is like that. We have to again assess the patient, the inflated condition or deflated condition. There's so many parameters to check on that, but we have to first assess the patient. So, very huge thing.
Right. Just to add up, as Dr. Sumant have said, that drooling is also very common.
Yes, ma'am.
So, any special care for the same?
We have to do some exercises. There's some movement exercises we have to do that to control the drooling, or there's some medicines to control the drooling.
Okay. So, you just teach the nursing staff, the
No, we do
attendant,
only.
you do only all the exercises, and the physiotherapist is also being included in the same?
Yes, we will do the postural exercise, not the oromotor exercise and soul exercise.
Right. So, Dr. Varun, generally we observe pocketing of foods in between the teeth and cheek. It is a very common problem what I've seen in the dysphagic patients. So, what care will you suggest? What points to be taken care of?
Pocketing means there is loss of bone around the teeth. So for that we have to go for professional care. There's a department called as periodontics, which specialize in this department. So if anyone having some sort of pocketing where there is regular, allotment of food, which we see also in normal people. So what we can do, we can go for deep cleaning of the periodontal ligament around the area of periodontal ligament. That will help the patient.
Thank you. So my question is to Mr. Anil. Who feeds the patient first with the test feed? Is it the SLP, the dietitian, or the nurse? Who feeds? Yeah.
They will assess the patient. What is the level of the patient? They will start the feed first. Then they will inform the dietitian which type of foods we are going to start.
Okay, thank you. So, Dr. Divya, do we think that with the tracheostomy patient, it is just the tube feed what we go, or we do have the other options also?
See, it depends again on the condition of the patient. Sometimes the patient is able to swallow thick liquid also. So we try and meet the nutritional requirements basically through the tube feeding. And in between, we generally encourage it because so then we do try with small sips. And then if encouraged, if we can move forward to semi-solid foods in small quantities.
So
that
again,
has to
that
be
depends.
tried.
Right. So, Miss Anjali, will you like to add up something to her?
We can, like she rightly said, like we can add, in our hospital, we can go for like pureed things instead of, like it's like, let's say, like the way man showed, pureed papaya or curd, yeah, these kind of stuff.
Okay.
But these will be very less in quantity because major part will be of the field.
Right. So, as being told by Ms. Sreemathy in her talk, so what is the criteria at your institute? Is the nursing staff or personnel given specific training for feeding the
really.
dysphagic patient?
Not really. We keep a track. Like while we counsel the patient, like Deepa mentioned, in their hospital there are 3 times rounds have been taken in the ward, but we counsel the patient कि अगर अभी आप जा रहे हो जांच के लिए आकर आपने इतना लेना है ऐसे लेना है, right? So we ourselves keep a track or we call up the sister like आप patient आएगा तो उसको बता दो he take the food and all that. We keep a track on call.
Okay. So it is not the special training being given to the
We don't
nursing
have
staff.
FNB trained and we don't have that kind of. Because it's a government again institute, so we don't have that FNB trained staff to be true. So we do it ourselves basically.
Right. Dr. Suman, at private, as you have shifted to a private institute, so do you people give any special training?
Here and there, like we are getting a new stuff. Yes. But per se, like when it comes to AIIMS, like we already have a speech therapist. Like before Kaustav joined, like we used to run it. So as a residents, we have our own training. But in subspecialties, like when we are doing some tours or your colonic pull-ups, there is a subset of patients that you need a special dynamic therapy. So I would like to share the platform or the information with my dietitian and the swallowing speech pathologist with me when I assess it. I mostly ask them to stand next to me when I'm doing a swallowing assessment. So during that time, I'll show the posture and the position. Yes. Because right now we are coming up with the new technologies like new surgeries, robotic surgeries, and conservation surgeries. So we want the speech pathologist to be trained because this is a different subspecialty in that. Okay?
Exactly.
So we ask them to get expertise on that by just learning it from us, so that patient can get benefited. Like this is the way you do it because they are very complex things. Only a speech pathologist can understand and people can allot some time for the patient. So we do train them, and it's depend upon the patient.
So we can say that as many of the hospitals are adapting, that it should be a team round. Once a patient is there, so dietitian, speech therapist, the surgeon, everybody should be there so that it can be done at one round go. And one can train the nursing staff also simultaneously.
Ideally, it should be like that.
Ideally,
But
it
because
should
of
be.
the logistics and technical issues, it's not there. But you should be in a state that you should communicate this information to a dietitian before you say, I mean, quarter that khana shuru kar do kuch bhi. So inform this thing. It has to be like this, and it has to be in a particular position. And this is the bolus size, and this is the volume you should add. So this is how it goes.
So generally, we have seen that a consultant and a surgeon give a remark and goes off. And dietitian जब तक आती है समझ में नहीं आता या staff आदि knowledge खा जाता है या yeah I just want to mention one thing over here, sorry, but surgeon many times and I've seen many physicians also, they don't write also and they tell the nursing staff लिख देना और वो instructions नहीं आती हैं.
No, I know that this is because of the, I mean, very busy schedules that are going on, and few of the patients, like for a GA surgeon, like or a thoracic surgeon, at initial phase you need to monitor. Maybe a surgeon is directly communicating at one stage, but in case of head and neck, okay, and especially max, I'm taking care of this thing because our patients at a risk of aspiration, and I can't just compromise the patient airway just to start the treatment. So I have to assess and inform. So right now, under my roof at least, the orders, verbal orders, what are the instructions, and what volume has to start. I'll communicate with my dietitian team, and every time we have a group at WhatsApp or communication to close communication. This patient need this kind of exercise. Yes, please carry on with this thing, and you're the expert.
So that is it's a
This
good
culture
thing.
has to be developed.
Yeah.
This culture has to be developed.
No, in many private institute, we are putting up all the information on screen also. So one consultant comes, puts the instruction, so it can be observed by the others also. But in few hospitals like government setups, it's still not being there. So this is a common problem. Am I right, Dr. Divya and Ms. Sanjali?
No, I'll comment on this in fact in GI surgery, which I'm working with. The doctor, the consultant, and the residents are quite active, and they mention it. They do call me up, like, "Ma'am, इस patient का ऐसे आप देख लेना." So
Yours is a department because it is being under a good leader. So leader makes a lot of difference. So that's why you must be having. But I believe, Dr. Divya, do you agree with me कि आपका भी government setup है?
Government setup, it's a private.
Private.
But yes, we do find challenges and when it comes for communication. And without proper communication, I don't think a patient can get the maximum benefit.
Yeah.
Exactly.
So it has to be a team approach, whether it's a government setup or a private setup, where teamwork is not there. So I think we can spread the message whomsoever we meet, and we meet in these forums, and we can encourage our co-health practitioners also to spread the message of teamwork. Because without that, the complete benefit of the treatment patient will not receive.
Exactly.
In fact, I added teamwork. मतलब it should be actually a team round even.
This is what we discussed, that it should be a team round ideally, but ठीक है, as sir is saying, the logistic is also there. That's a common problem. So we move forward. Dr. Divya, my question is to you that we have been preparing, as been mentioned in the talks also, the special diets, the pureed diets. So what kind of pureed feeds or diets what you give to your patients?
The consistency has to be taken care of. The texture of the foods has to be cared of. Even the amount of spices and the kind of spices which are being added to the food, that has to be taken care of while preparing the diet of a patient who is struggling with dysphagia. And I have seen that the temperature of the food also affects these patients. They are
Exactly.
not able to take very hot foods or very cold foods. Sometimes, yes, they are comfortable with very cold foods in case of radiation in a head and neck cancer patient. So again, depends on case to case. You have to assess the patient, and then you will decide that the patient is comfortable with a soft diet, or you have to further puree it, and a thick puree or a thin puree. It depends on the patient's condition.
On patient's tolerance regarding the consistency also. So how do you make your texture diets nutrient dense?
We cannot provide only with food. That's what I believe. We have to use oral nutritional supplements. We have to mix it with whatever smoothies or fruit shakes or blended puddings we give to the patients. So you have to top up with them. This is one way. Other way to make calorie dense, like in salted pureed foods like khichdi or dal, so you can add butter or ghee when you counsel the patients to make them calorie dense. In any case, we have to give nutrient dense foods to these patients.
So how do you assess like kitna calories per kg body weight, kitna protein? So do you have a special assessment or any standardized protocol?
We use SGA for assessing we have our nutritional assessment form. Then as for the modified RD of the patient, because maximum are underweight, you have to increase the calorie and the protein intake. Generally, the protein requirements of these patients are as high up to 1.2 grams per kg body weight. In certain cases, the patients are really emaciated, and you have to plan a diet containing 1.5 grams of protein per kg body weight. But practically, it is not that feasible for the patient, but we have to try. You have to give high amounts of calories and proteins.
Sometimes there's a tissue repair. There are many things, wound healing, pus coming out of so there are n number of factors you have to assess before planning a diet and calculation of the proteins and calories.
Thank you. As you have said about the temperature and the consistency, so does temperature or consistency of food help in managing the symptoms of dysphagia?
Yes, to a great extent, yes. In many patients, we have seen, specifically I mentioned earlier, like in patients who are receiving radiation or biliary cancer, they are not able to tolerate hot food. In these cases, it should be cold, I would say chilled food items, even in winters, that is very much comfortable for the patient and it is easier for them to take. So milk-based puddings or desserts, they are very comfortable with that. If we talk about, they are comfortable with blended, not very thick, not thin, but they are comfortable with that.
Yeah, please, please.
Some neurological patients, like ma'am, let's say lateral medullary syndrome. So the patient tends to develop cricopharyngeal spasm. So it is well known that cricopharynx is always in a contracted position. So what happens in cricopharyngeal spasm, the patient will be able to swallow liquids and even sometimes boluses. So what the principle says that the cricopharynx tends to open in a volume and the hot bolus consistency. So we try to feed the patient with that particular kind of a consistency or a warm bolus so that the cricopharynx relaxes in that position. So yes, definitely it does help.
Okay. So as you rightly said, yes, that mechanism is basically temperature related, but your somatosensory system, it represents in your cerebral cortex. Okay, it's not in the medullary system. Yes, both the tracks are different, but altogether they connected to your fourth ventricle swallowing center directly. So yes, giving it temperature modulated for like cold or warm, it will add some amount of proprioception to your reflex. So whatever the reflex, that oral phase, preparatory phase, they get maximum benefit. Beyond the tongue, where the reflex is involuntary, it is mediated by medulla oblongata and the other centers. So that is it reflex. It's like involuntary. So something has to be started. Is the volume of the bolus, tactile sensation, or general? So this sensory augmentation is one of the things that will help in bolus propulsion and the pharyngeal squeeze. Same thing works in your cricopharyngeal spasms. And in fact, I used it in a few techniques for toss cases and colonic.
So can we say that we can start off with the hot water, maybe a sip or so before giving any bolus or so? No, not
No,
exactly. It won't help out.
It won't help. Like whatever the bolus you are giving, just assess the patient whether they are aspirating. If he's having a pharyngeal residue, where it is, it's a valvular residue or pyrethrum residue, and grade it. If it is a larger one, okay, because that patient is pharyngeal squeeze is not adequate. It is not supported by your primary pathology, like patient with a stroke. So giving a temp modulated one, your pharyngeal residue is going to go down to a grade 1 or grade 2 from grade 4. Okay? And if it is the patient is in a grade 1 kind of residue, adding a cold or water is not going to. Okay. So it has to be, same thing. Assess and go ahead. So first thing in dysphagia or whatever, assess, take intervention, grade it, and again do an intervention, again come back to the same grade it. So once sensory augmentation is one of the compensatory maneuvers. Most of the international standards, few centers, they follow this sensory augmentation.
Thank you. Seeing the paucity of time, just one question to give as a concluding mark from all of you. One liner regarding, I just want to know, as all of you are from the different institute and different disciplines. So, how is dysphagic patient being counseled? In OPD, IPD, means is it the demo session what you give or how do you train? So, we start off with you. It will be a concluding remark for the management of dysphagic patient also.
Most of the time I'll be in operation theater. So if I have to rehabilitate a patient with a dysphagia, first thing I'll choose a day where I'm free. First thing, I have to give some time for assessment and everything. So don't just plan your schedule. And second, gather your team properly, train them because it has to be teamwork. Assess, then you take the rehab. So please don't schedule your behavior. Time is a very valuable thing in this age of patient. Actually, patient, compassion, so empathy, so a positive vibe, so that we can further go ahead with it.
Dr. Varun?
Basically, educate the patient and demonstrate the procedures and regular follow. That is very important.
Especially for mouth and dental care. Dr. Divya?
I would like to conclude by saying that nutrition requirement meets the nutrition requirement is actually a challenge for the cancer patient.
It's not working.
I would like to conclude by saying that coping up with the nutritional requirements is actually a challenge for the patient and the dietitians because the nutritional needs are really on the higher side. In this case, regular follow-up is very important. So that has to be encouraged because many times we see in the OPD that once you counsel a patient, they would come back once. After that, they will back and you also do that. It is very important to encourage regular follow-ups in these types of OPD also.
Mr. Anil?
But we have to work on the prevention of aspiration and the regular follow-up with the swallowing exercises and encourage patient as much as possible.
Psychology of a patient also makes a lot of difference.
I will definitely like to add for the IPD, I try my best what possible best from the government institute. But yes, for the OPD, I do counsel them to take. The first thing I ask is, do you have a mixie at home? They say yes. Because see, my patients are usually not very rich. They're like medium, Sangam art, they're not very affordable patients. So I don't prescribe ONS anyhow. And I tell them just say with less of options like खिचड़ी बना रहे हैं तो उसमें दाल and chicken and add everything and blend it out. So at least you're able to feed. And the most important thing I tell them is don't drink water with the meal. अगर आपको उसको निगलने में दिक्कत है तो यूज दही या लस्सी. At least some protein is going in along with the food. है ना. And रोटी also I tell them रोटी का टुकड़ा करो दाल चिकन जो डालना है डाल के मिक्सी में चलाओ and eat it. So and definitely I tell them मुझे 1 महीने बाद मिलो. I give them the date. So it's like follow-up is definitely required. And teamwork.
Thank you very much. So from this panel discussion, yes, it is very well interpreted that we need multidisciplinary approach for management of dysphagia patients. Teamwork is required of physician, surgeon, SLP, dental care. Everybody is being needed. An important part of treatment is helping patient getting adequate nutrition and avoiding dehydration, which is very common. In regard to diet, texture, thickness of fluid, positioning and strategies, because of paucity of time, I couldn't take up those questions regarding the positioning also, which are very important, especially for the dysphagic patient. The posture is very important. We could have asked and discussed.
We'll be having into our
Next session. Yes.
One important thing I like to add is I say no to juices and coconut water. मतलब कोरोना के बाद coconut water is like the thing
Yeah.
I am against juice and coconut water.
Thank you all our dignitaries for your valuable insight and time. Thank you all the delegates for your attention and active participation. Thank you very much, sir. So we proceed for the next panel, right?
Yeah. Yes, the last one. Thank you, Bhavna. Sorry for standing behind you. I was standing on her head, actually. So I would like to call upon, it is a compiled group discussion. So we will try to send out some messages to all of us and we will try to have a kind of a consensus, some ready reckoner kind of a thing which can be built up. So we, our all delegate faculty who's been present over here, I would like to call upon on the dais. Plus, I would request Sreemathy to conduct this session as a concluding thing from right from the beginning, from the assessment to the management time. Okay, so we can have all the faculty over here. I would request even Dr. Dash, Mrs. Anita Jatana to join in. We can have Kaustav, Dr. Sumant again. So, you want a pen? Yeah. Paper. I'll give it.
So it would be a short, crispy summary
Yes,
of what.
summarize for the whole day. We'll have.
We'll have both of them missing their flights.
Yes.
I have many concerns.
No, you moderate. Yeah, Shiva, you also need to join in. Anil, you can also join in. Dr. Varun can join. Yeah, please.
All the speakers.
Yeah, Divya. The meeting. Dr. Varun is not going to join because he has to go for his.
I think he
some
has
work.
discussed enough.
Yes, he has discussed enough.
Okay. No, that was an excellent talk.
Yes.
Definitely. Very, very
Okay,
helpful.
we'll be in touch. Sir.
Thank you, Dr. Varun.
But I had a question, I forgot.
Sir, I asked you 3 questions to him over
No,
there.
you asked about betadine gargle.
No, I wanted to ask about chlorohexidine.
Yoga also he asked.
Every person in the world, you see the sister, first thing is betadine.
Chlorohexidine.
Is that chlorohexidine he spoke about?
Yeah, so I want to ask with the enteral feed, like how many times in a hospital protocol, 3 times it is done. Is it enough? Or is it how many? What is your
In
recommendation
enteral
from
feed,
in enteral feed, bedridden patient?
Times is enough.
Okay.
But again, depends on patient. How many times he is taking the meal.
No, through the Riles tube.
Yeah.
Not anything through oral.
No.
So it is 3 times chlorohexidine with that forceps, the tongs that they try to do at the part of bed
2 times is
routine.
sufficient. I think.
That is enough.
Sufficient.
Either with a pediatric brush or a gauze piece over the ear and brush.
Yes.
We can
So betadine gargle, is that mouthwash useful?
Yeah, it is useful, but we don't recommend because it does not have a very good taste. So patient, no,
Full
resistant.
strength or half strength?
Sorry, sir?
Full concentration.
So full concentration is very difficult to take. So we have to dilute it.
And is the teeth care equivalent to gum care?
Yes, sir. Because microbes deposit around the teeth and it cause loss of bone.
Should we massage the gums like this to the face? For the face?
Yeah, massaging of gums will not do too much of benefit actually.
That's what we were taught when we were kids. To use our fingers as
Fingers, yeah, we can use, but it will not remove the plaque deposit around the teeth. So it will not do any, too much of help.
I would like to ask a question. You said you can use the water flow for normal individuals. And
Yeah.
So why don't you like which बचपन से सीखे ना कुल्ला कर लो? Why not that?
The problem is that it will not go with force between the teeth, and there where the bacteria are, mostly accumulate. Even for a normal individual like us.
Kulla you will do only inside. Now how
Yeah.
how you will clean the area between?
So, but the water philosophy.
Yeah,
you have to
mouth,
from outside as
mouth.
well as
Yeah.
inside.
It's a very good machine.
Yeah.
Yeah.
Mouth.
Yeah, it's a machine. They have prescribed to me also.
Yeah, it's a kind of a new thing. All of us can use it.
Online I purchased.
But don't use on regular basis. It is the only thing. It will cause damage to the periodontal, मतलब periodontal ligament. Once or twice a day. It will cause recession otherwise. So 2 times a week is sufficient enough.
Thank you very much. Thank you very much. And also thank you all the delegates, all the practice. Because at the end of it, we always see valedictory ceremony, and by that time, actually, it's all vacant. So, my sincere thanks on behalf of the organizers. There's somebody else was to give the thanks. I forgot the way people are starting to go. So better to say thanks to all of them. Thanks to the airport authorities. Yeah. It was very nice, and it was a very nice get together. It was very heart to heart, and it was a straight talk among us. And I think all of us are benefited. I am very much benefited. I noted down everything. So thank you very much. And this is the summary of what we have been discussing since morning. And I invite Madam Sreemathy to continue the discussion.
Okay, thank you all. So let's start with a few guidelines so that we have a flow chart, and then we'll finish it in 20 to 25 minutes. Is that okay?
Yes.
Okay. So there is a patient with dysphagia. Now, are we going to first, how do we assess what are we saw the interdisciplinary team here, but there are different scenarios where it's not available. So now first when the dysphagia team comes, is it referred to the SLP first, SLP from the consultant? Please take it. Kaustav.
The patient will primarily go to the
primarily go to the consultant because dysphagia is always an underlying symptom,
Yes,
symptom
okay.
of a disease. So it has to be diagnosed first. After that, if any treatment is needed, then the concerned doctors will provide the treatment. After that, they will come to us.
Okay, so after the SLP, you're referring to the dietitian, or is it from the consultant coordinator which goes to the thing, or you're going to do the dysphagia score?
Yes, ma'am. So assessment will include everything like clinical assessment, instrumental evaluation. Then following there should be a management plan. After that, it should be referred back to the concerned physician or the concerned doctor, and
Okay.
also to the dietitians for whatever the necessary kind of a diet they must be prescribed.
So, Dr. Dash and Doctor, would you think that there should be a coordinator or a full thing who makes sure that everybody gets visited, so that there is a flow chart for, like in a liver transplant, they say, or a BMT, they say get clearance from or to do it. So, how do you think it would help from the GI point of view, Dr. Dash? Please, please. Yes.
The work starts the point patient gets into the hospital.
Yes.
Admitted.
Okay.
Then we do our clinical work. At the same time, we request our nutritionist to have a nutritional evaluation of this patient. That is the first thing. And then second, we spell out our plan. After so many days, this patient is going for surgery or has dysphagia or something. We want to build up the patient within 15 days before the surgery.
Okay.
Please make a plan. So they will make a plan and try to build up either by enteral or parenteral or mixed. They will prepare the patient. So this is the pre-operative part.
Okay.
And then post-operative is managed by mostly the anesthetist. And then post-operative. Suppose I have operated for a case of dysphagia and I have done an operation immediately, the patient is not going to take it. Obviously, the first few days the patient has to have total parenteral nutrition. I'll tell them how many days of TPN. Day 7, we start the feeding jejunostomy. Any patient of throat surgery, dysphagia surgery, or cancer of the esophagus or so, either you put a tube or we do a feeding jejunostomy. So we say on if feeding jejunostomy day 7, usually some people say day 2. So we spell them on that day you start, and that is up to them to either start with with just saline or water or half strength feeding jejunostomy feed or full strength. It varies from person to person. Then they start that, gradually increase to semi-solid cells, and then we tell them what is the progress of this dysphagia patient, what is the improvement. So we tell them a time frame that over a period of 3 months, first month I expect he has to have small, very partial capability to eat. Slowly it increases. Over 2 months time, when I estimate that the aspiration or regurgitation is less, we go on to feed more. This point, after the surgery, maybe after 7 days or so, when the patient moves around, we bring in the swallow therapist.
Oh.
And the swallow therapist then makes an assessment what is the quantum of dysphagia in this patient quantity. He also understands, because of his experience, how many days this patient will take to take full feed. So he tells the nutritionist that this is the dysphagia thing, and orally you can give this much, you can give this much, and through TPN this much. And slowly and steadily the coordination starts, and then gradually the role of swallow therapist is went out and the nutritionist comes up, that continues still follow up for maybe up to a year. So it's a absolutely coordinated.
So that what the IPD patients and everything, like in our like as a head and neck, like we used to see the patients with a cord palsy or with idiopathic cord palsies or post surgeries. So I'll tell you the head and neck scenario. So like when a patient walks in with a complaint, okay, you have every equipment to diagnose. So try to make a diagnosis. First thing, you rule out your malignancy. First thing.
Yeah.
Okay. So once you rule out your malignancy, if it is a functional disorder or anything, post the case in a swallowing clinic, where it is a multidisciplinary clinic. You'll have your consultant, you have your resident, you have your speech pathologist, and possible nutrition. Okay, because it's not possible. It's possible. That's why I added possible. Okay, that's why I added possible.
You're in a different forum, doctor.
Actually, that's why that's possible. It's
Sreemathy
okay.
also
Yeah.
reacted to it.
So the point is like if you have I mean the consultant and the speech pathologist together assess these functional issues. Like if you're done a fees, you grade the severity, is a pharyngeal residue. You can do a compensation maneuver at the same time only.
Yeah.
Why you need the patient to be walking around the counters? So once you're done with this thing, give a rehabilitation time and date, everything, and then he will come in the follow. So having a clinic is very important when you're dealing with these patients. We in AIIMS, like before Kaustav joined, we used to be there. With Kaustav after joining, we used to rehabilitate patients with oropharyngeal dysphagia, stroke patients. Sometimes patients walk in with a wheelchair. The cases referred from this thing, and sometimes we, I mean, as to sir said, like after rehabilitating, building up the nutrition, like cortisol cases, they tend to send the patients for rehab. So we assess and we rehabilitate and we do the deconditioning process. Like it has to be integrated and it has to be close connection.
So in the swallowing
One
clinic,
place
yeah,
everybody-
swallowing clinic. So if we start in any setting, so swallowing clinic consultant, swallowing along with the treating doctor and swallow therapist, dietitian and
If possible.
no, sorry, doctor, I cannot say if possible. Without that, how will the nutrition go? Without, they will say, without the body being.
Dehydration since morning. I mean, how will we achieve
So
results?
there is no possible because without nutrition, the other things will fall apart.
Yes.
So when you said early enteral nutrition, it has to start within 24, 48 hours. The enteral nutrition should start. Without that, they cannot be weaned out of the ventilator. They cannot come out of the ICU. They cannot reduce the length of stay. And definitely they cannot. So OPD also, without the nutrition, you telling us, telling the textured diets, the way of increasing the nutrition and
Okay,
the
I'll
density.
take out this thing possible.
What about the
Physiotherapist?
neurological setup? What is the algorithm?
So the same thing, sir. There will be a swallowing clinic, whether it's an OPD or something. We do after the fees assessment or the instrumental assessment. The dysphagia score is done. Then they come to the nutrition clinic, and where with the depending on the dysphagia score, we do along with the nurses also in the OPD. They do the testing of the thing, and then we give them a diet chart along with to be followed with a follow up of the thing.
Surgery, sir, why do we wait for 7 days? Why don't we start within 24 hours or 48 hours? Or if you've already got the feeling tube in?
I said it varies. It varies depending upon the severe what I can say how major is the surgery, how many bowels you have divided, and how many anastomosis you have done. If there is no anastomosis, you start on day one. If you do some, no, not head and neck. I'm speaking of
Jejunostomy and yeah.
So they are having an advantage in starting early nutrition because the abdomen is absolutely. We also work with them, and we are very happy when we do some ENT thing limited to here. Start on day one, day two. But in our case, there are also other things we've done.
Because there is resection and other things. So
that
depending
case-
on the
So I
millimeter.
said it varies. It varies. That's why otherwise even suppose you have done a ENT case, you start with fresh full polymeric diet. But whereas if you do in our case, we start with the saline, see whether it leaks or not, and then half strength, full strength. So the recent literature that we say enhanced recovery after surgery says that you can start within 24 hours.
Okay,
Or even start with peptide based.
Yeah.
But we find people have vomiting, nausea, distension, so better to avoid and sleep well.
Okay. Shiva, can you tell about the AIPEN protocol, or what would you think about the nutrition screening and the risk of the swallowing questionnaire from the Indian standard? Can all the dietitians, Anita ma'am, Shiva, and this one, can you come in, three of you?
I won't comment much on AIPEN because I'm not familiar with.
Yeah, so
the first time I saw that one, definitely I'll go through that and let us see what we can extract from that. So we, as I said, we have our own screening and the assessment tool, which comprises of 127 characteristics, out of which 50% comes from the hospital information, and the rest of the things when we converse with the patients across the table, we go on entering all those details. And this assessment is a part of that, even the dysphagia assessment. That assessment constitutes even the bowel movements and even the weight changes, the biochemical parameter changes, everything gets reflected on that. So you have a fair idea how the patient is progressing. I don't want to go back what sir has said, almost similar kind of a thing we practice. I just want to be going ahead with that. Yes, of course, we start post-operatively, we start immediately within 24 hours. And in case certain times we in pancreatic cases, not this kind of cases, if at all if the pancreatic leak is really high, then we stop feeding. Or else there are no chances of stopping the feed unless until some the biles are secreting in a very high quantity or something of that nature. But in head and neck, more or less, we never come across such kind of a situation unless until there is a Kyle's leak. Then your mode of feeding changes. Then you have to go with the MCTs, or maybe the patient has to go for a re-exploration, or certain changes might happen regarding these patients. But one thing what I would like to put it across to the audience over here, if at all there are sometimes the flaps the body doesn't accept after the plastic surgery. So that's an issue where how to really go about it. However strongly you are feeding the patient, adequate protein calories are being given, but still the patient it will not heal. So we have tried in the maybe around 4 to 5 patients till now. That time the immunonutrition really does good, and it really gives a good reaction to that. In case if you come across any head and neck cancer patient, and if the flaps are being not accepted by the body and it is getting delayed to heal that one, I would advise you to immediately change it to the rather than the polymer, go for the immunonutrition and maybe wait for 5 to 7 days, and you will start seeing the results over there. And our continuum of this nutrition intervention actually never stops till the patient is alive. Even after the 10 years also, if the patient is coming, we have all the records, and again the nutrition counseling, and again the nutrition intervention for the survivorship. That's why if you have heard about it, it's not the rehabilitation what we talk about. It is the perioperative or peri-treatment nutrition. And rehabilitation, we all relate it only to the surgery, but don't relate it to only the surgery. You can relate it to even the medical aspect as well. If the patient is ready for going for chemo or radiation as well. However, it may be any kind of cancer, head and neck or any GI cancer. Still, rehabilitation still can be done over there. Building the patient for the forthcoming treatment cannot be only for the surgical part over there. So we need to change our approach over. Then comes once the perioperative nutrition gets over, then comes the recovery part. What we are doing is like we mix up all the nutrition aspect over here. Once the recovery gets over, then comes the rehabilitation part. Once the rehabilitation ends over there, then the survivorship starts. During the survivorship, you like to see that achieving ideal body weight, building the muscle mass, avoiding the recurrence of the disease. However, every time you may not be successful, but there are a number of studies where the dietary intervention has shown to reduce the recurrence of the cancers as well, the secondary cancers what they come across. So your intervention actually starts when the patient comes to you for the first time, but it ends with only when he ends his life.
Thank you. So, any swallowing checklist which you want to say some points?
Sorry to interrupt.
Please,
I would
please,
like-
please.
The question you asked is like the tools. Okay. So you can't select the tool like for everyone. Okay. Because I'll tell you the scales. DOS, dysphagia,
Yeah.
DOS scale. The ASHA scale. Okay. FAM scale. The FOS scale. Your lot of scales are there. Okay. The E10. Because the E10. It's an easy one. It is validated and less than take 2 minutes. So there are the scales, and for example, DOS scale. It's validated and score based on your MDS, modified barium score test, and your intake. So you can't be doing this on the day one of your surgery. So choose your scale related to the patient. Choose your time and scale wisely. So before you using that, it has been validated or not. You can't be using this thing because you can't publish that. The example, the FOS scale, the severity that is used for dysphagia, but some surgeons used to assess for the robotics, but it's not validated. You can't be using that. So you choose your scale wisely and regarding the time. And it has to be sometimes they need cognition also.
Yes.
So you have to be like if you are dealing with a stroke patient who's already even VT M1, so you can't be using it. A car hai, he can't be answering that. So you have to select the questionnaire wisely. For that, it has to be validated on Indian population. Okay, because you are in Tata. So the subset of patients you're seeing, you may be dealing with a gastroenterology or oncology patient, but you can't be using in a stroke patient.
Neuro, yeah.
So exactly. So it has to be validated, and you have to choose it wisely because you need to use the same thing in your follow-up also. So the outcome should be measured on equal entity and specification. So it has to be validated. If anyone is planning to validate in a proper thing, just please go ahead, but use it on an evidence base. It should be evidence based. It cannot be an expert level for evidence.
Excellent point. Thank you, doctor. So in your setting, can you just say about the swallowing checklist, anything what you do, at least a checklist to score at a nutritional adequacy or something which you can say in an OPD or an IP setting?
Currently, we are not using any proper checklist for because we have other challenges like manpower and everything. But definitely, yes, I recommend because any checklist helps you to evaluate the patient. Then you make a target for the patient that this is the amount of nutrition in terms of calories, proteins, and other thing is required for the patient. And then that can be used at different intervals at the start, at during maybe post surgery or something, and once the patient comes for a follow-up. So it should be standardized, and as Sir said that yes, single checklist will not be able to fit all. So for whatever outcome we are looking in a patient, we have to use standardized checklist, and I would say that maybe we can develop and pass it all across the hospital so that it is standardized for all the patients.
After getting the data,
Yes.
whether it suits Indian setup. Please, please. Bam.
In NCP, we do have 2-3 checklists. Out of it, the questions can be taken. Already, we people are following NCP. So, if we see all the forms for NCP, there are forms. Although we people are not using all those NCP forms, we are just using SG and all that. But there are forms which are already being standardized. Although not for Indian scenario, yes, as Ms. Sreemathy is saying that we are going to have it, but yes, it is already there.
I think in the OPD, just do an MNA, that you know where he is, then if required, do an FGA, but make sure those patients are assessed. Even it has to be teamwork. One person missing from the team will not show results.
Okay.
And if he's geriatric or if you have to really assess socioeconomics, what are his food intake, then cultural, then plan out the diet plan. It's definitely not going to be there. If he's eating chapatis and that's a flavor he likes, then you can ask him to put it in the mix. As you said, find out the first thing, is it available to him or not? There's no point sitting on a pedestal and saying do this because he's not going to do it. Compliance will only happen if you make it as close as it to his cultural and financial background as then only you'll see results.
So in
Thank you.
2002, I think 2020, right? The NRS.
Yes, NRS
the NRS is the
2002.
best one because you have the all
But
integrated.
it's
Even the
very
gap.
time consuming.
Faster in ICU.
The patient is
NRS
already
is the
70,
best.
score one is already there. This is GI thing, Apache score just simple. It's complex get when it is like it's in the subset. So this is basically the NRS. I just giving an
Yes,
example.
yes, we do NRS too.
Have that much of staff to do an
Yeah, we do it. We do it in our
Now modified NRS has come.
Yes, yes,
How
yes.
many dietitians are here? I would request
anyone to stand up.
Shilpa to share that screening tool to everyone. Let everyone use that one. If you say it takes more than 30 seconds also, I'm going to withdraw that tool. And it is such a impactful, so simple, self-screening. Don't have to MUST if you want to do, it will take 5 to 7 minutes. You have to train the person.
Yes.
Trained person has to interestingly do. No, or else the screening we know how it will be done by the nurses.
PGF.
Dietitian cannot be affordable to keep to do the screening. They're not for the screening purpose. And if you have a tool which is stuck up at the OPD level and the patient reads and goes himself, screening himself because he don't have to spend anything. No training is required. Your work is already done within 10-15 seconds. And all your NRS 2002, your MNA, your must, every question will be addressed by that. Every
NRSA comes with a guidelines that the history first thing, patient is giving a history that weight loss is more than 5% or not, or the BMI is the one. So one thing can clarify. Your questionnaire should be simple that you can be used in OPD.
I think the first most important indicator is weight loss.
Let me
And percentage of weight loss will tell you where he is nutritionally.
Simple. It should be very simple.
It's more like a snack questionnaire.
No, Sriman, we are mixing screening and assessment with
yes.
one tool.
Yeah.
Why you want to know the percentage of weight loss in the screening part? That is an assessment part. When you are doing an assessment, I want to know how much of weight loss is there over a period of
Percentage.
3 months. Screening is something you want to know whether there is a risk or not. Malnutrition risk is existing or not. That is the answer you are looking out for. Why you want to calculate the percentage of weight loss over there? Why you want to calculate BMI? Now everyone knows BMI is not a good indicator of your nutritional condition. Then why you want to calculate how much of time your BMI calculation and all those percentage weight loss it is going to take, and whether the nurse is really going to do all those things, definitely not. In none of the institutes it will be done, neither in AIIMS, neither in TMH, it will not be done. Then how the tool it should be, that is what we said, the patient should self screen that one. Even if extra patients come to the dietitians will never get tired of seeing the patients, but ensure that none of the patient escapes that tool. That is the one thing where, after reading those 6 questions, as I said, 15-30 seconds, definitely if the answer is yes, go to the dietitian, that's enough.
What I was trying to say, that all of us are working in different setups. We are all using screening and assessment tools, but they are all different.
Exactly.
But major is
We
SGA.
don't want this thing to happen. Someone is using MLA, someone is using NRS.
SGA.
Let's, as a forum, as a community, let's decide on one screening tool and one
Assessment tool for this. Yeah.
But this will be easier across, because a patient can go
See what
to
happens-
different hospitals for taking different opinions. There's a fashion these days of
Yes,
second
yes, multiple
third-
opinion. Yes,
third
yes.
opinion. So every time a patient meets a different dietitian, the kind of screening tool or the assessment tool she will be using will be different. So patient gets confused every time. So this is for the best interest of the healthcare practitioner as well as the patient, that we should all, if
Come together and
yes,
decide upon which tool in
frame-
India should be used.
yes, one
Yes, yes.
screening tool and one
Acceptable by
Assessment.
NHS and JCI.
Yeah.
So otherwise, if you go to JCI hospital or an
Okay.
NHS,
If it
they
is
will
validated,
guidelines will.
they will
Okay,
accept
going
it.
to the
If it is
next
not
one. Yeah,
validated,
last 10 minutes, Dr. Dash is pointing out. Kaustav, your input on having one common document for communication for dysphagia. Can you please elaborate on that from the SLP point of view? Your expertise, please.
Which is extremely important, because as a team we have to know what our role is and what the other discipline's role is. We have to understand how the doctor treats the patient and where we come in. So documentation is really important in that matter. So, we have our own documentation types. Doctors have their own, and the nutritionists have their own. So it's all should be mentioned in the file, so that we also know which wherever the things are, like what I am doing, what consistency I'm recommending, what kind of food I'm recommending, and how you would take care of the other nutritional statuses.
So, can you, in my presentation, there was one where there was a physiotherapist, so there is standing with position, the texture of the diet, the NS, the SLP, and everything is there. Will that work for an Indian scenario?
Definitely, it will work now.
It will
But
work. So,
not-
is there a.
Unfortunately, not every center works the same.
No, but majority is that, can we just say there will be one communication form, so that by just looking at it, the physiotherapist will know the position because he's going to write it, and SLP is going to write the texture. The dietitian is going to say this for the next 3 days, next assessment, they're going to be in this consistency. And the consultant, anyway, is going to see this in one glance in his rounds, and he will know the adequacy, what he's currently on, and the SLP is also looked at it, and the physiotherapist. Will that work, Dr. Dash and Dr. Will that work? One common document?
We follow this in our screening. Like we have a performer.
Wow.
It starts from demography. It starts for the right current assessment and the outcome of investigation. Then what is the management plan? And there's a data for the follow-up also. And that actually we are not. It's in developmental phase. That's why we not included that time. That what kind of consistency that has to be added, everything. But I used to say in my language that whatever the food that, I mean, like if I'm just trying to give a semi-solid, whatever the diet you take, I used to say like it should not fall 3 seconds or kind of thing. So just a common language, but it has to be documented in a standardized for performer. So if you have a proper performer, integrate that one into performer, because at later at 1 year at the end of year you can review this data that I have given this thing and did come out to be the results. So integrate this thing in your management thing. What is the diet you're giving? What is the frequency? What is the consistency? And it is augmented. It's a maneuvered, non-maneuvered, and later follow up how it is responding. Some patient may respond. Some patient may come back with this thing because of starting. So it has to be in a dynamic thing, and it has to be started right from the beginning. So integrate this thing in the performer itself.
Okay.
If you're developing it, just develop it in a proper.
Sure. Thank you. Sir? For communication, interdisciplinary communication, will one document, one pro forma work where as a
Should be.
class?
Should be.
Yeah.
I fully
Okay.
agree with him. My point is, there should be 3 things which should be considered for this. One is the ease.
Okay.
We have big scores, very accurate, very elaborative. Nothing works. People go for very easy things, and with so much load of patients, very difficult to do. Second is accuracy. Has to be a range maybe of 80 to 100% should touch the accuracy.
Okay.
And it should be evidence based. Be a very light evidence or something, but it should be. These three are there. Let us go for it. And I think if I have one patient or two patient a day, I would go for the best of the scoring, best of the things, and everything best. And then depending upon my experience and sharing of the experience, and do it and practice it, like Dr. Siba said, I will try scoring. I'll say like people to try scores and see how it. I'll go by Dr. Saab's score. And if yes, if anything Indian is scoring very well and giving us result, I would. No question about that. So we should be in an open mind. ऐसा नहीं कि वो बुरे लोगों का आ गया तो उसी को ही follow. ऐसा कुछ नहीं.
To start using it, it become easy. So once it become a big column, after 1 or 2 years, it become a small box that checklist tick, tick, tick. So just
It should be a consolidated list.
It should be consolidated. You should start.
Yeah.
make it be
Otherwise,
easy.
one get mixed from the other, eliminated from the other.
Okay. So I think I'm going to wrap it up because it's 4:50, and thank you all for patient listening, and thank you delegates, and thank you so much IAPN Delhi chapter and sir, Dr.
So a few words from the Vice President.
Please, please. It was really nice. I was happy to be. Dysphagia core group this year also has done something really fruitful. Thank you so much.
Just in the morning. So it was really pleasant being over here. My flight got delayed, or else I would have been attending from the first lecture itself. And I'm glad that you still waited on a Saturday evening till this time. And it was really a good debate. The kind of discussion was going on, and as sir said, heart to heart discussion. There was no formalities like agreeing, disagreeing is a part of the process of the clinical conditions. What we understand, my perspective, her perspective, and others' perspective will be definitely different. But ultimately, there's one thing what sir did mention that गोरे लोग जो सब करते हैं सब करेक्ट ही नहीं रहते. हम लोग जो सावले लोग भी हम लोग करेक्ट कर सकते. Don't trust us. And there are many things we need to Indianize. And for the last 1 year, I'm just going everywhere and telling that all tools are available. But let us say for us, what is suitable? Sir said every maybe 5 to 10,000 patients may be visiting here.
Yes, yes, more than that. More than that, yes.
3 to 4,000 visit TMH. How many patients screening any nurse, any staff, any person is going to do? So that is what, looking at our conditions, what is required for us. Let us modify the things. Let us take the information what is available, not to deny that one. They may be good in their places, as you rightly said, it has to be validated in clinical conditions at various places and in various type of conditions, like in diabetes, in renal conditions, in cancer conditions, we have to validate. It's a ongoing process. It will take maybe 1 year at the end of things. So today, whatever we debated, it's not going to stop over here. We are going to take it much, much ahead over. And the validation process has already started, and maybe from tomorrow, maybe from Monday, so in the AIIMS also we are going to start. Let us see if the FEC permits us, maybe in the next 2-3 days, it is going to start. So we have to be open-minded. Let us be really think about what the Western countries are doing. Can we really do something better in that? They are not done anything miracles, and we are no less than competing them or maybe doing better job than them, whatever they are doing. The only thing is like we are not documenting ourselves, we are not publishing in the right way, and our data are fudged by the PIs and the co-PIs. So there the problems are lying. Let us be very honest with what work we are doing. Publish it. It may be a small study, 30-40 patients, doesn't matter. But unless until you publish it, we are not able to refer or justify ourselves. So if you want to justify, you cannot keep on saying that America mein ye hua hai, that is why this paper you show. How many more decades we are going to refer to the Europeans and American papers? Let us come out with our own data, our own tools, our own protocols, and there is nothing impossible, I would say. And yes, what we as a dietitian require the physician support. And we are lucky enough in IAPN, people are really coming out with open heart, open mind, and accepting our point of view and contributing there too. And in which other societies you have such a kind of an amalgamation where two entities coming together and working for the same cause. In every hospital we always say that doctor ek baat karte hai, dietitian ek baat karte hai. There's always a conflict going on within ourselves, even though we don't talk about it, but there's a reality everywhere, it's existing. Let us come together, join the bridges, Ultimately, everyone is going to the benefit. If the patient gets cured, who gets the credit? Who gets the credit?
Doctor, obviously.
We don't want any credit. We want respect. We want our work to be recognized. We have good knowledge. We are ready to put it across to the physicians. Physicians has to support us. Yes, if you want to do, go ahead. Let us see. Why copy everything what the Westerners are doing? And why can't we really come out with? And today, I think by this opportunity, in the last 2 minutes, what you are given, maybe these 2 minutes can inspire you all. One of you or any person would like to join us in getting the tool validated or coming out with new tools, contributing your own experiences. We are very much open. Nowhere at any time we are going to say, yeah, you don't have experience. You are very junior. Nothing of that kind of any person in IAPEN is going to talk about. We are very much open, receptive to your suggestions. Junior or senior doesn't matter. Ideas are important. Come out with the ideas. You want a platform is available. You have the knowledge, then explore this one. Don't lose this opportunity. Again, we have to just look out for what Europeans have done. When the next guideline will come, then we have to adopt that one. Let us finish that.
And IAPEN has a journal.
We have the journal. You want to do the research, you don't have to worry about it. We have the medical writers. We have the statisticians. What more you want? You just have to do a good research in your wherever you are working. Take your research permissions. Go ahead. Do small studies. Doesn't matter. You want any expertise to be involved to give you advice? We are always there. Of course, in diabetes, I'm not going to talk about. Shilpa is going to talk about. If dysphagia is there, she will talk about. So we are not overlapping each other as well. Oh, I know this also, I know that also. I'll be everywhere. No one will be everywhere. We have designated area. I'll be dancing in Onco only. Nowhere else I'll be going. So same maybe Sreemathy, she will be over there only. So we have everything expertise coming together and working. Which other societies have core groups over here? And the core groups are designated and coming out with the guidelines and Indianizing the things and looking out for what is fit for our diverse population. So what we need, we all have to come together and we need support from the physicians. That's what. Thank you so much.
Thank you.
So
Just want
thank
to
you.
Take 30 seconds, I'm sorry.
Yeah.
But I just want to say that, like Sir and Shiva said that, I would just like to add on that the first university to the world which was given was by India only. So don't feel bad, or you should be feeling proud that you are born in India. You are, educating here, and feel pride that yes, you are from India and you will definitely contribute to the world. Just don't believe in copying and pasting from the Western because it is so called Western. Your Indians feel pride in that. We were the
Yes.
first to give the university to the world.
Yes. So we can conclude. Yes. So I would like to conclude this workshop. I think the way we wanted to conduct, we have been able to reach. Am I right, sir? Dr. Das?
Yes, yes.
Yes.
Sir
So,
is sitting there. He is one of the best critics of this, and he will be able to tell. But yes, I'm very happy for the discussion you started, the way you carried out the discussion. That's how you see. We may pass out through this conference just saying yes, everybody, yes, yes, yes. To go a little bit higher stage, everybody asks you evidence,
yes.
the logicality, everything logistics. So he actually approached that thing, and I'm very happy that people knew that you will be debated everywhere.
Yes.
Thank you very much. I'm looking forward for youngsters to start up. So whatever you deal, think why you are using it, why, and when it is used or not. Is it appropriate or not? Because someone will ask you out of the world that where you validate it. Sometimes even they ask in the language also it's even valid because you're dealing with it. Village people also sometimes illiterates or like some like in South India. I'm from South India. Like I mean, after before just coming to 2014, I don't. I mean, I have not really used Hindi. So in fact, I sometimes I have grammatical mistakes also. But I can't be filling a Hindi questionnaire like sitting there.
Yes.
I'll take 2 hours or 3 hours. I'll ask someone. So try to be in your own way and just create the new things. It's always discussion is the start. Discuss with the seniors, discuss with the new people, generate ideas, commit mistakes, learn it from them. That's how it goes. All the best. Thank you, sir. Thanks for the invitation.
Thank you for the comments, and I would like to thank from a core of my heart to all the faculty for being here, for such a wonderful discussions and innovative things we've come out. We've come out with many new things, and I would like to convey thanks to all delegates who waited till long on this Saturday evening. We holded them till long. And I would like to convey thanks to the industry also, our partners for Azura and Otsuka. And thank you, Azura, for getting good panelists over here. And yes, I cannot miss Mr. Suzanne and Mr. Panna also. They have been into helping complete organizing people from AIIMS. Thank you all for being over here. And we would like to see you into ICNC 2023 in February 2nd to 5th. I have shared already into the delegates group. You can register soon onto that. And plus the details are available on the website too. And hope to see in AIIMS also in April. We are planning for a bigger event for GI and liver. Sir?
What one suggested that what was the name of that? Someone suggested. I suggested something, and I thought this is good. They said something, I forgot that one. But basically, the aim was to update our Indian knowledge on medical nutrition. So that should be our theme
For the next this time. Yes. So we'll be soon announcing that for. We'd love to have more of IPEN Delhi members also been joining in. So the people who were like non-IPEN to the delegate group, we would love to be members from Delhi chapter so that they have been updated for more new updates and the conferences and the CMEs which we are being conducted. So as Mr. Shiv Shankar and Sreemathy has updated, so IPEN has been doing wonderful things into, and you can be a part to that. So let's become the member first, the first step to be there, and then we can move ahead into the different areas where we have the preferences. Thank you, everyone. Thank you so
And
much.
may I request all of you if you can come to this side. He has planned a group photograph.
Yes.
All of us.
Camera.
आप सब सीनियर मोस्ट बैठ गए आज ही
सब कहेंगे हम जूनियर हैं हम they all cannot stand
लंबे बैठ जाएं छोटे खड़े रहें
Yes, I have.
ये आएगा मेरे आगे तो कंप्यूटर एज वाइज सीनियर को बताया
Thanks, Shweta. Photo video. Thank you.
I want to say
You will go directly to the website. There's a button over there showing that you want to click onto it. There is a Google form. Fill it, give the payment, and there you will be on your paid ID.
Email ID.